the list, we'll go through a Botox workshop with hands on the track. So, welcome to everyone. Please request our Vice Chairman of Institute of Neuroscience, Kolkata, and Head of the Department of Neurology, and my mentor, Dr. Rishikesh Kumar sir, to start the process. Sir, please.
Thank you, Jackie. We'll start very soon, but you also have to eat up time till 9:30. So first of all, welcome everybody. And this is a pediatric neurozone, East Zone and Kolkata pediatric neurozone. So first of all, thank you the organizers, Arijit and Jaslovely, for taking pains for this. I know that how difficult it is to organize a conference. And this is actually service to the fraternity, and thank you for doing that. And we are grateful that you came to INK to offer this workshop, and when you came, we took with both hands, because I personally feel that there should not be any boundary. Pediatric should know adult, adult should know pediatric. And patient comes, when they come with pediatric movement disorders, they grow up in adults and they come to us. So we should know each other, we should know each other branches. In fact, when you see the movement disorders, the most exciting cases, they are and when you see the video challenges, a lot of cases are from pediatric. And this conference, this workshop will help us be more abreast towards these conditions. So once again, thank you for coming, and we look forward for a very vibrant discussion. This conference has been divided into some talks. Some talks are very relevant. When you see that when the patient has negative view, what to do, negative gene test, what to do. So they're very relevant, you can see. And after that, between that, some case discussion, and we also have botulinum toxin workshop where we see hands-on. We'll inject in some patients. Of course, all delegates are most welcome, and special thanks to those who have come from outside, and special thanks to the faculty, Arushi, Bikram, Adrish, Savani. Savani is around? Yeah, she's there. So thank you for coming, thank you for taking pains to come here. And all the best. We will be around. Any problem, let us know. Thank you very much.
Thank you, sir, for such a nice message. So may I please welcome Dr. Bhaskar Ghosh, sir, to have some words.
Good morning, everyone, and I sincerely thank you for inviting me over here. During last movement disorder conference in I think Gujarat, so Jasodhara talked to me that, sir, I want to organize a workshop in movement disorder, and without taking a single breath, I told her that you talk to Jackie and Rishi sir. They are the best person in our region to organize such a conference, and she immediately, I think, contacted them, and it is for Rishi and Jackie we could gather over here. Now, as I always say, what we were taught during our DM days, the movement disorder has changed totally, and I always think that the movement disorder book should be rewritten. Actually, during our time there was no genetic study, so we could not reach any diagnosis. We could do this and this and this and that. But after this genetics came into vogue, nowadays all the movement disorders are getting diagnosed, and in that way, a approach to movement disorder has totally changed. Now nowadays we trying to find out whether the patient has got Parkinsonian symptoms, ataxia, dystonia, so and so and so, and now we take them into a syndromic diagnosis. Then we go for genetic study and so. So I will thank the organizer. They have kept this thing in mind, and they have kept topics on genetics, and also kept topics where genetics is not working. So these are the need of the day, and I think this workshop will help those who are learning, and also persons like me who are, we have to learn in a new way, and there is no end of learning. Just a few words about Professor Subhash Mukherjee. His son is over here. So he was the head of the department in medical college. When I think during 2005 or 6, he used to call me, and then I thought there is no end in learning, because you can learn at any age. And now he is a good Botox injector. So I think we will learn today a lot from all of you. And thanks to our external guests, Arushi and also Shayani. And lastly, I also thank Jackie for organizing such a wonderful workshop. Thank you very much.
Thank you, sir. May I please welcome Professor Vibhu Kolani Das, ma'am, our Academic Director of Institute of Neuroscience, Kolkata, to have few words.
Thank you, Jackie. Good morning to all. And I should always think that welcome to this city of joy who have come outside Kolkata, and all the faculty who have come assembled here for this pedicon, Neuropedicon, and also the Eastern Journal also. And I thank the organizers for giving this opportunity to INK to organize this workshop. And we have Dr. Kumar and Jackie here, and I think it will be a very good workshop and very learning. What Dr. Bhaskar Ghosh said, that it is always the learning process. We will also learn, and it will not be finished. Throughout our life we will learn. So this is very thankful. I am very thankful that INK, on behalf of INK, I thank all the organizers and all who have come here, the participants, to be here and enjoy the thing and learn a lot. Thank you very much. Wish you all success.
Thank you so much, ma'am. May I please ask very own consultant pediatric neurologist, Dr. Orijit Chattopadhyay sir, to have some comments.
Good morning, everyone. As the organizing chairperson of the conference, which is the West Bengal State Pedicon and the East Zone Neuropedicon, welcome all of you to this workshop. It's actually one of 4 workshops we are holding today, and this one has been organized by INK, and I'm grateful to the team here who have done a lot of hard work, especially Dr. Jackie and our own pediatric neurologist, Dr. Joshodhara. Other people, of course, have also given their time. So if you look at the program, there's been a lot of thought about who the speakers and the topics are. We wanted to make them very relevant for both pediatricians and adult neurologists who have an interest in movement disorder pediatrics. So this will be the one-day workshop, and we have another couple of days after this, which is the main conference, and for those who have registered, you are welcome. I would like to take this opportunity to invite all of you for the conference, and thank you very much for attending this workshop.
Thank you so much, sir. So now let's start with the first session. May I ask Dr. Bhaskar Ghosh sir, so please chair the first session. Sir.
Thank you, Jackie. So we are going to start our today's session. The first topic is approach to early onset ataxia. So, and I will not go to the topic because he is the best person to judge over it. And I will just introduce Dr. Adrish Mukherjee. He is a খুব ভালো ছেলে. He is a very good boy. I know him from his school days. So I have never seen such a good boy. He stood first everywhere. and he is like, what should I say, the followers of his parents, and he's very calm and quiet. So eto bhalo chele I have never seen in my life. So even what I should say, because I am proud of it, he did fellowship under Dr. Sanjay Pandey in Amrita Institute, Faridabad, and Dr. Pandey did not know that he is son of Professor Subhash Mukherjee. So when I told him, he told me that he finished work and he came back, and after that I come to know. I mean, yes, this is his character. He is a very good boy. So he is currently, we are very sorry that he has been posted in the North Bengal Medical College, because you all know that he tried to start DBS in Bengal Institute of Neurology, and probably one case he could do. But after that he went for fellowship and ultimately he landed in North Bengal Medical College. So he is currently associate professor and he has done fellowship from Amrita Institute. With this word, I hand over to
Develop the thing in North Bengal also.
Good morning everyone, and thank you Bhaskar sir for your kind words, and very good morning to the respected chairpersons, all the delegates present here today. So I was told that this workshop is mainly intended for the residents, but I see quite a few of my senior teachers present today. But the goal of this talk is still resident oriented. So I've been asked to talk on approach to early onset ataxia. So just the basics, ataxia means without order, as we all know, in rate, range, force and direction of movement. What is important to know that it involves not only the gait but also limbs and speech. The predominant form of ataxia in children is cerebral ataxia, but we should also remember sensory ataxia and vestibular ataxia. So this is the very basic of ataxia. So I will start with just the neurological signs and then I will shift to the approach. So the neurological signs of cerebral ataxia, just as I told, not only ataxia of gait but of stance also, with limb ataxia, dysarthria, and a host of oculomotor features. So if I can highlight one thing from this talk, it's you should not miss the oculomotor features. So it can be divided as disorders of pursuit, disorders of saccades, disorders of saccadic intrusions and oscillations, and nystagmus. And we will see some examples of these and how it helps in the diagnosis. For sensory ataxia, Romberg test we all know. For vestibular ataxia, symptom dizziness, tinnitus, vestibular tests, nystagmus, head impulse test. Two tests I will say. One is the Unterberger or the Fukuda stepping test, and the next is the star walking test or the Babinski-Weil test. These are for vestibular ataxia. So this is the clinical examination. But in the pediatric age group, we need some general observation also, like the height, weight, BMI, head circumference. The vital signs are important, including temperature, the demeanor and behavior, the mental state of the child, any dysmorphic features, any bulging fontanelle, head tilt, rashes and skin lesions. And the rest of the neurological screening examination should include at least a cranial nerve examination. Again, eye movements have been highlighted, including the fundus, muscle bulk, tone, power, JPS, DTRs, plantar. And next are the associated movement disorders. And I will say not only associated movement disorders, any associated sign, neurological or non-neurological in the other systems. Examination and the review of the other systems, including musculoskeletal, such as scoliosis, space cavers, like that. So this is a brief, but we have to remember that early onset ataxia is the topic. It's less than 25 years of age onset. In children above 5 years of age who have a normal cognition, it's relatively easier to test. But in younger children, sometimes it's very difficult to assess like that. So in those cases, we should rely on observation skills and history from the parents. But we should not miss to check the tone and reflexes. It can be checked in very young children also. Right. So this is the clinical examination part. Now to the approach. So we will start with the first case. 17-year-old female patient, acute onset dizziness and imbalance for 5 days. 1 episode of vomiting, no history of dysarthria, diplopia, headache, seizure, fever, rash, arthralgia, and no similar previous episode. The first video showing the gait. The second video. So she is missing the finger. And the third video, there are some eye movements. So why I am telling this? Because she was treated as a case of ataxia, vestibulopathy like that. She was given Stemetil and she was discharged from the OPD. But when we saw the patient after 2 days, these were the signs. So this is clear that this is something central in origin. So the gait is there, the dysmetria is there, and eye signs are there. And then we did the MRI, and what we got is a brainstem demyelination in this patient. So we treated with the methylprednisolone and then immunomodulators, and then she gradually recovered. Now the second case. Now this is a 3-year-old boy, uneventful birth and developmental history, presented with episodes of refractory focal seizure. That subsided. Then he developed hyperkinetic movements and imbalance. So if we see there is a choriodystonia with ataxia, and the MRI is showing basal ganglia changes, caudate and putamen. So what this child had was NM-DART encephalitis, and again he improved with treatment. Third case given by Dr. Jashodhara. This is perhaps one of the more common pediatric ataxias. Acute onset ataxia, MRI normal, preceded by fever and good recovery. So this is the classical for a post-infectious cerebral ataxia. Right. Now the 4A and 4B. One case I faced in my internship at medical college, and the other during my residency. So acute onset ataxia in a 6-year-old girl who had history of epilepsy, and acute onset ataxia in a 5-year-old boy who had family history of epilepsy. So what happened? And any resident guess? So there is a common factor in these cases. The acute onset ataxia, something happened. In one child he had epilepsy, and in the other child he had family history of epilepsy. So what happened? Okay, so this happened. So the child was prescribed phenytoin serum, and the dose was given according to eptoin, according to dilantin, eptoin. There was a confusion. The child took dilantin. So if we note the concentration of phenytoin is different in dilantin and eptoin, and this is and this was the culprit in the first case. What happened in the second case? His parent was taking phenytoin, and the boy took phenytoin while playing. So both the cases of phenytoin toxicity. This is for the residents again. The 5th case of again acute onset ataxia. What is this? Right, so this is opsoclonus. So now we know that. So ataxia, how can we classify broadly? Acute, recurrent or intermittent, and chronic. So these examples showed acute ataxias. So how do we, what are the usual causes of acute ataxia? Infectious or parainfectious cerebral ataxia, which we have discussed. Then the variants of GB syndrome. Then comes the vascular intoxications, traumatic, neoplastic, autoimmune paraneoplastic, usually subacute course, brainstem encephalitis, opsoclonus myoclonus ataxia syndrome, ADEM, demyelination, labyrinthitis, metabolic. So we have seen examples how to approach clinically, and then we can arrive at the diagnosis. Because remember, for acute ataxias, many are treatable causes, many are reversible causes, acquired causes. So you need to have a clinical approach for acute ataxias. And last is, but not the least, is functional. So now functional gait disorder is not a disease of exclusion, but we have to show positive signs for a functional gait disorder. And is a functional gait disorder seen in children? Yes, it is seen in children. So this is a brief approach to acute ataxia. So what we need to do is to pick up the red flag signs from history and physical examination, like fever, lethargy, ear pain, distress, seizures, head injury, papilledema, ciscranial palsy, any hemiparesis, any focal neurodeficit, any areflexia like that, so that we can rule out all the etiological, whatever we discussed in the previous slide. then we do MRI, we do all the relevant investigations, and then we arrive at the diagnosis of post-infectious cerebralitis. Always remember whether there was any previous episode. This may be the acute episode, but this may not be the first episode. So there are some recurrent or intermittent types of ataxias which we will discuss next. Some of the examples are given here, like episodic ataxia, migraine, and BPV. Okay. So this is the sixth case. So a 22-month-old boy, 6 self-limiting ataxic attacks over 2 months, each lasting 60 to 90 minutes. In the absence of any associated symptoms like loss of consciousness, pallor, or abnormal eye movements. So what is the diagnosis written here actually? So this is a recurrent vertigo of childhood. So now we are moving from acute ataxias to intermittent or recurrent ataxias. So this is a recurrent vertigo of childhood. Now, if you want to differentiate from vestibular migraine and recurrent vertigo, it's very similar, but the absence of migraine-like features helps to differentiate. Now, any resident want to give the answer to this? So this patient has a conglomeration of features, and all the points which we have discussed in examination is useful in this patient. So a 12-year-old girl, asymptomatic till age of 18 months, mild febrile illness with lethargy, followed by progressive ataxia, dysarthria, and dystonia. Fever subsided within a week, and the deficits recovered gradually. But she had 2 further episodes of the same deficits, and the last time it is gradually progressive. And what is shown in the pictures here? Huh? Okay, so I will give you a hint. This is optic atrophy. So there are no pigmentary changes. This is optic atrophy. And anything in the bottom one? So you just recall the points we discussed. Na? Musculoskeletal system, pes cavus is there. So again I am saying neurological, non-neurological, every system is important. So just look at the video. This is published by Sanjay Pandey sir. We discussed about this case a lot. Now, any takers for the diagnosis? Residents? All right. So it is Kapos syndrome. It's cerebral ataxia, reflexia, pes cavus. So you just look at the acronym, you expand it. There is ataxia, reflexia, pes cavus, optic atrophy, and hearing loss. It's due to ATP1A3 mutation. This ATP1A3 is a very naughty gene. It causes a lot of things. So one of it is Kapos syndrome. Can anyone tell what are the 1 or 2 things, diseases caused by ATP1A3 other than Kapos? Okay, next time. Now, why I asked about this? What is happening here? What is happening in this? So he came with the complaints of difficulty in walking. So is this ataxia? Is this functional? What is this? Okay, so first thing you note that it is occurring predominantly on the left side. With the jugs there is some posturing going on, and I have given a hint it is precipitated by movement, not just standing. Right. So this is the paroxysmal dyskinesia kinesogenic. Okay. Now is there a relation of paroxysmal dyskinesia and ATP1A3? So when we see a hemi-distribution, we think of ATP1A3 in paroxysmal dyskinesia. Age may be variable. Okay. That is why I asked about that. Okay. So this is what we call an ataxia mimic. This is not a true ataxia. All right. So what are the causes of intermittent or recurrent ataxia? Again, benign paroxysmal vertigo, migraine with brainstem aura, then all the genetic episodic ataxias, then the metabolic conditions we discuss later on, epilepsy, and then the group of intermittent exacerbations. One is Kapos, the other is Consias. This is a very interesting disease where there is exacerbation induced by physical or emotional stress or fever. Okay. So just like Kaposi fever can exacerbate it. And the last one is BT-BGD, or the biotin thiamine responsive basal ganglia disease. It again has that, like that, fever-related encephalopathy, ataxia, all the movement disorders. Then it may get relieved. Then again there is an exacerbation like that. So this is one group we should remember. So one is truly episodic and one is exacerbations. So in the genetic cause of episodic ataxia, we just highlight there are a lot of genes being discovered now. The important thing is that for type 1, the attacks are brief, seconds to minutes. For type 2, it's prolonged minutes to hours. But the important thing is that if you look at it, most are channelopathies. Okay. So now we are, as Bhaskar has said, in the diagnosis, as we move more and more towards genetics, but still we can find some telltale signs in the MRI in some of the disorders which we have discussed. So in the acute stage of maple syrup disease, we find these hyperintensities in the cerebellum and the brainstem. Now the right is very characteristic of again BT-BGD. So if you find a child like that clinical presentation, and if you get an MRI like that, you think, why I am just telling it again and again, because these are treatable disorders. You must identify treatable disorders. Okay. Now the next series. 15-year-old boy born out of non-conceived parentage with normal birth and developmental history, ataxia for 1.5 years, jerky movements for 1 year. Okay. Again for the residents, anyone, because this is a workshop. I think this should be interactive. This is anyone. Where are the residents now? This is the best answer I got. Okay, so again so when we see movement disorders, we have to identify the phenomenology, then we have to identify the conglomeration of neurological non-neurological signs, then we have to arrive at a syndrome. This is the basic approach of movement disorders, right? So we see that there is ataxia and there is myoclonus. Keep it simple. I am not going to the type of myoclonus. There is myoclonus, there is ataxia. Now there is this. Now what is your diagnosis? What is this? Cherry red spot. So your first diagnosis will be? See, it's written there, the diagnosis. Sialidosis. So why is this important? So in this article, it was very beautifully, they tried to make an algorithm of the myoclonus ataxia syndromes. So now we are going to the associated features. So myoclonus ataxia syndromes. You see the first classifier is epilepsy with frequent seizures, cognitive impairment. I just keep this, and then it's epilepsy with infrequent seizures, and then there is no epilepsy. This is the first classifier. Now it's very important to note the second classifiers. See, it's giving clinical clues. If there is cherry red spot, you think of sialidosis. If you are getting occipital seizures, you think of Lafora. If you are getting dysmorphic features and so on and so forth, you just look at the features. So clinical signs are important. Of course, you will argue that at the end of the day I will send genetics, but still it is important. Because you need to have the syndrome, otherwise you will either end up with a negative or a VUS, and you will take help of Dr. Vikram. So that will be the end point. So peripheral neuropathy, muscle weakness, atrophy, behavioral disorders. What is this syndrome? Do you think? The last one. What is this conglomeration of features we call as optic atrophy, stroke-like episode? Everything is given there. So we think a mitochondrial disorder if we get such a combination of features, right? So this is important. And I will just introduce one thing here. If you look closely in the next slide, again dystonia, Parkinsonism, NCL, spastic paraparesis. What is written there? ATX/HSP. I don't have a marker. HSP. So this is the first point I want to hit, is HSP. So the SPG group can have ataxia as a presentation. Okay, number one, good. Then you just come down. You will get another important thing: reduced upward gaze. Reduced upward gaze. Then you think of, so again oculomotor signs. Then you come further down, scoliosis, musculoskeletal. So you see everything is important when you are looking at these patients. And I will introduce another term. If you look at ATX/STUB1, that is autosomal recessive spinocerebellar ataxia. So we know the autosomal dominant spinocerebellar ataxias.
These are the autosomal recessive or the SCAR group, SCAR. And it's very interesting to know it's STUB1. Now STUB1 also causes SCA48. That is autosomal dominant. So the same gene can cause autosomal recessive, can cause autosomal dominant. Just the nomenclature is different, nothing else. Okay. And at the bottom one, no epilepsy. Very important classifier is opsoclonus and presence of telangiectasias. Okay. So this is how we approach the combination of ataxia with myoclonus. Now, what about this patient? Okay. So what does this patient have? So there is ataxia. In addition to ataxia, so in the right side you will see there are eye movement abnormalities. He is asked to follow the pen, he cannot, and on command he cannot do suckers. There is some head movement along with it. With ataxia there is dystonia in this patient. Just look at the face, look at the limbs. See, he is moving his head. Okay. So, now we will go to associated oculomotor features with ataxia. So, saccaded dysmetria, oculomotor apraxia. So, when we see these head thrusts, we think of oculomotor apraxia. Then jerky tracking of the smooth pursuit, nystagmus, opsoclonus, square wave jerks, ophthalmoparesis, and very importantly vertical gaze palsy. So, these are the things we should note. Now this paper came out and they have classified the recessive ataxias according to the eye findings. This is I found this very interesting. So if there is ophthalmoplegia, they go for the Paul G group, and also SPG7. Again SPG group is coming in ataxia, right? Then if there is oculomotor apraxia, you see ataxia with oculomotor apraxia group, ataxia telangiectasia, all these are coming. And if there is vertical gaze palsy, Niemann-Pick type C. So you get a young patient, ataxia, psychiatric symptoms, behavioral symptoms, vertical gaze palsy, you think of Niemann-Pick type C, okay? Okay. Now, this child initially had imbalance and then developed this posturing. Can you have any idea about the possible diagnosis in this case? Why I am telling possible diagnosis? Because we could not send the genetics in this child. But if we get such ataxia, dystonia, and this feature, something is there. What about the dentition? Is there any hypodontia? Something is there. So in this group, we think of the polar 3 group of leukodystrophies in such patients. Okay. Now this is 12A, 12B. So 12A is showing telangiectasia. What is 12B showing? So there is some dystonia, there may be some tremor. There is some wasting also. So there is some chorea also. There is choriodystonia, there is wasting. So what do you think is the diagnosis in this case? This is a genetically proven patient. So this is the patient ataxia telangiectasia. So when ataxia, why I showed this patient? So when ataxia telangiectasia progresses, these movement disorders dominate the picture gradually, chorea, dystonia, and so on and so forth. So if you get a patient like that, take the previous history and you will arrive at the diagnosis. So this is the genetically proven case of ataxia telangiectasia. Now having choriodystonia and all these things. Okay. Fine. So this paper reviewed so now ataxia with dystonia. So they reviewed ataxia and dystonia, and this is the entire list of so many genes where dystonia is comorbid with ataxia. So it's a very huge list again. Interestingly, in our study at BIN, we followed a lot of patients of ataxia, and it was also a tertiary referral center for Wilson disease. We found Wilson disease patients having ataxia with dystonia. So in our country, do not forget Wilson disease when you get a patient of ataxia and dystonia. Okay, good. Right. So what is this gate? And the diagnosis? HSP. So which type of HSP possibility? So there is something called the ear of the lynx sign. So if you look at the MRI, this MRI shows the ear of the lynx sign. So these are the ears of the lynx. This one, this hyperintensity. So this is classically seen in SPG 11 and SPG 15. This patient had SPG 11. SPG 7 is usually associated with ataxia, but SPG 11 can also have ataxia. But predominant is spasticity in this patient. So now the associated clinical features. All these things we note: hyperreflexia, areflexia, both are important. Fred's ataxia we know. Classical picture, areflexia. Spasticity, scar. We have discussed what is scar. We have discussed what is SPG. And also I think you know RSAX or SSES. Okay. Then what I will highlight in this chart is that the last point is diabetes mellitus in Fred's ataxia. So do not forget systemic features also. Right. So we look for the reflexes, we look for the spasticity, tone, fasciculations, myoclonus, rigidity, chorea, dystonia, sensory symptoms, optic atrophy. We have already shown the case of Kapo's for optic atrophy. Good. So how can we clinically classify the autosomal recessive ataxias? So this article classified as a pure cerebral ataxia, cerebral syndrome with intellectual disability or developmental delay, cerebral syndrome with motor neuron involvement, cerebral syndrome with polyneuropathy, metabolic or mitochondrial syndrome, which we have discussed, all those features of mitochondrial syndrome, and cerebral syndrome with extrapyramidal involvement or oculomotor apraxia. So if we can clinically classify like that, we can have an idea as to the possible diagnosis or the possible group of diagnosis. So just 5 minutes. Structural malformation, spinocerebellar ataxia, I have again highlighted AD and AR, both types, which we already discussed. The last point I have kept is ataxic cerebral palsy. This child presented with ataxia and dystonia.
And open it. Make a fist and open it.
Can you guess the diagnosis?
Fast. How about real fast? How fast can you go?
The diagnosis is
Fast you can do?
SCA3. So SCA3 presented at this age.
Can you do this?
And not only that, Dr. Saini has published a case of SCA2 with onset at toddlerhood. So a host of scars can present at a very young age. So do not forget the AD category. So usually they have a strong family history, but the presentation may be at a very early age. Okay. And the last case, tuberculous meningitis. There was gait impairment. She was doing well, then again an acute deterioration of the gait. Okay. So what happened in this patient? So this patient developed an infarct. So there was a chronic process going on. Now she developed an infarct and there was an acute deterioration in this patient. Okay. So to summarize the approach, first we have to exclude the ataxia mimics, which one I have shown, the paroxysmal dyskinesia. Second, the acquired ataxia, which I have again shown, tuberculous meningitis. Then for the early onset ataxias, we need to look at the clinical features. INS is the inventor of non-ataxic symptoms, which we have also discussed. Again, eye movements have been highlighted. Then MRI. Now, why it is important? Because look, they have written consider repeat disorders. So if we blindly send it for whole exome sequencing, you will get a big 0. So you have to identify the phenotype, you have to identify the syndrome, and you have to send the genetics accordingly. Okay. And the last 3 slides. Spotter. Epilepsy, cataract, ataxia. CTX. So these cerebrotenous xanthomatosis. So again, general observation important. Cataract, good. What is this nystagmus? So this is a very interesting patient. She developed eclampsia. She had a very serious course, and on recovery she had ataxia and downbeat nystagmus. Okay. And this is only for the residents. What is this? So we are talking about ataxia, we are talking about the role of cerebellum. So if we say that there are some, we now think that cerebellum may be involved in this syndrome also. What is this syndrome called? This is the Unna-Tent syndrome. So we published this case of Unna-Tent syndrome recently, where we found the cerebellar atrophy and also there was a choroid plexus papilloma with it. So I acknowledge my mentors, Joshodhara and all the residents. Thank you so much.
Thank you very much, Adrish, for your very lucid and lecture in a workshop with plenty of questions and clues. And I invite a few questions from the audience, although time is very short, or comments. Rishi, want to make some comment?
He gave a wonderful overview of ataxia. And approach was important, which he showed. So I think that, and these are the things. There are 4 or 5 important articles. What he showed, dystonia, ataxia plus madness, ataxia plus dystonia. Everybody should read about that, and maybe he can share the slides, PDF of slide, and that way approach can be wonderful.
Okay, Arijit, I want to make some comment? No. So anyone? And had it been 25 years old lecture, it would have started with Friedreich's ataxia. Now he mentioned Friedreich's ataxia during the last 5 minutes of his talk. So that is the difference. You have to learn every time that how the things are changing with the advent of new MRI techniques and also genetics. Now if you don't have any more questions, we can proceed to the next topic, that is approach to early onset dystonia. So that is also changing a lot. We used to think of Wilson disease every time we used to get such a patient, and nowadays probably the movement disorder specialist will rebuke us. They don't you know how a Wilson present, because there are hosts of diagnosis. And to talk on this interesting subject, we have Dr. Jackie Ganguly, who is actually one of my very good students during his MD days. I had a chance to teach him for 3 years, and I know his worth. So. And he also respects me every time he gets a chance, and I have a lot of love and affection for him. And he is actually did DM from Medical College Kolkata, and also he did fellowship under Professor Mundar Jog, I think, from Western University and Canada, and he is attached to INK, and I think after his joining, Rishi has got a very good hand to extend his services to the community and also in the academics. So without wasting much time, I hand over to Dr. Jackie Ganguly.
Thank you so much, sir. I still remember those days of Biashing while we were doing our DM neurology. We went to go there and learn from Dr. Bhaskar Ghosh, sir. And thank you, sir, for being my mentor all the time. Come in. Slides. Thank you. So proceeding from ataxia to dystonia. So now the talk will mainly for the early onset dystonia, but I have tried to keep it mainly in the genetic dystonia. So starting from the classification, our axis classification, as we know, axis 1 and axis 2. Axis 1, we have that age of onset, body distribution, temporal pattern, and associated features. For the early onset, generally we will like to keep infancy, childhood, adolescent below 20, but there are many overlaps with that early adulthood onset between 20 to 40. So we have tried to keep it in that block from infancy to early adulthood. And in the etiology, we would like to focus mainly on the genetic part with autosomal dominant, recessive, X-linked, and mitochondrial ones. So we would like to give an overall approach clinically and some mainly clues, those we can get while facing our patients in our clinic, and some radiological clues to reach a diagnosis. today we'll not talk about all those acquired causes and focus on genetics. So in grossly, if we approach genetic dystonic syndrome, we will have autosomal dominant ones where we have that classic DYTs, along with some NBI like neuroferritinopathy, some juvenile onset Huntington that can present with Westphal variant of more dystonia, and SCA3. In the autosomal recessive ones, we have mainly all types of storage disorders starting from copper, from Wilson, or most of the NBIAs, GM2 gangliosidosis, Niemann-Pick, all those glutaric aciduria, methylmalonic acidureas. In the X-linked, we have Lubac, DYT3, Lesnihan, Moore-Tranberg, and in mitochondria, last but not the least, with Ley, Bellas, Lon, and Polgy. So important here is how it progresses, how it starts and how it progresses. So the rule of the thumb is generally if in a young dystonia it starts with a focal, mainly in the lower limb onset, and then gradually progressive. On the opposite thing we see in more of adult onset dystonia where it starts with focal and generally remains focal. But there is a catch. In the early onset you can have both the progression, either caudorostral progression like starting from the lower limb and gradually becoming segmental or generalized, what we see in our classic TOD1A, DYT or KMT2B. And on the other side we will have rostrocaudal progression where it starts with the craniocervical bulbar involvement with TAP1 and ATP1A3. So this should be your entry point to approach while you are seeing a case of early onset dystonia. See these two cases of TOR1, this is actually first case of TOR1 where responded very nicely with globus pallidus DBS, very bad dystonia almost like hemiballistic jerks we are seeing pre-GPI DBS. And more or less he is doing much better after GPI DBS. So that's how important it is to know what the genetic background is, because not all the dystonias respond to DBS. On the other hand, contrast that with TAP1, this is Dr. Dibbani's case, with childhood onset generalized dystonia gradually progressive, but see predominantly it involved the craniocervical region. The onset was predominantly craniocervical, became segmental, involving the upper limb, and some foot dystonia also we are seeing. Coming to KMT2B, this is actually relatively new kid in the block, but everywhere when you are reading this thing and more cases we are getting in that KMT2B club with this early onset dystonia, it can mimic just like DYT1 and it can also mimic like TAP because both rostrocaudal and caudorostral progression you can see there. So this was a study by Dr. Bikram et al. From Niemann's where very bad generalized dystonia was there and responded very good with the GPI DBS. You can see that iron deposition in the globus pallidus. So we will discuss many cases where you will see beyond NBIA, you will see in SWI there will be iron deposition in the GPI. So don't get biased with NBIA all the time. So clue here is one, as we discussed with focal onset generalized becoming progressive, and this facial dysmorphism with tip of the bulbous nose. But that may not be common in our Indian patients or in the Asian descent KMT2B. This is mainly for the European descent KMT2B where you will see those long faces and the bulbous nose. Now there is a KMT2 mimic. Everywhere when we are progressing with the genetics, we are getting a lot of mimics. You will think this is DYT1, you will find no, this is KMT2B. You will think is that KMT2B, you will find no, this is not KMT2B. So this is Hobbs complex, mainly lysosomal pathway, VPS 16 and 41, exactly same presentation. So lot of craniocervical involvement and then gradually becoming segmental.
Quindi stando appoggiato riesci a stare in piedi.
And then progressive with truncal involvement. But see, again iron deposition is there in GPI. So it can mimic exactly like KMT2B, but KMT2B can come negative. So think of VPS 16 and 41. So this has been from MDS gene review where we are seeing TOD1 with mainly limb onset in the TAP1, craniocervical, genal again craniocervical. ANO3 we'll discuss it in brief in a few seconds, where it can have craniocervical along with a lot of tremor, it can mimic essential tremor. PRKRA is mainly limb onset dystonia along with Parkinsonism. So DYT16 is PRKRA where you will find dystonia Parkinsonism and KMT2B as we discussed. So moving on to combined dystonia, the clues are first dystonia with Parkinsonism. Primary genetic dystonia with Parkinsonism will have in one side the DYT5 spectrum, you will have ATP1A3, PRKRA and Lubac. And some secondary dystonia is a part of other movement disorder where both can be there, dystonia and Parkinsonism, like Wilson, your juvenile genetic PD like Parkin, PINK1, DJ1, all the NBI groups, Westphal variant as we were discussing, and SPG11, some HSP again as Dr. Adrish was mentioning, SPG11 is everywhere between, it can come with ataxia, spasticity and also in dystonia. How to approach this DRD spectrum? This is the new classification of DRD spectrum where you will have classic DRD on one side with GTP cyclohydrolase, tyrosine hydroxylase, sapiapterin reductase with classic diurnal fluctuation, no significant motor fluctuations with dopaminergic drug. They respond very nice. And on the other hand, you will also find some DRD plus phenotypes where apart from DRD you will have something else like some ptosis, some episodic drowsiness, hyperthermia. Transportopathy, we will put it here in, can present with more of DRD and more of DRD plus with dopamine transporter or VMAT2. And there are some DRD lookalikes where you may get some response with dopaminergic medications like in our juvenile Parkinson, but with very early onset dyskinesia. Big list of pallidopyramidal syndrome we will see, and SCA3, myoclonus dystonia will put it here, and ataxia telangiectasia. Why ataxia telangiectasia is here? Dr. Adrish was discussing this because it may mimic DRD lookalike. So ataxia telangiectasia can present to you with dystonic tremor of the neck, and that can respond to levodopa. So these are all classic DRD and DRD plus phenotypes where what the syndromes we discussed. And another new kid in the block is this developmental disorder affecting dopamine system, that is SOX6 mutation. This SOX6 mutation clue is lot of bony abnormalities like craniosynostosis, osteochondroma, but that can also mimic like DRD. And on the other hand, well, we will see in this DRD look-alike, all those Parkinsonism is young onset Parkinson disease where they are pallidopyramidal we are discussing, and it can have varied presentation from different subgroups like in the plateau G6 from NBI, BX07, ATP1, 13A2, all can come there. And ataxia telangiectasia we already discussed, and myoclonus dystonia also. Moving on to Lubac. Lubac actually presentation is not that early. It is a bit kind of 30 to 40 year onset, but as we discussed, there are a lot of overlaps and it can present around 20 or below 20. Clue and very common in Philippines. And this craniocervical, again this very much craniocervical predominant Lubac is the clue. In the MRI findings you are seeing caudate atrophy and you are seeing this hyperintensity in the striatum. So you can feel that okay, this is chorea acanthocytosis, exactly like this you can find. Juvenile Huntington you can think of in this MRI picture, but those may be negative, it is just Lubac. And this is that knee buckling gait, that is one of the features of Lubac. It may not be always present, but remind this can be also functional also, so don't get biased. PRKRA, another one we were discussing with generalized dystonia with lot of truncal involvement, and another dystonia that can improve very nicely with GPI DBS. So see the pre and post DBS, significant response. There is another case published of PRKRA from my friend Dr. Shubhodit, and hyperintensity C in that striatum again, and exacerbation was there with some fever. And the siblings you can see both having dystonia. So these are the new things you have to keep in your mind while approaching the dystonia, not only those classics DYT1 or DYT6. Moving on to NBA, this was one of our patients presenting with status dystonicus, and GPI DBS we had to do as a life-saving measure. You can see eye of tiger sign. Praying mantis sign, we often discuss this because of the jaw opening dystonia. They always try to keep this as a sensory trick and looks like praying mantis. Praying mantis sign is not specific for PCAN, it can be seen in any NBIAs. And this was one of our case from Medical College Kolkata, exactly like dystonia with your praying mantis sign was there, tiger of eye sign was there, along with atypical retinitis pigmentosa was there, and acanthocytosis you can see. This is Herb syndrome, that is genetically mimic of PCAN. Moving on to plateau G6. Plateau G6 we often discuss with young onset Parkinson's disease with very early telltale dyskinesia. We always say when patient of young Parkinson with are present with dyskinesia in low dose, we always think of Parkin or plateau G6, but it can present with isolated dystonia also. This is one of our cases. And so you can see that cervical dystonia and the writer's cramp also. So this was plateau G6. MPAN, mainly mitochondrial, Dr. Odrich was discussing a lot of mitochondrial ataxia, and with C19 or 12 mutation, you can see optic atrophy, you can see those wasting, and it comes in that block of pallidopyramidal syndrome, so you can get some response with levodopa. The clue for MPAN, this is a case by my friend Dr. Dibani, and you are seeing the spastic gait with some Parkinsonian features, marked faces, and some dystonia with split palladium sign and comb sign, these radiating hypointensities from the substantia nigra. These are clues for your MPAN. Woodhouse-Sakati syndrome, another NBIA. This is mainly we classify it as type 1 or severe, or type 2 as mild forms, and where you can have this intellectual disability dystonia, and along with clue is sensory neural hearing loss. So this is the facial features with lot of alopecia, because endocrine abnormalities are the clue. This is from my friend Dr. Mitesh. So alopecia is there, dystonia is there. Difficulty in writing, and this is her brother, again same presentation. So alopecia with endocrine abnormalities, think of Woodhouse-Sakati. And here you are seeing that iron deposition along with pituitary hypoplasia. So that's the clue with DCAP17 mutation. So that's the block. When you will see dystonia with deafness, what are the clues you will think? You will think of Mott-Trenberg or team 8A. You will think of Woodhouse-Sakati. You will think of Waardenburg with white forelock, beta-actin, methyl malonic aciduria, Megdale or Serac mutation, and mitochondrial definitely. Coming to VAC14, VAC14 again nucleid in the block, and we are seeing some cases of VAC14 recently with lot of truncal dystonia, both with retro and antero, and see in the VAC14 you are seeing iron deposition in the globus pallidus and some hyperintensity in the striatum. Now this was the girl who initially diagnosed as functional, from this case was by Dr. Shubodit, and then this lot of back arching, will think of drug induced. But remember one thing, whenever the patient present with list of back arching, don't forget NBIA. First cause if it is drug induced, second cause this is NBIA, third cause it can be steep person. So this is from my friend Dr. Chayoni, and this is same truncal involvement, lot of truncal involvement, along with striatal hyperintensity. So normally you don't find that of striatal hyperintensity in NBIA. So NBIA with striatal hyperintensity with truncal involvement, that's the clue for your VAC14. Some deposition disorder, mainly with the manganese, SLC 3810 and 3914. This was from our paper published with our mentor in Canada, Dr. Manda Jog. With dystonia is there, and you are seeing this T1 hyperintensities. You may not get that classic cock walk what you see in the miners or proper copper who are environmentally exposed. These are genetic dystonias. SLCA 3810, main point to remember is you will have polycythemia and cirrhosis, those organic features, systemic features. In SLC 39A14 you may not have those cirrhosis. Another storage disorder is our lysosomal storage disorder. Our patient came in very bad shape with significant dystonia, with lot of coarse facial features, with significant craniocervical involvement, marked generalized dystonia, and the clue was this wishbone sign, what we see in SWI, and in the T2 hyperintensity in the posterior putamen. So T2 hyperintensity in the posterior putamen you may get in our movement disorder world in multiple system atrophy, Parkinsonian type, MSAP, and in this type 3 GM1 gangliosidosis. Now Niemann-Pick, as we all know, vertical saccade initiation failure will be there. So a lot of generally we see it in adult, but it can sometimes present in young, as Dr. Adish was mentioning. Dystonia presentation can be there along with ataxia and chorea, and you are seeing in the top one of our patient with lot of facial grimacing. So whenever there is facial grimacing or lower facial dystonia, don't forget Niemann-Pick. And seeing C blue histiocyte from one of our patients whom we went for bone marrow biopsy. So some are reversible, like ataxia, like in dystonia also, like in AVED. So the clue is dystonic tremor. So AVED can present with only dystonic tremor. So in a young age, if you are seeing dystonic tremor with minimal ataxia, don't forget to send vitamin E, because that's reversible causes, otherwise you will miss it. Biotin thiamine responsive basal ganglia disease, again my previous speaker has discussed. This is the imaging clue here with dystonia. So lot of subcortical hyperintensities you are seeing along with deep gray matter involvement and lactate peak. So these reversible causes, don't forget, of vitamin E, vitamin and this biotin thiamine responsive basal ganglia disease. Welcome Dr. Bikram. Some organic acidureas or classic glutaric aciduria and L2 hydroxyglutaric aciduria. You are seeing this macrocephaly of glutaric aciduria along with open sylvier fissure or batwing sign. On the other side, you are seeing that centripetal hyperintensity of L2 hydroxyglutaric aciduria, again presenting with writer's cramp with dystonia. There may be very subtle ataxia. So dystonia, ataxia. Moving to SERAC1 with that classic pontine eye sign, where you are seeing that hyperintensity along with sparing of the posterior part of the pons. This group, it's Lay-like syndrome with dystonia deafness. So again, deafness is the clue for Mechdel or SERAC1. And definitely you will not forget Lay, all the genetic causes of the Lay syndrome, and lot of overlaps are there with, it can present with isolated dystonia, isolated pyramidal or some kyphoscoliosis along with that striatal hyperintensities. Some atypical ones like purine metabolism, this case presented to us with, this is Lesnian syndrome with lot of biting and one part of the lip is gone actually, poor kid, and significant dystonia, little bit better. Now we are injecting Botox mainly for the arm dystonia and leg dystonia, and this handcuff sign discussed by Professor Bhatia, because of this lot of biting or self harm, you may find this case of handcuffs. Now moving on to dystonia myoclonus, main approach is when you are seeing a case of dystonia myoclonus, so the myoclonus is more than dystonia or dystonia more than myoclonus. So in our classic DYT11 or sarcoglycanopathy, you will have myoclonus more than dystonia. On the other hand, you will find those ANO3, POLG, KCTD17, you will have dystonia more than myoclonus. So see these two cases. First one, this is by two of my mentors, Professor Mandar Jog and Dr. Rishikesh Kumar. So this was sarcoglycan with DYT11, you are seeing a lot of myoclonus more than dystonia. And here see, this is one of our patients with ANO3, lot of dystonia, dystonic neck tremor. Dystonia is evident while writing at this myoclonus. So that's the way you have to approach. And interestingly, I would like to share with this ANO3 guy, we tracked this when he said there is a strong family history. We tracked him. We went from Kolkata to Porbandar, a distal part of the village, and we find this. All the patients in their family have different phenotypes of ANO3. We had now 16 cases of all the same ANO3 in the same family with dystonia myoclonus presentation, chorea presentations with intrafamilial variability. And thank you, Rishikesh sir, for giving me that opportunity to go there and examine them. Now, last few cases we'll discuss. One is your ataxia telangiectasia spectrum. Remember, it may not come with ataxia, may not come with telangiectasia. This was one of our patients with just typical some retrocolic neck jerks, and you can see that, and little bit of coriform movement or little bit of myoclonus, mini polymyoclonus, whatever you say, but it was ATM. So don't forget to send our serum alpha fetoprotein. In this spectrum, Silver-Russell syndrome will also come with typical triangular faces with maternal uriparietal disomy. You are seeing those triangular faces classic in the Silver-Russell along with this myoclonus. So in detailed approach we will not go. This is a nice paper by Professor Bhatia, residents one can go. This was one of our cases we published in AOMD, where hypomyelinating leukodystrophy with movement disorder with Pelizaeus-Merzbacher-like disease, dental malocclusion, as Dr. Adish was mentioning, with pollard 3A, broad-based gaze with little bit of foot dystonia in HBSL or DARS1. So in PMLD we are seeing this hypomyelination, thin corpus callosum and cerebellar atrophy, and in HBSL we are seeing the pontine involvement and the spinal cord involvement. Phagocytosis in this group of the white matter lesions, where the clue here is angiokeratoma and bullet-shaped vertebra, with these coarse faces, thick lips, angiokeratoma. When you don't miss it, you can get fucosidosis. Type 4, you can also put it in this hypomyelinating leukodystrophy spectrum with cerebellar atrophy, but it can have different types of presentations. This is one of Professor Bhatia's patients. It's typical craniocervical involvement, and this was one of our patients. We will see this whispering dysphonia, so listen carefully. So this is classic whispering dysphonia of the type 4. These are all we club in tubulopathy, and this is the paper we recently published with Dr. Bikram, Dr. Dibani. So these are all type 4, the clue. So laryngeal dystonia, significant in isolated dystonia syndrome, you can get in DYT6, THAP1 and GNL, and in complex dystonia you can get it in type 4 and KMT2B. So whenever you are getting predominant laryngeal dystonia, don't forget THAP1, GNL, type 4 and KMT2B, and KMT2B mimic, that's VPS 16 and 41. Moving from tubulopathy to interferonopathy. So Aicardi-Gutierrez will the classic interferonopathy. We will see calcification in your CT brain and those chilblain lesions. And this is interesting. This patient actually got admitted yesterday with seizure, but she is from Agarwal. And see, a lot of dystonia you are seeing. So history of seizure I already mentioned. And not all Agarwals are SCAR12. Here in Kolkata, Agarwal with essential tremor, this is SCAR12. But not all of them have, because this is predominant dystonic syndrome rather than a tremor syndrome. And you are seeing this megalencephalic leukoencephalopathy with subcortical cysts. Now we have total around 7-8 cases. And moving on to some chromosomal abnormalities, we are almost in the last part of our presentations. So Klinefelter syndrome, it can present with dystonic tremor. So you are seeing this. This is one of our patient, our mutual patient from me and Dr. Bikram. So this guy presented to us with dystonia, dystonic tremor. Initially we missed this diagnosis because sequencing was not that helpful initially. But then we examined carefully, we found gynecomastia, and we went for karyotyping, and this was 47XXY. This was Klinefelter syndrome presenting with dystonia. Another chromosomal deletion syndrome is your 18p deletion syndrome that can present with dystonia. The clue is very puffy faces because of these thyroid problems. And this was our recent case with 16p11.2 microdeletion syndrome. Clue was this kid was diagnosed as cerebral palsy, but when we examined, there was a lot of dystonia and autistic spectrum disorder. So 16p11.2 microdeletion syndrome can present like this. So these are chromosomal abnormalities. So not only just go for SCAR panel, or don't only just go for whole exome sequencing. Think of these on also. You may get it as chromosomal microarray. That can be your investigation of choice. Just 5 minutes, sir, I will ask. Moving on to paroxysmal dyskinesia. So paroxysmal dystonia dyskinesia overlap, I would like to say, with PKD, PNKD and PED. The main thing is we will not go through the chart. If that PRR2 comes negative in PKD while you are suspecting, don't lose hope. It can be all different causes. They can all present with paroxysmal dystonia where PRR2 can be negative. In PNKD, again, if you are not getting that MR1, don't lose your hope. It can be a lot of other disorders what can present with PNKD, and definitely paroxysmal exercise induced where this GLUT1 and pyruvate dehydrogenase complex you are seeing. So some very classic clues in paroxysmal dystonia. Here you are seeing this inverted swan neck sign. Look carefully for the left hand posturing. You are seeing this inverted swan neck sign described in ATP 183. This is dystonic cataplexy. So in cataplexy, you generally don't want dystonia. But see this, very excited kid, got something from Amazon. So up to this is cataplexy. But now you will see. So that's the dystonic posturing in cataplexy. When you are getting this, think of KCNMA1. SLC28-2, definitely we should not miss, and we should do a brain imaging in PKD because of this, our classic farts. And two imaging clues I will give you, one with PNKD with striatal involvement. So PNKD kid, see that dystonia. but with striatal involvement. Generally, you don't expect in PNKD with striatal. If you get it, most likely this you are dealing with phosphodiesterase 10A. So this is again a big group of disorders of phosphodiesterase where 10A can present with PNKD. And similarly, if you are getting a kid of PED with your globus pallidus hyperintensity, think of pyruvate dehydrogenase complex. So these are the two kids. We are seeing a lot of dystonia, and this one a bit adolescent with again PED. So we discussed PNKD with striatal involvement, think of phosphodiesterase 10A, and PED with globus pallidus involvement, think of pyruvate dehydrogenase complex. So last two slides, one is your nocturnal dystonic dyskinesia. It's in ADCY5, GNA1 or GNB. So a lot of awakening related bouts of severe opistotonic posturing in GNA1. And this you are seeing truncal hypotonia. So whenever you are seeing truncal hypotonia, ADCY5 comes in your mind, and those nocturnal episodes, all these nocturnal things club it in this, mostly in these three categories. So with this, I will end my presentation. I thank my mentor and my team of INK. Thank you.
Thank you, Jackie, for your nice talk. And I personally feel that among the movement disorders, chorea is most interesting, but dystonia is something which is like more of a mathematics like, and it has got particularly those are chronic cases, they have got good genetic correlation. So that is more like a mathematics and very interesting. So if you pick up the proper clue, I think you could, and also by MRI you can get some clue, and later on you have to order the genetic test, and if it matches, you are very glad that you could diagnose the thing. Now I invite some comments or questions from the audience, please. Jasodhara, কিছু বলবে? No, কিছু বলবে না.
In Aicardi-Gouttiere syndrome, are there any particular skin changes?
Yeah, chilblain lesions we got. We generally don't see much of Aicardi-Gouttiere. One or two cases we have seen.
Yes, I have got one case.
Okay.
So, patient presented to skin specialist first.
Yeah.
So, and then came to us, and dystonia, loss of milestone, and CP-like picture, regression of milestone, plus delayed. So, it was labeled as cerebral palsy by few physicians, and genetic testing proved it. And we did a skin biopsy also, and skin biopsy also showed there is some degeneration, and in retina also there is some degenerative changes. But we could not find the classical calcification.
Okay. So
in your case, there was calcification.
I would like to ask you a very silly question. How long it takes to get a proper diagnosis in Kolkata if you get a patient for the first time presenting with dystonia?
Yeah. So, sir, I would say if it is very classic, it's matching with all our known phenotypes, we directly go for clinical exome sequencing. If in that perspective, most problems are happens, people send the wrong genetics. Suppose as we are discussing in ataxia, people are randomly sending whole exome sequencing, and that's the problem happening. Many of the repeat disorders we are getting, those can have dystonia. I have two SCA3 patients, no ataxia at all, only dystonia. So they send whole exome sequencing and it can come negative, and lot of genetic labs are popping up like a mushroom and don't know what they are doing. But if you are doing properly, I think within 1 month we can get a diagnosis.
Are there any genetic panel, the dystonia panel, like encephalopathy panel?
Yeah.
Or muscle disease panel?
Yeah, we are trying to collaborate with Medgenome and Newberg both. So we have already done this Parkinsonian panel, and so the thing is we have done this as whole exome sequencing with MLPA, because once you don't do MLPA, you can miss a lot of these copy number variations. Similarly, we are trying to do an ataxia panel or dystonia panel. In Canada, when I was there, you have panel for everything. Many a time the problem happens, sir, because how to make a panel, because there are a lot of other genes who are not in the panel, but they can present like this. Like our Klinefelter syndrome patient. To be humble, I missed the diagnosis. We could not get it. Everything was normal.
The tall stature.
Yeah, so when we opened the shirt and checked for specifically gynecomastia was there, he never said that I have gynecomastia.
For our students, I would ask you that what sort of genetic test you will advise?
Yeah, so actually,
Instead
sir,
of
we
whole
have,
exam sequencing,
yeah.
what are the things you have to see to properly advise the genetic test?
Yeah. So actually, we have our sub workshop in the post lunch session that will
Yes,
be
yes,
to.
I think, welcome Dr. Bikram Mullah, I see him.
So he is the best person who will talk on this,
Yeah,
exactly this topic. So overall, just a brief thing is, as we discussed, like if you are thinking of repeat disorders, go for SCA panel. But the problem is a lot of new ataxias are coming. Like now your FGF14 or SCA27B, lot of common cause of late onset ataxia, or RFC1 canvas, common cause of late onset ataxia. But we are sending SCA panel, it is coming negative. So because we need long read expansion. Here we are not doing the long read expansion. So that's the main thing we have to remember. So interpret that genetic report, and we will all learn from Dr. Udaya and Dr. Bikram in the post-lunch session how to approach this.
So this is, I really feel a topic to great discussion, because we all know that we have to send genetic testing, but actually what you have to send? Yes, sir.
In childhood hemangioma, we treat it with propranolol. Can it be used in ataxia telangiectasia?
Yes.
Actually, I don't use propranolol in ataxia telangiectasia. The thing important for the dystonic tremor of ataxia telangiectasia can be levodopa responsive. So 3-4 cases.
Will you go through some in internet, or like, is there any evidence that they are treating of propranolol?
Okay, sir. I will come back to you. I will go through
You
it.
You will see.
We use propranolol right and left in all
Hemangioma.
So it will reduce the heart rate, it will reduce the growth of hemangioma. But in ataxia there is almost a different disease.
Yeah, exactly.
There is degeneration.
Yeah.
Due to the genetic mutation, there is degeneration of the cells, as well as your degeneration of the blood vessels and some telangiectatic
actually, sir, when we published,
this is different. There is no role of propranolol in ataxia telangiectasia.
yeah, we published this case of dystonic tremor without ataxia, without telangiectasia, and in there we highlighted why telangiectasia happens in ataxia telangiectasia. We searched the literature, we went through it, we found there is, because of the ATM gene, there is hyperactivity of vascular endothelial growth factor. So VEGF is getting hyperactivated, and that's why telangiectasia is happening.
So, Vikram, want to say something?
I mean, a very nice presentation, Jackie. I missed the initial part, but I mean, it's very interesting. Neurology is like, for instance, as you told, sir, mathematics. I mean, if you get a good phenotype and dystonia, it is always sort of follows the, up to a certain extent, the flow chart. And it will be very sort of, feels good when we know what is the diagnosis, especially because in many of these disorders, there is very long-standing diagnostic, delay will be there. And many of them nowadays can be up to a certain extent treatable. Very few are curable, or can be halted there. But we can give a clarity to the patient and the caregivers that what exactly it is and what is the future holds for them, and how best we can assist them in have a good quality of life. I think this one especially is very interesting in the sense that that's what, with the phenotype itself, we can up to a certain extent come to a provisional, nearly accurate diagnosis.
I think within coming few years, we will be also be more wiser, and we will easily diagnose this condition. So thank you, Dr. Jackie, for your nice talk. Now, our last talk in this session is approach to genetic overlap of epilepsy and movement disorder. So this is another very interesting talk, and because sometimes we could not make out what is what. And to talk on this topic is none other than Dr. Sayani Rai Chaudhary, who is Assistant Professor and at Lady Hardinge Medical College and Kalavati Children's Hospital, New Delhi. And she has got special interest in movement disorders. So without wasting any more time, I hand over to Dr. Sayan.
এটা बहुत छोटा छोटा क्या স্ক্রিন সব ছোট হয়ে গেছে রেজোলিউশন ম্যাচ করবে না তুমি ও ও ও ওকে ওয়েট মিনিট এত ছোট হয়ে কার্সারই দেখা যাচ্ছে না কার্সারটা কি করে দেখবো আমি জানি এটা ভিডিও প্লে করতে না এটা আমার স্লাইড ভিডিও এখান থেকে এরকম করে প্লে হয়ে যাবে তাই তো
ভিডিওটা প্লে করে একটু এগোবেন এগিয়ে প্লে করলে হয়ে যাবে
হ্যাঁ
আগে প্লে করবেন তারপরে এগোবেন
আচ্ছা ঠিক আছে ওকে Okay. So a very good morning to all, and I would really like to thank East Zone Neuropedicon and West Bengal Neuropedicon for inviting me to this workshop. And I really congratulate the Neuropedicon team that I think that is the first time they are doing this pediatric movement disorder workshop. Not even in, I think, in AOCN, which is the Association of Child Neurology. Till now, we didn't have a pediatric movement disorder workshop. Last time, Dr. Suhasini and me organized one in Delhi, which was a masterclass in pediatric movement disorders. But it's really very heartening to see that we are also approaching, which is a very niche area in this topic, because for us, many of us, maybe pediatric neurology is also a growing field, and within that, epilepsy is forming a major branch of it, but we are glad to see that movement disorders is becoming also an important topic. So now my topic is the approach to the genetic overlap of the epilepsy and the pediatric movement disorder overlap syndromes. So the learning objectives from this would be that I will give you a brief overview of the genetic landscape of the epilepsy and movement disorder overlap syndrome. So we will be talking about syndromes which have both epilepsy and movement disorder in common. The neurobiological basis, because we are going to talk in the next 30 minutes a lot about genes, the pathways, because that will guide us and give us a clue. And if we try to find out if there is a specific correlation between the pattern of the movement disorders with the underlying biological mechanism, and we know that sometimes we face a lot of challenges in differentiating movement disorders and epilepsy for the clinicians, and lastly, we try to formulate an approach. So now what is this disorder? So we do see a lot of common syndromes where we have both genetic epilepsy and movement disorder. So commonly we refer to this as the genetic epilepsy and dyskinesia spectrum. So to start with, it began with the PRR2T mutations, which calls the paroxysmal kinesogenic dyskinesias, and this syndrome also were found to cause the self-limited familial benign epilepsies in the children. And that was the first time, so it was a synaptopathy, the PRR2 mutations. Then soon there were more genes like the ion channel genes in the CACNA1, the KCNA1, the KCNMA1, and disorders like the GLUT1 syndromes. So those also are found to cause that. They also cause a paroxysmal movement disorder and an epilepsy. So most of these epilepsies were well controlled to treat. So this was the initial focus of interest. But over the years, we have seen that there are epilepsy syndromes which are more devastating, which is called the developmental and or epileptic encephalopathies. And in this group of disorders, we are gradually recognizing that movement disorders also, apart from developmental delay, intellectual disability, maybe autistic traits, vision, hearing, so movement disorders are also present in a very chronic and persistent form. And really they are paroxysmal in nature in this genetic DEEs. So we will be mainly focusing on this two, because this two have the association with epilepsy. And then also in children, infants and children, we do see a lot of metabolic disorders, the inborn errors of metabolism, the neurotransmitter disorders. So they can have also coexist in both epilepsy and movement disorders. And it is very intriguing to see that, these are two different areas, like the seizures occur because of the involvement of the cortex, because of the hyperexcitability, the imbalance between the excitability and the inhibition. However, the movement disorders is more of a balance between the cholinergic, dopaminergic pathways, and that occurs at the subcortical levels. So it is very intriguing to see that the same genetic variant is causing both, like there is disruption of the multiple cellular processes in multiple neurons in both the cortical as well as in the subcortical networks. So without knowing, so we have to little know about this neurobiology, otherwise understanding this very heterogeneous and phenotypically variable group of disorders is difficult. So what we would see that, so the exact etiology is unknown, that why the same gene causes. Mostly it is at the cellular dysfunction level. So we see that there is a particular mutation, genetic mutation, and the protein structure get altered. So the protein which is getting altered, it is not only present in one part of the central nervous system, but in multiple areas of the central nervous system. And that alteration of the protein leads to a very broad level cellular dysfunction in multiple neurons, both, as I said, in the cortex and in the subcortical areas. And that's why we see such a complex neurological picture, which is causing both epilepsy and atypical motor control, resulting in the movement disorders. So if we can see that this is basically the diagram of a synapse. So this is the presynaptic neuron, this is the postsynaptic membrane. So in the presynaptic neuron, we can see that there are many biological mechanisms and cellular pathways which are happening. There are transporters which transport the chemicals. Then there is a nucleus, endoplasmic reticulum, the Golgi apparatus, which is related with the transcription regulation and dysregulation. Then we have the protein degradation pathways. Then there are mechanisms involving the autophagy. We have the ion channels, the sodium, potassium, calcium. We have the synaptic vesicle pathway. And these are all in the presynaptic neurons. Then in the postsynaptic membranes, we see the different types of receptors, the GABA, the glutamate receptors. Then you have the sodium potassium ATPases. And if you see that if there is any genetic mutation which causes disruption of any of these biological mechanisms, can lead to such a overlap syndrome, which has both epilepsy and movement disorder. So if there is some defect in the transporters, like the SLC1A2, which is the glutamate transporter, then you have anything disrupted in this transcription regulation and the post-translational modifications like the MECP2, the BRAT1 genes can cause this. Then ubiquitin mediated is mainly the UBE3A, which is the gene causing the Angelman syndrome. And now we are recognizing a lot of disorders which are involving this aberrant autophagy, like the WDR45, which is the BPAN gene. Then we have a genes which are regulating the synaptic vesicle pathway, like the STXBP1, TBC1D24, PRRT2 mutations, a lot of the ion channel genes starting from SCN1A, 2A, 8A, potassium channels, CACNA, and these are all in the presynaptic neuron. And in the postsynaptic membrane, what we can see is that there is the green 2B, which is the NMDR regulated, in the GRIA4, the AMPA receptor, and also the sodium potassium ATPases. So whenever there is alteration of any of this gene leading to disruption of any of this intracellular function or biological mechanism, then that can lead to this genetic epilepsy dyskinesia spectrum disorder. So now but there is no as such classification how you can classify these disorders, but what I have attempted that you can classify these disorders definitely by these biological mechanisms. So in the paroxysmal disorders, we already know that these are the group of genes which are associated with the paroxysmal movement disorders, like the synaptopathies in the PRRT2, PNKD genes, the channelopathies, the transportopathies, and the sodium potassium ATPases. And in the genetic DE, so we as pediatric neurologists or pediatricians see a a lot of developmental and epileptic encephalopathies, which is way apart from the previous two colleagues who were from the adult neurology who are seeing. So we see, so more we see more of genetic disease associated with movement disorders, and similarly the same pathway can be affected, like a transcription dysregulation in the MECP2, which is a Rett syndrome. We know we get a lot of extrapyramidal features, the synaptopathy, the STXBP1, the channelopathies, the G protein complex transduction, which has already been seen, the GNR1, and many receptors. So, and most commonly in children, what we see is a hyperkinetic movement disorder, mostly a chorea dystonia phenotype. Now, just I would go briefly overview through this, both the genetic disease and the paroxysmal movement disorders which are associated with epilepsy. So like previously we had seen the cases of ataxia, dystonia, but when we are approaching children, we see a lot of, so not only ataxia or chorea, so we see a lot of other paroxysmal movement disorders like a paroxysmal tonic-up gaze, benign paroxysmal torticollis of infancy. Then we can have this hemiplegic attacks, and in particularly in the childhood we see the classic PKDs, PNKDs, and the PEDs, the paroxysmal exercise induced dyskinesia. And as we have already seen that, you know, this three main group of disorders are causing this overlap with the paroxysmal movement disorders. And so this first two are the synaptopathies. This is the transportopathy, and this is the channelopathy. So this has both. So this red is representation of basically the subcortical pathway, and blue is the representation of the cortical pathway. So there is a mixture of both this in this overlap syndromes, and we see that in the channelopathy genes there is a lot of the cortex is more getting involved as compared to the subcortical ones. And when you progress from channelopathy to the transportopathy and the synaptopathy, that is more of a subcortical networks which are getting affected. So now this is a child who is a 2-year-old boy who had presented with that in 6 months age, the father would say that he would have this coarse tremors of the right upper limb. Sometimes if it would last long, then it would involve the perioral area, and it would involve the tongue. And this were the episodes. So as you can see that there is some fine jerky tremors of this right upper limb, so or a myoclonus. So here he would have this lingual tremors, the perioral movements, perioral tremors were also there. So this was the initial presentation. Along with this, the child would also have episodes where he would have the right focal clonic seizures. And initially we were confused from the history whether this is a seizure or what he did, because when we saw the videos were more like tremors. But then one day suddenly he landed up with a status epilepticus, and it was a focal status epilepticus. So that time we the first time convinced, no, there are some episodes, because the father would say that it would start with the right hand, it will involve the oral, and if the episodes are prolonged, sometimes it would last for hours, and if the episodes are prolonged, then there will be some seizures also in those episodes. And when we examined the child, we found that there was a lot of cerebellar ataxia. He would have an intention tremor, and there was a very episodic worsening with any febrile illness, with excessive physical activity. The child would have worsening of this ataxia, the child would have worsening of these tremors, and it would even last for days, like 15-20 days. He was admitted with one febrile illness, and this movement disorders, which were initially paroxysmal in nature, actually became continual. So in this you can see that he is having this intention tremor, and he also had in one time, he also had this focal dystonia where his right upper limb was dystonic, and he would have dystonic tremors too. And the triggers were particularly physical activity and febrile illness. So initially we were suspected that it could be a GLUT1 disorder. So initially we did a CSF, it was normal. Then we suspected maybe it's a channelopathy, some CACNA1, some potassium channels. But eventually it turned out to be a TBC1D24 related disorder. So in this disorder, so if you're suspecting a child who is very episodic, very paroxysmal movement nature, so apart from GLUT1, this is the other group of disorders which can present with such a paroxysmal movement disorders. Though it was a variant of uncertain significance, but still the phenotypic, this was damaging by the in silico prediction models, and that this was a phenotypic match. So now these are all the most common genetic causes which come with both paroxysmal movement disorders and epilepsy. And we do see that in some of these groups, the epilepsy will be very self-limited, some focal seizures, some generalized seizures, but in some like CACNA1A, there can be, a developmental and epileptic encephalopathy presenting with the Lennox-Gastaut syndrome, presenting with the West syndrome, or sometimes in the TBC1D. So TBC1D24 now has been classified as a developmental and epileptic encephalopathy gene. So where we can have again the West syndrome, the epilepsy of infancy with migratory focal seizures. And we see that in most of these genetic mutations, the most common movement disorders what we are getting is the dystonia and chorea and ataxia. And in all this group of disorders, so they can be of paroxysmal nature, starting from the episodic ataxia to PKD, PNKD, benign paroxysmal. So this CACNA1A mutation has also been associated with this benign paroxysmal torticollis and also the PRRT2 mutations. So ATP1A3 has already been covered in the previous two talks, where patient can present with this rapid dystonia, onset Parkinsonism, and the alternating hemiplegia. So what we get in children are mostly the episodes of, they will have this alternating hemiplegia, some hemidystonia, then you think of a ATP1A3 gene. Now, this were the disorders which were more paroxysmal in nature, but now there is a lot of growing interest and focus in the genetic DEs which are having movement disorders in common. So this was a recent paper which was published in 2023 in the Neurology journal article by Dr. Sheffer et al. And they tried to, although it was not exclusive pediatrics, but they included children also, and the 77 patient cohort, they found that stereotypy was the most common. Stereotypy and dystonia was the more common movement disorders, occurring in 48 and 44%. And then this was followed by chorea. And if you see, in children and infants, we do realize that we often see a mixed phenomenology. It is not isolated ataxia or isolated dystonia. What we get is a combination of dystonia, chorea mainly, and sometimes even myoclonus. And in this, so the neurobiology was important because in this paper also what they tried to do was that they tried to correlate the biological mechanism. So they tried to find out that whether they can, classify the genetic groups, and whether they can predict that if there is any particular pattern of movement disorder occurring with the various genetic variants. So what they found that stereotypy was more common. So as you can see, this purple ones are the stereotypy. So stereotypy is more common in the transcription regulation, like the MECP2. So the ones which are associated with most autism spectrum disorders, like the CDKL5, the MECP2, the MEF2C. So those have more common stereotypies in common. And then dystonia was more predominant in the channelopathies, like the sodium, this SCN1A, SCN2A, SCN8A, and the synaptopathy genes, like the STXBP1, the DNM1, the TBC1D24. All those were more associated with dystonia. So now I will show you few cases and the various movement disorders which can coexist with epilepsy. So this was a 2-year-old boy who had a global developmental delay. So he attained language and cognitive milestones much later than the motor. He had autistic, he was a typically an autistic child with very minimal speech. And he started having seizures since 6 months of age. Initially the seizures were focal clonic. They were triggered by fever, then there was febrile seizures. Eventually at around 1 year of age, he started throwing epileptic spasms like a West syndrome. And then currently at 2 years of age, he has now evolved in like a LGS phenotype. And the movement disorder, what he would have was as a part of the autistic spectrum. So he would have this complex motor stereotypies that he would just tap the table every time. And so these are the basically, so if you try to classify, so the stereotypy, so the genetic variants which present with both stereotypy and epilepsy are the transcription regulation. So whenever there is a transcription dysregulation, so that can present with stereotypy, also the post-translational modification, the synaptopathy, the NMDA signaling pathways, the channelopathies can, and this child was eventually proven to be a ARA-GEF9 mutation. So it was a hemizygous X-linked pathogenic variant, and this genetic variant usually alters the neuronal signaling and the connectivity pathway, similar to the PCDH19, which is also a common cause. So this was a child with ARA-GEF9. So now coming to another case, this was a 3.5 years old boy who presented with this early onset polymorphic seizures starting from 2 months of age. So initially he would have episodes of these focal tonic seizures, then he started having epileptic spasms at around 8 months of age. Then at 2 years of age, twice he was admitted with us at 2 and 2.5 years of age, where he would have just this episodes of ophthalmic posturing. He would just posture for 15 to 20 days, and that was a febrile illness triggered. And we even initially could not make out it could be a generalized tonic seizure or dystonia. We did a ictal EEG. The EEG was normal. Apart from that, the child also had this global developmental delay, dysmorphism, spastic quadriparesis. There was optic atrophy. So this were some of the seizure videos. So in the night, he would have these epileptic spasms. Followed by some oromotor automatisms. There will be a tongue protrusion, and eventually the child would go into sleep. And currently he is having this focal tonic seizures in the morning on awakening, where he would have typically this right upper limb extension and left upper limb flexion. And finally, after a period of the child was well, then the mother complained that he would have these recurrent episodes. So from the history, we couldn't understand whether it was a dystonia or it was a tonic seizure. Just the mother would say that the child would cry for hours, and he would have the tonic stiffening of the upper limbs. So this would last, this would be very episodic, but there was no postictal state. He would just cry, and there will be upper limb. But if you look the lower limb, he had a persistent foot dystonia, and this would be episodic, but this would occur maybe 40 to 50 episodes per night. So that was a recent complaint where the child had come to us. We did a ictal EEG also. We got a ictal correlate. This was actually all tonic seizures. So eventually. So this was not the ictal record, but they showed posterior head region discharges. There was cerebral atrophy, and eventually on genetics he was found to be a SCN2A, which was a likely pathogenic variant. And so the learning points, but whenever you have a child, so this is a classical presentation of a child with early infantile developmental and epileptic encephalopathy starting from 2 months of age. And sometimes differentiating these movement disorders and seizures are really a challenging task when you have such a overlap syndrome. And when you have a EIDEE with movement disorder, which was initially paroxysmal in the case, it was initially some episodes of ophthalmic posturing, nothing much. Then he continued to have this lower foot dystonia. So think of a channelopathy gene. So this was a 11. So now coming to dystonia and epilepsy. So there was a 11 months old boy who had global developmental delay. So he has achieved no milestones. There was not even neck control. Some social smile was there. So he also had, from day 7 of life, he started having seizures, which was focal cloning. Then he developed at 5 months of age epileptic spasm. So he would have these episodes where he would have this dystonia of the bilateral upper limbs, intermittently lower limbs also. He didn't have a vision. He had optic atrophy. There was hearing impairment. And eventually he turned out to be this WOX gene mutation, which is basically a SCAR12 autosomal recessive variant, which is presenting with a dystonia. So if you see dystonia and epilepsy, if you're finding a child who is having both dystonia and epilepsy, so you can think of these disorders most commonly as channelopathy, then as synaptopathy, and also G protein related coupled transduction pathways, of sodium potassium ATPases. And these are the two like GNAW1 and ARX. So these are the two genetic variants which can present with a very severe form of dystonia, like a status dystonicus. So this was a 6 months old boy who had presented with a global developmental delay. He had some neonatal onset seizures, some focal eyelid clonic jerks, and then he would have these episodes in sleep. So he would have these episodes of oculogyric crisis in sleep. There was dystonia also on examination. Otherwise, there was no no diurnal fluctuations, and the child was found to be extremely hypotonic on examination. So whenever we see a child, we suspect maybe a neurotransmitter disorder, most likely a tyrosine hydroxylase or a DRD variant. But this child was found to have a GNB5, the same the G protein coupled transduction pathway disorder, and it was found to be pathogenic. So oculogyric crisis has also been seen coexisting with epilepsy. Apart from neurometabolic cases, like mostly we see neurotransmitter disorders, as I said, but this G protein induction pathways can also be a cause of this oculogyric crisis. So this was a 2-year-old boy who, now coming to the chorea and epilepsy, so this was a 2-year-old boy who had presented with GDD. The child had an infantile onset, some focal seizures, but these were very infrequent, not like a DEE, some well-controlled focal seizures. And then he has this, so now from around 6-7 months of age, he had started having these intermittent episodes where he has this dystonic movements with some oral chorea also. And the EEG was, so when the child presented to us, the seizures were already passive. So we got a EEG which just showed some cerebral dysfunction, but there was no, not like DEE. And eventually he turned out to be a CACNA1E mutation. It was VUS, but the parental segregation we did, it was negative. So chorea and epilepsy can also coexist in this all disorders, like the whenever there is a CAM signaling pathway defect in this GNAO, GNB1, the CACNA1E1s, the PRRT2 mutations, the UBA5 related disorders, the post-transcriptional can also have this. Now coming to this case, this is a girl who is a 6.5-year-old girl who initially at 4.5 years of age presented with some focal tonic seizures. So it was initially well controlled. She was well. She started on levetiracetam. She was fine. 1.5 years later, she started developing this drug refractory focal epilepsy. Like she was on 6 anti-seizure medications, but she didn't have any control of the seizures. And apart from that, the child had very mild autistic traits. There was some speech delay. And 6 months down the line, when she developed a drug refractory epilepsy, so initially there was no movement disorder. So this parents came to us saying that, she would have this paroxysmal episodes where she would have this food dystonia for 2 weeks. Then she would have these episodes of tongue thrusting for 2 weeks. And gradually 3 to 4 months down the line, she evolved into this continual hyperkinetic movement like a generalized chorea, and there was a lot of facial movement involving the tongue, the face, the upper and the lower face. And the mother would give a very interesting history that so the mother was fond of giving surprises to this child, and whenever she would receive a surprise, that same day she would have us immediately, within half an hour she would have a seizure, and she would have a very marked exacerbation of this movement disorder. So initially we thought that there is a genetic epilepsy dyskinesia spectrums, and the EEG was full of electrographic seizures. We could not achieve seizure freedom, not even 50% reduction. So eventually she turned out to be a GNB1 mutation, again the CAM signaling pathway disorder. And so the learning points was that initially this child presented with a very well controlled, like a mild autistic child who is presenting with a very well controlled epilepsy, controlled with one drug. But eventually in the line of 2 years, she landed in APA, such a devastating etiology. So we have to be very cautious in counseling. And when you see a marked exacerbation with triggers like sensory stimulus, emotional stimuli particularly, think of this CAM signaling pathway disorders or the postsynaptic movement disorders. Now coming to ataxia and epilepsy, so this was a child who is 5 years old. She's also a GDD, autism, ID, and she has this infantile onset. At 8 months of age, she started having febrile seizures, which were GTCS, then some afebrile seizures. The child has some dysmorphism. She had also had autistic traits and had ataxia on examination. So this is a very common case scenario for a pediatric neurologist. We suspect of a SCN2A or a SCN8A mutation. So this genetics has been seen, but the report is awaited. So query, we are suspecting a channelopathy, but as we know that in today's era of genomic evolution, we don't know that predicting a genotype from a phenotype is really difficult. And in this disorders like channelopathy and synaptopathy, ataxia and epilepsy can coexist. And now coming to the myoclonus and epilepsy. So this was a 16-year-old girl who had actually presented to us around 12 years of age. So she had this around later 1 year. So the parents actually did not remember when the movement disorder started. So we assume that maybe in the late infantile or the early childhood days, she started having these episodes of chorea, dystonia. And when actually she got admitted with us, so she had a worsening of the baseline movement disorder. And she presented to us with this myoclonus, like myoclonus of the fingers she had presented to us with predominantly, like causing a finger extension and a finger flexion. And she also had history of this adolescent, like at 10 years of age she started having these seizures which were GTCS, some myoclonic head drops, but when she presented to us the seizures were actually passive. She was well controlled and she was classically a Rett syndrome like a phenotype, very autistic, no speech, nothing. She had just achieved a standing, but after the onset of the seizures she had epilepsy and a regression, and the MRI which was done that showed that there is, surprising to see that there is a cerebellar hypoplasia, more on the left side, asymmetric cerebellar hypoplasia, and this child was found to be a case of a CASC mutation, which is one of the genes which causes severe pontocerebellar hypoplasia. And so this child also had chorea and dystonia as well, but eventually she got admitted with a febrile illness, the dystonia worsened, and she actually expired because of an aspiration secondary to severe ophistogenic posturing. So now coming to myoclonus and epilepsy, so this can also be seen in this channelopathy gene, synaptopathy, the STXBP1. Like I showed, the child with TBC1D24 can have a lot of myoclonus, although myoclonus in this movement, in this group of disorders are relatively rare, and this is also in this post-translational modification pathways like the UBA5. And tremor, so this case has already been discussed previously. So tremor, neonatal onset tremor, early onset tremor, always think of STXBP1 and SCN8A. So these are the most, apart from the channelopathy genes which classify neonatal onset STXBP1 and SCN8A, but when you are presenting in the early childhood, so think more of a channelopathy disorders like also the CACNA1A, the KCNMA1 also comes into place. So Parkinsonism, like hypokinetic, very rare in pediatric as well, and more in this overlap syndromes, they are very rare. But yes, neurotransmitter disorders like tyrosine hydroxylase, epiaptame reductase, all those things can present with a hypokinetic syndrome. ATP1A3 sometimes can present. Synaptopathy genes can also present. So hypokinetic are very commonly, overall the hypokinetic movement disorders are rare in pediatrics, and in this overlap syndrome they are even more rare. Early childhood onset, the Vox child which I had shown who had WWX mutation, he had dystonia, but it has been described that this children can have neonatal onset Parkinsonism features, and the late childhood onset, like most commonly seen the Rett syndrome phenotypes, the MECP2, the FOXG1, CDKL5. In these disorders, we see a lot of hypokinetic features. So, but however, in children and infants, I had said in these overlap syndromes, we often get a mixed bag. It is not isolated dystonia or isolated chorea. And sometimes we do realize that, differentiating these movement disorders and epilepsy are a challenging task, particularly when the GNO1 girl presented with this dyskinetic exacerbations, which was sometimes really difficult to differentiate from the motor seizures. From the history at least, you have to get a ictal video recording, and on this smartphones nowadays help a lot. And in synaptopathy genes also, sometimes myoclonic seizures versus other hyperkinetic movement disorders. And in all the children who has this autistic spectrum disorder, sometimes motor stereotypies we can sometimes even confuse with the focal motor seizures. Now formulating an approach for this overlap syndromes, so first you have to try to, so when you get such overlap syndrome, first we have to try basically classifying both the group, like the epilepsy, what is the seizure semiology, what is the epilepsy type, it is a focal, generalized, unknown epilepsy, like you cannot classify it, or you have to classify the epilepsy syndrome. So in ILE 2022 has given a very nice classification where they have standardized it. So it's a self-limited epilepsy versus a DE you have to classify. Then you also look at the movement disorder phenomenology, like it's a hypokinetic, paroxysmal, continual, what are the triggers, try to identify the triggers. Then the main clue becomes the additional systemic features, like what comorbidities the child is having, developmental delay, hearing abnormalities, autism, some family history positive, any dysmorphism. Then as in any other neurological case, what we would do is that we investigate with the MRI. We definitely look at the EEG. We have to find out whether it's a developed epileptic encephalopathy versus a self-limited kind of an epilepsy. Then if we are suspecting a neurotransmitter disorders or something, we can do a metabolic workup. Otherwise, in this overlap syndrome, so we usually go ahead with the whole exome sequencing. And if the family history is positive, then we can also do a trio analysis. So this was the last slide to approach, and the take-home messages would be that movement disorders and epilepsy really do coexist, and for that we have to dig deeper into the neurobiology of these disorders. Not only drugged, so we are in these disorders, we are too overwhelmed with the drug-resistant nature of the epilepsy. We try to ignore the movement disorder component, but they can also too severely impact the quality of life of the infants and children, and you have to have a clinical awareness of these overlap syndromes, so that is very important for a focused diagnostic approach.
Thank you, Dr. Sayani, for your very lucid talk, and I think you have made it clear that how to approach when you got a movement disorder as well as epilepsy combination. So, first of all, I will invite some questions or comments from the audience. Yes, Yasudhara.
Just recently I saw a child with a PRR2 mutation, but that came late. The child, initially 5-month-old child who presented with a febrile seizure. So it happens, nothing was given first obviously, then the child started having febrile seizures. Then levetiracetam was added, then the child started having daily seizures on adequate dosage of levetiracetam. So valproate was added, the seizures stopped. But meanwhile genetics was sent because others were negative. So PRR2 mutation came without any movement disorders were there, but the child was having a twin who started having some head nodding movement.
Oh.
So this child is having infantile onset epilepsy, which was happening daily, but after adding valproate, the seizures have vanished. But PRR2 mutation is sensitive to carbamazepine, so it it is very sensitive, as they say. So do you think it will be wise to give, the child has responded, the seizures have responded, the daily seizures. So do you think at this point it will be advisable to change valproate to carbamazepine?
So the child doesn't have a movement disorder.
That child is not having, but the twin is having.
But I think seizures are controlled. You can wait.
Seizures are controlled, but this child may have, because the parents are very educated, as we know, they have studied everything, and they are saying whether the movements will come up. And for the other child who perhaps is having the mutation, the movements have come up like a head nodding movement. So in that child, do you think it is advisable to...
That child you should try.
Because there are no seizures, nothing, just a head nodding movement. So I am not sure whether...
So it's a pathogenic mutation?
It's a pathogenic mutation.
Okay.
Both the twins are having that. But one is having epilepsy and another is having just a head nodding movement.
Sometimes the movement disorders phenotype can evolve later. So they, in the late infancy, they may try to start developing this choreoathetosis. May not be initially seen in the early infantile period. So I think for the seizure child, if it is controlled with valproate, I think you can wait.
Yeah. So the thing is that with subtle movements with that, do we give carbamazepine?
No.
Often
So
in children it becomes very difficult to start a medicine.
Any other question or comments? So from the today's morning sessions, one thing we have learned in common, that is whenever you get a patient of movement disorder, you have to try to find out what the phenomenology of the movement disorder, whether it is a dystonia, chorea, myoclonus, so and so. Then you have to try to find out the other neurological features apart from movement disorder. Then you have to add that, and then you have to find out from the general examination additional features, like whether the patient has got telangiectasia or like that. So 1, 2, 3. Then number 4 is that you have to do certain investigations. So like you have to do for Wilson disease profile or some blood test, other blood tests which are needed. Then you have to go for MRI. You have to try to find out certain unique features for these movement disorders or proper diagnosis. Then you make a syndromic diagnosis, and then you order some genetic tests. So those genetic tests, what we have to order, and if we order something, if it comes negative, what we have to do, that will come later on today's talk. But in this way, I think every speaker, Dr. Rodrish, Dr. Jackie, and Dr. Sayani, they have tried to emphasize that, and they have shown the videos, several videos, I think, to impress. So it is I would say it is a very successful, wonderful workshop, and it has made us quite a lot knowledgeable. So I once again thank all the three speakers for their nice lectures, and I have a big hand for them. And I hand over to the organizers for concluding.
Now I may request Bhaskar sir, the chairperson of these sessions, to give away the mementos to the speakers. Dr. Adrish Mukherjee. Dr. Adrish, you need to take another one. Now Dr. Jackie Ganguly. Dr. Shani Rachel. Now may I please request Dr. Rishikesh Kumar sir to give away the chairperson's memento to Bhaskar sir. The special for the chairpersons. Thank you all. Now our second session will start. May I request please Dr. Jackie Ganguly to carry forward.
Thank you, Sujishmita. So moving on, now we will have 4 case presentations. So we will total have around 7-8 case presentation. We have divided it in 2 sessions. Both will be, some will be very easy cases and some will be a bit tough, and we will cater the taste of both pediatric and the adult neurologist. So for the case presentation, the first case, I would like to ask Dr. Anushree to come up on the stage. Yeah. So for all the presenters, we, because of the lack of time, be very brief and just tell in briefly what you want to present, what's the unique about that case.
Good morning everyone. I am Dr. Anushree Pal. I am resident of neurology in Institute of Neurosciences, Kolkata. Today I will be presenting 3 cases of movement disorder which are interconnected by a surprising entity which I will come later on. So my cases, I have named this presentation as Twisted Tales of Trembling Teens. So my first case, she was a 17-year-old female. She presented to the OPD with tremulousness of hands for 2 years and a gait imbalance for last 1 year. I'll quickly show the videos.
হয়তো আমার হাত কাঁপছে, ঘাড় কাঁপছে আর হাঁটার সময় প্রবলেম হয়।
So we can see there is spastic ataxic dysarthria along with postural tremor which was asymmetric more on right side, and it worsens on wing beating posture.
হয়তো আমার হাত কাঁপছে, ঘাড় কাঁপছে।
there is gross intention tremor, as well as appendicular ataxia in lower limb also in the heel shin test. So in the MRI, so we first did the we ruled out all the treatable causes, and in the neuroimaging, the MRI brain showed cerebellar atrophy and T2 and flare hyperintensity in the brainstem, as we can see here, and also the posterior limb of internal capsule is slightly hyperintense on T2, and there is symmetric pallidal and thalamic hypointensity in T2 and flare, as we can see here in both sides. So we sent for spinocerebellar ataxia panel, which came back as negative, and whole exome sequencing was also normal. So without divulging the diagnosis, I will go to the next case, which presented with a similar presentation. He is a 16-year-old male with a progressive gait imbalance for 8 months and mild cognitive decline and behavioral change from 2 months. On examination, he had some gaze-evoked nystagmus, symmetric postural and action tremor, spasticity, and ataxic gait with dysmetria. So this is the video.
যাও যাও দুটো হাত এইরকম
So we can see the both truncal and appendicular dysmetria, truncal ataxia and appendicular ataxia, along with some postural tremor worsening on wing beating posture. In this case also, the MRI brain, here the picture is quite clear. We can see the posterior limb of internal capsule bilaterally has T2 and flare hyperintensity, and the thalamus and pallidus on both sides are mild to moderate. Hypointensity is there. Both thalami are more hypointense than the globus pallidus. There is also some periventricular white matter changes seen in the flare and T2 also. So in this case also, after ruling out common causes, we sent for spinocerebellar ataxia panel, came back as negative, and whole exome sequencing, which also came back as normal. The third case, which is the last case of this series, he is a 25-year-old male, but his symptoms started after he completed his teenage years. He presented with tremulousness of hands for 4 years, gait imbalance for 2 years, personality changes, mood disorder, hypersexuality and aggressiveness for last 2 years, and cognitive decline since last 2 years. On examination, I will show the video. Other than the video, there was generalized hyperreflexia, spasticity and dysarthria.
जाओ उधर ठीक है अभी पैर
So you can see there is not much swaying when he is walking, but the broad base is quite evident, and while doing tandem gait there is significant difficulty.
जाओ उधर finger nose finger nose ऐसे करो.
We can see there is significant appendicular dysmetria in the finger nose finger, and there is intention tremor as well.
सीधे करो straight करो.
Here also the imaging shows a T2 and flare hyperintensity involving the brainstem. Here we can see, and the posterior limb of internal capsule is hyperintense symmetrically, along with some pallidus, globus pallidus hypointensity in the flare sequence, and some periventricular white matter changes. As like the previous two cases, spinocerebellar ataxia panel was negative, and whole exome sequencing come back as normal.
Okay, Anusri, just stop here. So she presented 3 cases, clues he has given from the same diagnosis. All the 3 cases presented with mainly ataxia with coarse tremor, and similar imaging finding in all 3 of them. Posterior limb of internal capsule was hyperintense, lateral part of the thalamus and globus pallidus was hypointense. So now you can proceed.
So,
No,
no,
all
sir,
three
no,
different
all
cases.
three different
and in
cases.
all three cases, scar panel was normal, and whole exome sequencing, including mitochondrial exome max, was normal. Anybody want to take it? Many of us here, sir, actually know the diagnosis. Anybody apart from INK who wants to take it? So 3 cases, same diagnosis. Yeah, Vikram knows it. Yeah, so that whole exome sequencing already done, sir. You can proceed.
After we have exhausted all the genetics and neuroimaging, so we went back to the history. We called these patients to OPD and we delved into the history. On probing, an surprising entity came up. So why I am presenting all these 3 cases together? On asking repeatedly, the first case, the patient, the 17-year-old female, she was sniffing scented glue sticks containing toluene. In the second case, the 16-year-old male patient, several bottles of eraser fluid containing toluene were discovered from the patient's room. And in the third case also, the patient was addicted to glue containing toluene. His father had a glue factory where he was addicted to these toluene containing glues. So, toluene is a volatile solvent. Abuse potential of volatile solvent has been reported for many years. The first case being reported in 1961, and it has been seen in as young as a 4-year-old child. These are commonly used substance, as these are easily available and very cheap. Toluene has a lipophilic nature, easily crosses blood-brain barrier, and it has a tendency to form a lipid bilayer in the highly metabolic deep nuclei, gray matter, deep nuclei, and also the cerebellar dentate nucleus, which leads to the MR imaging leading to the thalamic and pallidal hypointensity. We can also see dentate hypointensity, but that was not present in our cases. So, in the classification of volatile substances, we can clearly see aromatic hydrocarbons like benzene, toluene present in adhesives, spray paint, glues and paint thinner, which are easily available in market.
Please wrap up.
So, quickly I'll show the sniffing, bagging and huffing methods of the abusing the substance, and the neurological toxicity, which is dose dependent, and around 8 parts per million. It presents euphoria, excitation, disinhibition, exhilaration. The clinical MR findings typically shows the posterior limb hypointensity. It is already reported in literature. Posterior limb hyperintensity along with thalamic and pallidal hypointensity. Management is acute exposure is supportive management. There is no specific treatment for chronic exposure, but the sources of exposure must be identified and minimized. There are some small scale study regarding acetaminophen and aspirin combination, which can inhibit the toluene metabolism, but this needs further larger studies. So these are my references.
Thank you, Anuj. Thank you. So for our second case presentation, may I invite our consultant pediatric neurologist, Dr. Hina?
I have one question.
Okay, sure.
So, why it is specific for this posterior limb and this your both gray matter and white matter, particular part of the brain?
Yeah, actually posterior limb hyperintensity is nothing specific for toluene. In any kind of spastic ataxia presentation, you will feel this cerebellar involvement and posterior limb of internal capsule hyperintensity. Here the clue was that everything when you ruled out, along with posterior limb of internal capsule hyperintensity, both the sides were hypointense. So we call it sometimes as a river sign, like two mountains, and between those two mountains there is a river. River is hyperintense, and both the two mountains, lateral thalamus and medial globus pallidus, is hypo. Exactly why this has happened, that we don't know, but as Dr. Onusri was mentioning, because on some receptors are there who are prone to this kind of toxicity, that's most likely the cause.
Good morning, everybody. Thank you to the organizing team for having me here. I have just 2 short cases to present, and let's start with it. So my first case is a 5-month-old girl. She came to me about a year back. She is a first child of 3rd-degree consanguineous marriage, and she had uneven full antenatal and birth history. She mainly presented with complaints of delay in attaining milestones, mostly motor milestones, that is, she had partial neck holding, not approaching objects, no rolling over, but her cognitive and other milestones were normal. She also had started to have multiple paroxysmal events in the form of uprolling of eyes with the normal posturing of both upper limbs. This happened multiple times a day, and for variable period, this was been happening for the last 1 month. Let's quickly play the videos. So you can see the child is having some rolling of eyes, having posture in both upper limbs, some oral automatisms. This has been going on for some time. Clearly she's not responding to the mother when the mother is calling her. It's a very similar video. True. So on examination, her anthropometry was normal, her vitals were normal, her pupils were reactive. Other than depressed nasal ridge and some frontal bossing, most of her, there were no dysmorphic features. She also had some head lag, axial hypotonia, brisk reflexes, and decreased tone. As I said, her cognitive milestones like social smile, eye contact, visual tracking all were normal. She was not having any hepatosplenomegaly or any neurokidneous markers. So the differential we thought about was possibly some early onset infantile epilepsies, like genetic epilepsies like the KCNQ, KCNT mutations, or some treatable metabolic epilepsies like biotinase deficiency, which we should always be thinking of in patients presenting with early onset epilepsies, and obviously structural malformations. Another differential which we also considered were early onset dystonias, white matter disorders like Krabbe's or MCT8 disorders, which can also present as early onset dystonias, treatable metabolic disorders like biotin-thiamine, responsive basic ganglion disease, and obviously parental insult in all children presenting with epilepsies or dystonias should always be considered, since we don't have a very clear history in most of the cases, and neurotransmitter disorders was also consideration. We got an MRI done, and the MRI was just showing normal myelination for age and some prominent subarachnoid spaces. So that more or less ruled out white matter changes, structural and perinatal injury. We got an EEG done. EEG was showing a discontinuous background, which showed a delayed maturation of EEG components for age. This is what the EEG looked like. There's definitely some discontinuous background, but there were no abnormal discharges seen. So we also did a video EEG. Sorry, I could not put the video EEG here. And we captured multiple events without any EEG correlation. We got a metabolic workup, ammonia, lactate, biotinase, and TMS, TFT, everything was normal. So then we came to the conclusion that probably these are some paroxysmal non-epileptic events, possibly dystonia with oculogyric crisis. We asked them for a neurotransmitter profile, however they refused, and we directly went away for the genetic testing. And this is what we got as positive. She had a mutation in the cypiopterin reductase gene. It was a likely pathogenic and homozygous mutation. So just putting up the video of this child after being treated. This is a few months back. This was when she was 18 months old. She has attained her motor milestones normally, and cognitively she has been normal for her age, at par with other siblings. So she was given L-Dopa and 5-hydroxytryptophan, and she's doing quite well. Coming to case 2, she was a 16-year-old girl who presented to my OPD. To our emergency just a few days back. She was apparently all right till 12 years of age when she had her first episode of unprovoked seizure, and for this she was taken to the local hospital. She was started on Levera. For a few months she remained asymptomatic, and then she had another episode of breakthrough seizure when they had got the first MRI done. That was around in June 2022. And it was reported as abnormal. I'll come back to the MRI later on. So after the drugs were optimized, her seizures were well controlled. So she did not come to the emergency with seizures. She actually came with some other abnormal movements, and these movements have been present for the last 2 years, and they're increasing in intensity. So quickly play the video.
हाथ मत ही हाँ पानी दे रहे हाथ मत हिलाइए, हाथ मत हिलाइए.
So she's having very severe oromotor dyskinesias. In addition, she's very fidgety, very anxious looking, and she's having these coriform movements. Coming to her antenatal and birth history, it was significant that the mother had a fall during pregnancy and she was delivered in the vehicle on the way to the hospital with also a history of delayed cry and an ICU admission, the details of which are not available. Developmentally, she had mainly delay in the speech milestones and she started speaking fluently only after 6 years of age. And her scholastic performance was average and there was no significant family history. Examination wise, her height and weight both were less than the third percentile. She was very anxious looking, no facial dysmorphism, mildly increased tone, breast DTRs and plantar extensors. There was no Gehr-Fring grossly and no hepatosplenomegaly, and rest of the examination was normal. So with a child with significant perinatal history and cognitive and speech delay and past history of seizures and progressively worsening abnormal movements, mainly in the form of oromotor dyskinesias and coriform movements. I forgot to mention that she also had some intermittent dystonias, which was not very prominent, so that we got only after probing into the history. And so we consider these as the differentials, such as the progressive neurodegenerative disorders like Wilson's neurodegeneration of brain iron accumulation, could be possibility of leukodystrophy. Early onset dystonias was considered, could be just a consequence of perinatal injury which she had early on, and could also be just a very severe form of neuropsychiatric disorders like PANS and chronic tic disorder. So the EG was normal. Blood investigations, the ASO titer was normal, cerebrosplasmin copper levels were normal, urine copper was normal, ammonia lactate came normal. Eye examination did not show any Gehr-Fring or cherry red spots. We got a repeat MRI. So this was the MRI which was done in 2022. And we can see that she's having significant white matter changes, more or less symmetrical, and they are present in the peritrigonal, periventricular, and hyperparietal regions, along with involvement of the external capsule in the insular cortex. That probably explains why she had so much of speech fluency issues. And this was the MRI, which we repeated recently in our institute. And we can see that the white matter changes have not progressed. They're just the same. Definitely no basal ganglia involvement, no involvement of any other regions of the brain, no new white matter changes. So basically these were non-progressive white matter changes, no involvement of basal ganglia. Now, one significant history which they had told us that she was having some diurnal variations in the movements. So when these movements started, they were more towards the evening, and the rest of the day she was fine. But then slowly these movements progressed, and they were present most of the time of the day. So we gave a trial of low dose dopa, starting with 2 mg per kg per day in 3 divided doses. And this is a child after about 2 days. This is an evening video especially, just to see if she had any variations in the evening time. Movements have significantly improved and she looks quite comfortable. So likely diagnosis we thought could be dual pathology like the HI sequelae causing the white matter changes along with dopa responsive dystonia. It could be a DRD plus phenotype because of the white matter changes. Many neurotransmitter disorders like PTPS or dihydropterin reductase deficiency can have white matter changes in addition to all the movement disorders. And as I said, it could be just some neuropsychiatric disorder like PANS and chronic tic disorder, which could be present in any of the children with static encephalopathies and intellectual disability. The genetic testing is still awaited, so we don't have a confirmatory diagnosis yet. So just an overview of the neurotransmitter disorders. When should we suspect neurotransmitter disorders in children? If they present with movement disorders, should I go ahead? Yeah. So if they present with movement disorders in the form of dystonia, truncal hypotonia, oculogyric crisis, bulbar dysfunction, along with Parkinsonian features and features of autonomic dysregulation like excessive sweating, temperature dysregulation, ptosis, meiosis, hypoglycemia, and in addition, they might have developmental delays, seizures, and psychiatric comorbidities. So these are some of the clues when we should be thinking of neurotransmitter disorders. The neurotransmitters in brain are the monoamine neurotransmitters. Sorry?
Quickly wrap up.
Yeah. So we have, we know that the two the common neurotransmitters in the brain, the serotonin, dopamine, epinephrine, norepinephrine, glycine, and GABA. So quickly going through the metabolism of these neurotransmitters. So dopamine and serotonin are synthesized from tyrosine and tryptophan. This process requires 3 enzymes. One is the tyrosine hydroxylase, tryptophan hydroxylase, and aromatic amino acid decarboxylase. So deficiency of any of these enzymes can result into monoamine synthesis disorders. So 2 of these enzymes, that is tryptophan and tyrosine hydroxylase, requires tetrahydrobiopterin for as a cofactor. So any of the the tetrahydrobiopterin itself requires 3 enzymes, that is the GTP cyclohydrolase, PTPase, and cypiapterin reductase. So deficiency of any of these can result into neurotransmitter disorders in addition. And then there are the catabolism defects associated with dopamine beta hydroxylase and monoamine oxidase, and also the recycling defects of tetrahydrobiopterin. So just quickly going through the classical DRD, usually presents in childhood or the adolescent period with focal onset dystonias, which will then progress into segmental and then generalized, and they can and those with later onset can have Parkinsonian features. That can be the most important clue in the classical DRD is the diurnal fluctuations and the sleep benefit which is seen, and obviously they have very dramatic and sustained response to small dose of levodopa without much of motor side effects. The classical example being the autosomal dominant GTP cyclohydroxylase deficiency. And the DRD plus phenotype, as I already mentioned, they usually have an infantile onset. They may have psychomotor delay and other features like seizures, hypotonia, oculogyric crisis, autonomic instability, and they have less dramatic response to L-DOPA. They require higher doses, and usually they will have more of motor side effects. The classical example being the autosomal recessive GTP cyclohydrolase deficiency.
We can stop here.
Yes, sir. So just going to the last slide, that's the treatment and the phenotype of the common neurotransmitter disorders and the treatment. So basically most of these disorders respond partially or completely to L-DOPA carbidopa combination. So a combination, L-DOPA should be tried in most of these disorders, and only the few ones, the last two, they will usually not respond to L-DOPA, but most of them respond well to L-DOPA. So the take-home message, what I would like to say is that all patients presenting with movement disorders at whatever age and whatever form should be given a trial of L-DOPA, and so that's what that explains that not all of these genetic disorders are grim. That's what.
Thank you.
Thank you
So much, Dr. Kim. So that's a nice presentation on DRD spectrum disorder. Now there will be a short case by Dr. Santosho. Dr. Santosho is our fellow movement disorders. Please. So try to make it just very brief.
Okay, thank you. Good morning, everybody. So let me introduce. I'm Santoso. I'm one of fellow in the movement disorder in the INK. So today I want to present my case with the title "Deeper Than Sadness." So maybe directly to my case. Though 39 years old male with a normal and perinatal development history. This patient has history of depression triggered by rejection for the job interview started 12 years ago, and then having self-injurious behavior after 2 years of initial symptoms, I mean after depression. And because of this, this patient being followed up by psychiatrists with medication fluoxetine, sertraline, aripiprazole, and risperidone. Then 5 years back, family members noticed that some fidgetiness was there, and then developed tendency to fall while walking since 1 year back. From family history, we got a cousin brother from the maternal side had psychosis and addiction, and also committed to suicide. And this is a examination. From the examination, we
sound please.
কি অসুবিধা হচ্ছে এখন?
So, actually from here, patient has a grunting speech, I mean a vocal tic with dystonic posture. He cannot maintain for the posturing for proper seat.
Actually, a lot of fidgetiness going on, right?
Yes.
But we are seeing.
So, okay. And for the walking, or I mean for gait, we can see here. So, some jerky movement for the two hands, and also see patient has a freezing of gait when he turned.
So that's the clue here. I would like to stop Dr. Santosho. So this was the complaint how the patient presented. He said that when I am walking, some suddenly lock and key type of phenomenon happening. Somebody is stopping me, and on the very next second, it is getting cleared. So seen by others outside and diagnosed at freezing of gait, and initially that complaint was like that. But look carefully. Can you play the video once more? Because clue is here. Okay, now proceed.
So, in summary, 39 years old male clinically with a history of psychiatric illness, depression, progressive of pseudo freezing of gait, FOG, choreiform gait, and grunting speech or vocal speech. So, we put the differential diagnosis first because of secondary, such as drug induced, maybe because of antidepressant medication, and or maybe because of metabolic. And also we thinking of genetics, because the features is similar like Huntington disease, or maybe Huntington's phenocopies like HDL2, chorea acanthocytosis, and can be Wilson disease. And then continued with the relevant investigation. I mean, for the further investigation, we do a routine blood parameters, serum ceruloplasmin level. All of investigation is normal, within normal limit, including the EEG also, without abnormality detected in the recording. From the MRI, we can see here there is a hyperintensity in the caudate nucleus bilateral. It is similar like in Huntington, I think. But from the genetic, I mean for the Huntington disease test, we got allele, both is normal. I mean
okay,
within
so
the normal.
Santosho, just stop here. So patient presented with that pseudo freezing of gait, whatever, along with lot of fidgetiness, along with some family history of psychiatry, suicidal attempt. So definitely with that MRI picture, initially people may think of juvenile Huntington, but as we know, juvenile Huntington can have striatal hyperintensity, caudate atrophy, but generally they have more of Parkinsonism rather than more of chorea. Here we are getting chorea, that pseudo freezing of gait, what we call it, because of the choreiform movement, and then this kind of hyperintensity, where routine parameters are all normal and HD was negative. And fresh blood acanthocyte when was sent was normal, but there was a twist that Dr. Santosho will explain.
Then we continue for the another genetic. here we found that patient has a compound heterozygous mutation in the VPS38 genes, which is responsible for the chorioacanthocytosis. Then we continue. We check repeat for the blood smear using a fresh sample here, and it is wonderful. We got the acanthocytosis here.
Yeah. So the learning point from this case was fresh blood acanthocytes should be fresh, quote unquote. So what happened when if you write that and go to the lab, if they are doing it fresh, it's happened from here also and in anywhere, it may not be that fresh. If you keep it for a few hours, it may get degenerated. So best thing what we do, we talked with our pathologist Dr. Chaudhary, send the patient directly to Dr. Chaudhary's office. He took the blood and examined it, and we got that fresh blood acanthocytes. So initial that fresh was not that fresh. So that was a learning point. Thank you, Dr. Santosha. Thank you.
Thank you. Thank you.
So that's it. You want to finish? Take home message.
Okay. From our cases, we have a learning point first. Chorioacanthocytosis can be a cause of a pseudo freezing of gait, and if someone come to us with the psychiatric symptoms and then develop for the movement disorder, so it is not always because of drug induced. And if we found bilateral striatal hyperintensity, so we have also think with the neuroacanthocytosis also should be considered. And actually, I have one video miss here. So from this patient, we didn't find feeding dystonia, and we know that feeding dystonia is prominent in the chorioacanthocytosis. So we write here, feeding dystonia may not always be then prominent in a chorioacanthocytosis, and fresh blood acanthocytosis test must be done in the fresh sample.
Thank you.
That's it.
Thank
you.
Did this patient have, what was the actual phenomenology? Pseudo freezing?
This was chorea actually. We will see.
Chorea. So that chorea was preventing him from movement.
Yeah. So today we will learn two cases of pseudo freezing. One case we have already seen, and Dr. Purba will show another case of pseudo freezing. So when patient present to us with freezing of gait, it may not be true freezing. It can be something else.
So
there are lots of differential diagnosis of acanthocytosis. We ruled out liver disease, intestinal disease, malabsorption.
It is genetically proved. So
it is VPS30 में pathogenic mutation.
Yeah, from
and no organomegaly as you are saying.
Did the patient have peripheral neuropathy also?
Yeah. When you practice in the rural Bengal, you will find this kind of cases. So I have got 4 cases of neuroacanthocytosis, so far level without any genetic test, and majority having diphallobacterium latam in the intestine. So Escherichia diphallobacterium latam in the stool. So malabsorption is one of the cause of this, because malabsorption is ultimately leads to loss of your essential fatty acid, vitamin E. So many things are there. So chorioacanthocytosis ataxia sequence, and in a rural Bengal, you will find this kind of cases. That's why I asked for what are the other differential diagnoses, liver disease, or intestinal.
In liver disease and kidney disease, actually there is sparse cell and Barr cell anemia. So they look like this spiny horns. So that is one important.
And acanthocytosis is physiological. In 3% of blood smear. So if it is processed 6%, then it is significant.
Something, yes.
And the clue was more irregularly spaced. Yes. Those, as Sir was mentioning, here we got it around 10% and more of irregularly spaced.
So usual clue is that if you have got what you have told, that abnormal tongue movement.
Dystonia.
So I think someone has also showed a case that tongue had made another hole below mouth. So the tongue was coming out through that. So very abnormal tongue movement is one clue. Another is peripheral neuropathy. So if a patient you have got chorea associated with loss of ankle jar, first think of neuroacanthocytosis. So that is a very important clue, that absence of ankle jar.
Feeding dystonia is
Absolutely,
prominent.
sir. Thank you. So another short case, just because of we are about to break for lunch. So Dr. Rosina. Keeping them from lunch.
I'll take my minutes.
sorry. Go ahead. Sure, go ahead. Dr. Hina is here. Okay, she will come back. Once you come back, you can ask. Sure. Yeah. Yeah, they are not totally reversible at all. Even the ataxia and tremor is not totally reversible, but in all three cases, one was lost to follow-up, but both
I'm
the
Dr.
cases,
Rojina.
tremor is much better. Yeah, atrophy may persist.
So my case is named as confusion of clumsy. Here, so 36-year-old male patient came to OPD with normal perinatal and development history with complaint of gait imbalance for last 3 years, slurring of speech for 1.5 years, with progressive slowness in daily activities for last 6 months, along with episodic memory impairment for last 6 months, without any history of postural dizziness, urinary problem, but there was history of father death in 40s, whose cause of death was undiagnosed without any significant family history, other significant family history. Now coming to the clinical findings, higher mental function MoCA was 24 out of 30. Problem usually noted in delayed recall with executive task. And speech was mild dysarthric. Cranial nerves examination was normal except there was gaze evoke nystagmus. Motor system tone in appendicular rigidity of 1/4 with normal motor power. And there was subtle myoclonus with sensory system examination. There was diminished sensation to pain and temperature in the distal lower limb. Deep tendon reflex was 2+ in the upper limb and lower limb it was diminished, and plantar response was equivocal. Now coming to the cerebellar sign, gaze epoch nystagmus was there along with dysmetria, finger nose test was positive, heel scent was impaired, and gait was broad based ataxic gait. Tandem is unable to do, and extrapyramidal system there was mild appendicular rigidity of 1/4.
Sound. एकदम ऊपर, एकदम नीचे, एकदम ऊपर, एकदम नीचे.
And myoclonus, subtle myoclonus was there.
So some dysrhythmia you got in finger tap, right?
Yes, sir.
And some dysmetria you got.
Yes, sir.
So far, what are the features we got? We got some cerebellar features. Yeah, some
Yes, some
cerebellar
slowness.
features, some Parkinsonian features. The bradykinesia is there. along with myoclonus you showed,
Myoclonus.
right? So three main phenomenology what we are dealing with.
Gradual onset, no family history.
No family history of such, but father had died at age of 40, which was undiagnosed.
Yeah. And he had some psychiatry issues, I think. Some undiagnosed, yeah. So detailed history we don't know. Okay.
So coming to the summary, that 36-year-old male clinically presented with progressive ataxia, cognitive decline, Parkinsonism and neuropathy.
Okay, show
Yes,
the
sir.
SCAR report first.
So
Go ahead.
just differentials, we thought that spinocerebellar ataxia, Friedreich's ataxia, Wilson disease, vitamin E deficiency, neurometabolic disorders or the storage, that is Niemann-Pick or Gaucher's, white matter abnormalities, leukodystrophies, mitochondrial diseases, and the ataxia telangiectasia variant spectrum disorder, and the young onset MSA. Now, sir, I am coming to SCA panel. Now, this was the MRI which shows there is cerebellar atrophy, and this slide shows there is cerebellar atrophy along with here there is gray matter hyperintensities presenting as ribbon, and along with the bilateral coded hyperintensities. Now coming to the routine blood which was normal, vitamin E level was done normal, vitamin B12 normal, ceruloplasmin was normal. On slit lab examination, no K-ring, USG was done which is normal. Serum and CSF autoimmunopanel was seen, came negative. EEG was normal, and NCS all 4 limbs, axonal sensory motor neuropathy of both lower limbs. Now coming to the SCA panel which was normal.
So just hold here, Rojina.
Yes, sir.
So as we were discussing, the patient presented with all those three phenotypes, along with some cognitive decline in the movement disorder. We had Parkinsonism, we had myoclonus, and we had ataxia,
Yes,
right? With some doubtful family history. Because of that family history, ataxia was there, and ataxia is predominant gait ataxia, lower limb ataxia with subtle dysmetria in upper limb. So SCA panel was ruled out. Neuropathy was there, so again SCA was think fast. In the MRI, actually, there was mild cerebellar atrophy. In the diffusion, there was no rebound. Mostly, apart from mild cerebellar atrophy, MRI was normal. So that's how anybody want to take apart from INK. Any residents? Okay, so we can proceed.
Okay. So what could be? Then we don't want to miss any mitochondrial origin of disease, so we send the exome max targeting cerebellar ataxia, which shows the PRP gene PRNP gene mutation of chromosome 20 at exon 2 location, which was pathogenic. That lead to the defective prion protein, which lead accumulation in the neurons, and this result in the Gerstmann-Straussler syndrome. Now, a few lines about GSS syndrome. It usually presented as the gait disturbance, that is ataxia, along with dysarthria. There may be the lower limb dysesthesia, areflexia of the lower limbs. Positive Babinski may or may not be there. Characteristic change, some psychological symptoms may be there with cognitive dysfunction after 3 to 6 months of onset of the imbalance usually, and onset usually younger than 60 years, and duration for diagnosis of the disease 9 months to more than 2 years. So the most common mutation, there is many other mutation also, most common mutation which usually found is the proline is replaced by the leucine at 102 location. And there was a case report from India by the Gauri Devi et al., which shows there is familial prion diseases. That is the first reported case from the India.
And same variant they got also, right?
Yes, sir.
Proline 102 leucine.
These are the actual MRI findings usually seen in the Gassman-Stossler-Sinker disease, which shows that there is the cortical gray matter hyperintensities presenting as a ribbon, and along with the corded bilateral corded lobe hyperintensities and the cerebellar ataxia. So the take-home message, GSS should be considered in a patient with progressive ataxia, myoclonus and cognitive decline, and earlier death of parent should be asked in the history. The commonest mutation of GSS in India is proline 102 by Lewisian with varied phenotypes.
Straussler-Sinker variant. To leucine. Apart from mild cerebellar atrophy or that may not be present. We did not get any cortical ribbon in diffusion, but still when there is this combination, a bit short history, rapid progression of ataxia along with Parkinsonism and myoclonus, don't miss prion. Compared to the CJD ones where you will find generally very rapidly progressive ataxia, definitely will think of CJD, but here it can be a bit slow progressive compared to the typical CJD ones. So that's the clue. Thank you, Dr. Regina.
Thank you.
Thank you. So, few housekeeping arrangements. There is a subtle change in our program schedule because some emergency happened in the ward and some of our residents have to go. So, we have to keep you wait little bit for the lunch. So, can I ask another case presentation? So, apart from food, I think there are a lot of food here also as a movement disorder food for the brain. So, Dr. Purva to present her case, please.
দুটো করে স্লাইড একসাথে আসছে না প্রিভিয়াস কোথায় আগেরটায় যেতে হবে Okay, I'll be presenting few cases like they all have the single diagnosis. So short video of few cases. So this is the first one. Pseudo freezing. This is a 3-month-old history of gait disturbances, history of marital discord, depression, and followed by the patient used to tell that he has stumble and he has fall sometimes. So this is the patient is walking on gait right. We can see the freezing. And MRI brain diffuse T2 hyperintensity, metabolic workup was normal. We'll go to the second one. This is the second one. This patient, young onset, and he had gone to the tuition class. While coming back after tuition class, he became very mute. He was not interacting with family members. Next day, he was taken to psychiatrist. He was treated with flupentixol. And a few days after this treatment, he started having these movements. Jaw opening dystonia with some gait imbalance. Cognition was preserved, like after psychiatric treatment, he started to speak and cognition was all right. Then next case. Yes, sir. Flupentixol. After that, he developed this disease. Mutism went away with flupentixol, but he developed these movements, jaw opening dystonia and some gait imbalance. So this is the next case. This person is a football player, professional football player. He complained that he was not able to kick the balls, and sometimes while kicking, he used to fall. So other than this hung up knee jerk, all other neurological examination was normal. will. There was no cognitive or behavioral abnormalities. Next video. This is a video from NRS Medical College given by Dr. Shankar Saha. So, this patient used to have this tick stereotypic movement, and 12 years old boy. This is insidious onset. There were some behavioral disturbances and these movements. His MRI and metabolic workup were normal. We'll go to the next case quickly. A 12-year-old girl presented with abnormal movements of whole body, abnormal posturing, dystonic posturing, and laughter, uncontrollable laughter. MRI brain showed bilateral basal ganglia hyperintensities. Metabolic workup was normal.
Okay, so I think here we can stop.
Okay, we have another, I think, one or two small videos. So this is another video from NRS Medical College. Patient presented with catatonia and hemidystonia. MRI brain showed diffuse cerebral atrophy. Metabolic workup was normal. Yes, sir. After he first was catatonia, olanzapine, then hemidystonia. Yes, sir. And this is mainly generalized dystonia, jerky dystonia of whole body. Because of time constraint, I'll just go to the next video. This is again generalized dystonia ataxia. MRI brain
before,
is the sample.
Purvati, just
yes.
Let's take the opinion of the house before going to the MRI brain. So you showed around total how many cases? 8 cases with different phenomenology. Some are movement disorders, some are kind of some general neurological examination findings, all having the same diagnosis. Here, I think any residents want to take it. It's very common. I know anyone can guess it, apart from IMK. Anybody wants to take. So what are the phenomenology? Just quickly. First case.
Pseudo-freezing.
Pseudo-freezing of gait. So this is the second case of pseudo-freezing of gait. We were discussing the first pseudo-freezing of gait with that chorea, right? And that was in chorea chondrocytosis. Here there was another pseudo-freezing of gait. Then
hung up knee jerk.
Hung up knee jerk was there.
Then jaw opening dystonia.
Jaw opening. Paroxysmal jaw opening
paroxysmal
dystonia.
jaw opening dystonia. Ataxia dystonia. Myoclonus.
Plus spasticity.
Spasticity. Hemidystonia, catatonia.
Yeah. One important differential diagnosis will be drug-induced.
Drug-induced.
Yes, sir.
Many of the cases were treated with.
One was olanzapine, one flupentixol. 2 cases. Yes, sir.
But so much of white matter hyperintensity in the brain, that has to be.
Yes. So what can be single clue which will diagnose all?
Anybody?
Single test diagnosing all.
Just one clue. One test you have to order and you will get the diagnosis. This is not drug induced fully. Okay. Yeah. So something else.
So which one disease has to be ruled out? That is the number one.
Yes, sir.
That is the.
So what we will get in EEG if we do an EEG here?
I'll show you.
So that's the EEG. So all 8 cases were SSP, right?
Yes.
They presented in this way. Apart from that classic slow myoclonus, it can have different presentation. That pseudo-freezing of gait was actually slow myoclonus. So first pseudo-freezing we saw in chorea acanthocytosis because of the chorea. Second pseudo-freezing of gait we saw because of that slow myoclonus. Paroxysmal jaw opening dystonia, more and more cases have been getting reported, very commonly seen in SSP. That hung up reflex can be seen. Dystonia, paroxysmal laughter, you will think of some gelastic seizure going on or not. but all these jaw perioral involvement can be seen in SSP.
So diagnosis, we all know, CSF, 3 patients showed OCB bands, all were positive for this thing, measles antibody. So our take-home message is like we should order, because few of these cases we even thought of whole exome sequencing before ordering EEG. So we learned a lesson from there. Before ordering high-end investigations like whole exome, clinical exam, we should do one simple EEG, at least in children and juvenile onset, to rule out SSP. It can be great mimica. Thank you.
Thank you, Bhubadi. So nice cases, all for SSP.
Sir, 4 of them had been vaccinated for measles, and none of them reported any measles infection. Like we had asked repeatedly, all 8 cases they didn't report any measles infection, and 4 were immunized.
So none of them had, this myoclonic jerks or
later on they developed, but not on the presentation.
Reduced scholastic performance like that.
One or two patients, that young onset, one said that reduced scholastic performances, but most of them had, actually 3 or 4 had acute onset, sir, only 3 months onset. One patient, that jaw opening dystonia, acute onset, went to tuition class, he came back, he was mute.
Give them any treatment?
Supportive treatment, not isoprenosin or alpha interferon, no, sir.
Actually, sir, what we are seeing, all these are actually slow myoclonus only. Like this may be slow myoclonus of the jaw. That's the jaw opening dystonia. And that hung-up reflex was also maybe pseudo hung-up reflex. That's also slow myoclonus getting stimulated by the stimulation. That paroxysmal dystonic posturing with pointing index, that can be also a slow myoclonus. So the classically slow myoclonus, what we expect in SSV, it can have varied forms, some atypical manifestations, and most likely that's the clue. Thank you, Bhubadi. As we were changing our schedule little bit, so I will ask Dr. Bhaskar Ghosh sir to introduce the next speaker, and then we'll break for the lunch.
So there is a slight modification of the routine, and now we will have another session. Now, how to approach treatable neurometabolic movement disorders. So that is very important topic, I think, because most of the movement disorders which we mostly discuss, they are just symptomatically treatable because they are mostly genetic, but you have to find out certain treatable conditions so that we can give some benefit to the patients. And to talk on this subject, we have Dr. Arushi Shaini. So she is the professor, the department, I think PGI Chandigarh. So she is a well-known face in our movement disorder society. So without wasting time, I hand over to her for delivering her.
Good afternoon, everyone. And at the outset, I would like to thank the team of Each Zone Neuropediatric, or the organizing team, for this opportunity, and special thanks to Rishi sir, Dr. Jackie, and Dr. Jasodhara. I know I'm standing between you and lunch, and also because most of the things that I'm going to teach have already been discussed, and there's been a lot of talk about genetics. What I'll try and do is to keep it simple, what we can do at the bedside, and if we can just look at the videos and put some thought process into the patient before we order some tests. So this is going to be little basic from what you have been doing what you have been listening to in the morning, and there might be some overlap because yes, everybody has alluded to the treatable conditions, and I think these treatable conditions deserve repeated mention so that they stick to our mind. So there are 3 things that we need to understand when we talk about treatable neurometabolic disorders. The first thing is that some basic idea about neurometabolic disorders has to be there, because it's not just that you have a gene and you put a name to it and then you think about like that. You should have, when you are looking at core neurometabolic disorders which are more difficult in children. So then you at least need to have some categorization in your brain. And of course, then what is the concept of movement disorders and what among them are treatable? Now you know that IEMs are rare disorders, so you will think about them in a lot of patients. You will confirm your diagnosis in a less, and only probably tip of the iceberg would be treatable, but even then it is important. So this is the current classification, where there are so many categories, and in next 5 years maybe the classification is going to evolve much more and become much more complex. But this is a basic thing which we try to learn, and I stick to this slide always. So if you have to think of IEMs in general, and we are going to talk about neurometabolic because brain is affected in almost 60 to 80%. So we are going to stick to those IEMs where brain is affected, and hence we say the term neurometabolic. So broadly you can think of them or remember about them as disorders of intermediary metabolism, disorders of energy metabolism, and complex molecule disorder. Now this is something which you already know. I'm just trying to put those into categories so that it is easy to remember. So when you talk of, so disorders of energy metabolism and intermediary metabolism are clubbed together as small molecule disorders. You would remember this same classification from your MBBS days, and later you might have read about it whenever you try to read about IEMs. And the other group is complex molecules, and they're biochemically large molecules because they're complex molecules, so they do not easily cross the membrane. So that is why where they're formed, they generally are stored in those organs. So that is why complex molecules are large molecules. The rest of the molecules, or the common IEMs that we deal about, are small single molecules which easily cross the membranes, and that is why they are put together. Now, it is important to remember because we are going to talk about specific diseases, and then in your brain you should be able to put them into some category. So the typical example of intermediary metabolic disorders would be disorders like aminoacidopathies, and one example each. So the most common aminoacidopathy would be MSUD. Somebody said, so MSUD, right? Organic acidemias, urecycle defects, carbohydrate intolerance defects, these are all small molecules. So that is why they are known like this. Energy, you know, comes from three sources in the body. One is glucose, the other one is mitochondria, and the third one is fatty acids. So these are typically the classic disorders which are put into disorders of energy metabolism. And this classification is also relevant to give you an idea about what happens in their manifestation. So when you talk of energy disorders, their manifestations would be more like energy crisis in that particular organ. When you talk of small molecule, their manifestations would be either because of accumulation of one compound or deficiency of a product which they were supposed to form. The large molecule disorders, they present less in children as acute forms, and they present even less as acute movement disorders, but still yes, we do see them. So movement disorders in neurometabolic disorder in children, the most common presentations are acute encephalopathies, epilepsy, tone abnormalities, but yes, movement disorders are a sizable proportion, and that is where their importance. IEMs contribute up to 1/4 of the cases in children. However, in contrast to adults, when you see a child with a movement disorder, it is very difficult to say that okay, this is the underlying IEM. In contrast to adults, because they generally do not come as only complaint. So in children, especially the younger the child, there will be a greater gamut of hard neurological signs, and movement disorder would be one thing. Now this movement disorder but may help you to recognize the type of disorder. But in children, remember, you often have to take everything together. So you have to look at the clinical, you have to look at the MRI, and you have to look at the basic investigations before you can actually say that okay, this is the type of IEM that I am dealing with. So that is one difference. Single movement disorders often do not predict the type of underlying IEM unless there are very specific syndromes like you have oculogyric crisis and you have hypotonia, delayed milestones, then yes. Still, what you can pinpoint is, okay, I'm probably dealing with a small molecule disorder. The subtype is probably a neurotransmitter disorder. Short outside of that, you really, if you have to pinpoint, you have to make use of genetics. But in this particular session, we are not going to talk much about genetics. So the obvious question is, what is the most common type of movement disorder you see in children? So in children with IEMs, you see both hyper and hypokinetic. However, international studies show that dystonia is most common, followed by ataxia. And we conducted a similar study at our center, and we also found that across all the age groups that we study, which means we studied up to 12 to 13 years of age, we also found that dystonia and ataxia were the most common disorders. Now, this is the traditional classification that you look at the movement disorder and then you try and remember the causes. For me, it becomes difficult to remember the movement disorder and try and remember the cause. Because if you look at the causes, you will see mitochondria pretty much figures everywhere, which means you should remember, okay, mitochondria can come like anything, which is not truly the case. Because when you have a patient, especially an infant or a very young child who can't speak, you will have to look at the entire syndrome. So how I try to remember it is in this way. So you divide your patients age-wise. So one age group is very young children, let's say 1 to 2 years of age, who will come with the conglomeration of neurological symptoms. The second age group is the walking children between 2 to 5, 6 years of age. And the third age group is peri-adolescent patients who are like, let's say 8 to 12 years or 14 years of old. Age, and their symptoms will be more like the adult cases that you see. Now, for each age, you have to remember which are the common IEMs first. Then you have to see which are the ones which commonly come with movement disorder. And this is something which probably you know, because as I'll show the cases, I'm pretty sure I have put them as cases, but I'm sure they are spotters to you. So what I'm trying to emphasize is that even if you do not know, when you see a case, you're trying to think of the IEM first, then you're trying to think of the movement disorder, and then of course you're trying to see whether you can treat this patient or not. So there are many disorders. We are trying to stick to the important treatable ones. So let's see the first age group. Now, the most common IEMs will be the one which will come most commonly, right? So even if when you talk of children 1 to 2 years of age, the most common disorders would be either organic acids or mitochondria, right? And then, of course, there are other disorders like mineral deposition based on the age. So when I say mineral deposition, Wilson is also amongst them, but you know instantly that, okay, an infant will not come with Wilson's disease, but there will be some other form of mineral deposition. And again, for the same reason, storage disorders will have a very limited expression in this age group, but in older children, you see many types of movement disorders. So that is why I say, when you're thinking of infants with movement disorders, the most common groups will be the ones which are the red ones. And about the presentation, so children will most commonly come with either unexplained developmental delay, with and without crisis, and with some movement disorder. And your approach, I think Sir highlighted in the morning, that what you should remember is when you see any child with a neurological complaint and you put a syndromic diagnosis, your approach will remain the same. So you will first try to look for a structural cause, then you will try to look for a metabolic cause, and in the end you will go ahead with the genetics. This also follows the ease of these tests. So MRI you can get done within few hours, metabolic test results you probably can get within few days. The genetic test will come within few weeks. So that is also the importance of these investigations. So you need not learn. Organic acids is a word which is commonly used everywhere. Just remember that this is a broad classification which is used. So some of them specifically affect the brain. The other ones have more systemic manifestations. But the one in blue are the ones which are most common as well as treatable. So that is the importance of understanding about them earlier. Now, the organic acids, when they come in 1 to 2 years of age, they come with almost a similar presentation. So you may have an infant who may have a pre-existing developmental delay or was normal. Then there was a trigger such as a fever or infection, and that led to an acute deterioration either in the form of loss of milestones or encephalopathy or a metabolic crisis, right? So this would be a typical story for an IEM, organic acid or a mitochondrial disorder coming in this very young age group. You will have some signs on examination which will be common, like children will have altered sensorium. If the acidosis is much more, they'll have acidotic breathing, they'll be floppy, diminished reflexes, might be intubated. The fundi will be normal, there'll hardly be any organomegaly. The head circumference at this age may be normal. So not much that you'll get. When you see actually a patient at the bedside, you may all see an encephalopathic baby with some metabolic tests. So the first important is that when you see such a child and you've ruled out an infection, you'll of course look at the first line metabolic test. The common accompaniments to make you think of organic acidemia and mitochondrial or a separate category urea cycle defect will be a difference in the blood gas. So an acidosis will give you a clue that this is this type of disorder, and alkalosis will tell you that this is probably a urea cycle defect, right? And there can be accompanying impairments. Now the second clue comes from neuroimaging. So the organic acids in general affect the basal ganglia in the brain. So typically the ones which we are talking about, propionic acidemia, MMAs, they all typically affect the basal ganglia, and that is why you can imagine that the first movement disorder whenever it will appear will be probably dystonia or related movement disorders. So you can easily make out that this is not a setting of an infection. This would hardly be a setting of demyelination. So this has to be a metabolic deterioration in your patient. Of course, wherever available, you should take the help of these metabolic tests in the form of TMS and GCMS because they help give you the bedside clue. So in this particular patient, the C3 was elevated. You can simply remember that Important, C3 is a very common metabolite which is elevated. So important causes of C3 are B12 deficiency, propionic and MMA. You should actually remember these 3 causes by heart. When you have a well child or a polysymptomatic child who has elevated C3 compounds, you should rule out B12 deficiency. If you have a sick patient, you should still rule out B12 deficiency, but you should also start thinking of underlying inherited metabolic defects. So that is why this one investigation is very important. This child turned out to be propionic acidemia, but trust me, this genetic report will come to you 6 to 8 weeks later. Before this, you have to start treating your patient within the first 48 hours. So remember, this presentation will be of propionic acidemia, MMAs, isovaleric acidemia, in general, most of the organic acidemias, right? How will you treat them? So the treatment would be, you will have to treat many of them together. The most common ones, so you start giving them B12. Remember, when you're treating them, you have to give them hydroxycobalamin, because that is the activated form. There can be several points in the pathway, but this is the activated form. So in a sick child, you give hydroxycobalamin, because if it is underlying MMA, your methylcobalamin is not going to help your patient. So in the sick child, give mega doses of carnitine, thiamine, riboflavin, CoQ, and B12. Don't forget this very important vitamin, and wait for recovery. You can prove your diagnosis later on, but this is what is the treatable IEM in an acute state. Now, similar presentation as I said. So this another child who had a similar presentation, who had the same movement disorder, came with an encephalitic-like illness. We could not prove any infection, and when he started recovering, the child started showing severe dystonias. Now this is exactly the same presentation. So you look for clues in the second most important thing, which is your imaging. Now this imaging, I'm sure everybody remembers, is typical of glutaric aciduria, because what you see is the bat-wing appearance. You see frontotemporal atrophy, and it's not very obvious, but in other patients you will also see bilateral striatal injury, and that is from where your dystonia is coming. So GA1, another very important treatable IEM. It comes with an acute encephalopathic crisis. It can have late presentations also, and in later stages they are known to have chronic renal failure, brain tumors, and peripheral neuropathy. But this is something which probably doctors seeing the children may not see. Now remember important differences. When you are trying to treat glutaric aciduria, your patient has to be started on oral carnitine. That is the single most important component that has to be there. And secondly, you have to put the patient on a diet which is restricted in lysine. Always tell your patients that whenever they are unwell, they have minor febrile illnesses, they should double the doses of these megavitamins so that they do not land in a hospital. So simple treatment cofactors that you need to remember for GA is, you don't have to give B12 injections, but you have to give carnitine, and you have to prevent lysine from the diet. So this is another child. The same point that I'm trying to emphasize, within first to 2 years of age, a child with or without pre-existing delay comes again with dystonia, deteriorates with a febrile illness, may or may not have similar family history. Again, your MRI will help you. So this time the MRI shows bilateral GP signal changes and bilateral substantia nigra signal changes. Anything that you can think of at the bedside? So when you have GP involvement, isolated GP involvement, when you have bilateral striatal injury, you think of GA. Same patient. So tyrosine hydroxylase, okay, but yes, but you have intense GP signal changes. They are very typical signature of conditions like isolated MMA. They are also seen in kernicterus. They can also be seen in a very important disorder which has a typical signature on the urinary excretion. So this is a 4-hydroxybutyrate, which is basically a metabolite of the GABA pathway. So what I'm trying to arrive at is the SSADH deficiency, which is a GABA pathway defect. So in any child with or without developmental delay and infantile onset dystonia and bilateral GP changes, think of SSADH. Why is it important? There is no specific treatment yet, but you have to remember that you have to avoid 2 anti-seizure medications, which are vigabatrin, tiagabin, and valproate is also contraindicated. So remember, there is a slight change in the anti-seizure medications. The therapy is underway. So SSADH, which is right now only controllable, may soon become a treatable organic acidemia. All right. So this is another child who has dystonia and has these similar bilateral changes in the GP. What additionally would you want to ask? So this baby was born near term, had no birth asphyxia, had mild neonatal jaundice at home, subsequently was noted to have delayed motor milestones and had an early onset dystonia. You can jump up to so MSUD, you're right, sir. MSUD has many variants. So the classical ones actually comes in the neonatal period with severe encephalopathy and much more florid presentation in the brain. The intermittent ones can come later, but this is a very common situation in your OPD practice. So this child did not have a metabolic disorder. This may not become very obvious. I mean, it's a metabolic disorder of that sense, but it's not an inherited one. So this is an acquired metabolic disorder. The clue is there in the history. So this is because of kernicterus. So in our country, dystonic CP because of kernicterus is very common. When you see a patient at 6 and 7 months in the first visit, you may not be able to make it out. But remember, you should always ask this history. When your child is polysymptomatic, has only dystonia and has this GP, always rule out kernicterus in the background.
Temporal lobe must be affected, medial temporal.
No, sir, no, not at all. They should not, actually not.
Bilirubin will not attach to the...
So bilirubin can do much more damage because when there is bilirubin encephalopathy, actually the child usually has sepsis and so many other things. But a typical signature of bilirubin encephalopathy is in the substantia nigra, is in the GP and is in the subthalamic nucleus. If the child has also had some asphyxia, then you may also find white matter changes. But generally the lobes are spared. It is the typical signature the bilirubin deposits in these areas. Okay, so now coming to the second most important group. Again, you will see that the presentation is same. There is nothing more that I'm going to tell you in the history. It is again same, an infant who has pre-existing delay, has a febrile illness-related regression and starts having dystonia and recovery. And this child also had impaired visual impairment, had impaired ocular movements and cortical vision impairment because of the MRI changes. So this was the MRI. What is the difference from the previous MRIs? The clinical history is pretty much the same. So now you see that there is diffuse bilateral symmetrical involvement of the white matter in the brain involving the corpus callosum, pretty much sparing the basal ganglia, involving areas in the midbrain, right? So this is what you call as leukoencephalopathy, right? Unless you find that there is an underlying inherited leukodystrophy, the broad term for white matter involvement is leukoencephalopathy. So you are thinking of a metabolic disorder and you have this leukoencephalopathy on the MRI. What are you going to look at? So sometimes there can be basal ganglia involvement, sometimes there can be only white matter involvement, and sometimes there can be selective area. So this is a striatal type of involvement. There's inverted lactate peak on the MRS. This was a child whom we had autopsied also. And this is a similar presentation in another child where you see, so these are sequential MRIs. Now in the third episode of regression, you see bilateral GP signal changes along with atrophy. So what is the common theme here? So the common theme is that again, infantile onset GDD with and without regression has variable areas on the MRI. This is the group of disorders. So this is mitochondrial disorders in general. When you try and evaluate, you may see elevated lactates, but these are the disorders which will not pick on the TMS and GCMS, and you will eventually have to resort to genetic testing. Why is it treatable? So remember, there are broadly 2-3 types of mitochondrial disorders in children. So one is the respiratory chain disorders, which we call as the nuclear encoded or the autosomal recessive mitochondrial nuclear chain disorder. So you have 5 complexes in the mitochondrial respiratory chain, and there can be genetic defects. They will commonly present as diffuse white matter abnormalities. What is the treatment implication? You have to start them on a mitochondrial cocktail. Cocktail is something just like you can make your own cocktail in the evening in a glass, you can make your own mitochondrial cocktail for the patient. There is no set criteria, but generally it involves mega doses of so many vitamins. Now this last presentation is particularly important, and here is the importance of genetic testing. So when there are, in a mitochondrial disorder, when only isolated GP are affected and it's a boy, you start thinking of PDH deficiencies. PDH is important because the treatment is slightly different from the rest of the mitochondrial disorders in that you have to initiate early ketogenic diet, and some of the genetic variants are thiamine responsive.
In so PDH variety, there will be less loss of hair or alopecia.
They can be, sir. There are many things described. PDH is a very tricky gene, so many things are described, but they can't be taken as a specific pointer to a disease. They can be additional features. But when you're thinking of mitochondrial, you have to differentiate that are you treating in general, but you need to diagnose PDH disorders because there are specific treatment implications. So, All right. So I think neurotransmitter disorders we've already heard so much about. I'm going to skip this. So early onset hypotonia, oculogyric crisis, delayed motor milestones, these would be the early clues towards an MRI which is usually normal or at least is not florid like other metabolic disorders would be your clues towards neurotransmitter defects. Again, in a young child with dystonia, if you have this type of MRI, I think it's a spotter. So what you see here is T1 images. We've not shown you T2 images like we love to, everybody loves to show T2 images because they are the ones. When somebody tries to show you T1 images, remember they're trying to take you to one disorder which is hypermagnesemia, or at least a mineral deposition you should think of. Otherwise, why would somebody show you T1 images, right? So this is hypermagnesemia and the treatment is? With chelation with? Calcium diaditate. Chelation has to go lifelong. You can have your own protocol, but at least in the initial years, you'll have to give it monthly. All right. So this is just a brief spotter since we are talking of young babies and treatable conditions. So look at this video and what was this movement that the baby did? Again. So remember, you should always ask about history, then examine, then jump to a diagnosis, right? But let's do the third step first. So what do you think? Normal, abnormal? There are some things which you may use if you want to use those terms, whether these are epileptic events in that, whether they are cycling seizures or infantile spasms, or they are just dyskinesia because the session is on movement disorder. They are combination of all of the above or none of the above? Normal. Normal movement. So what is this particular type of movement? These are shuddering attacks. So this is a normal happy baby, and what he does like this is the shuddering attack. This is very common. It comes by its own, goes by its own. The treatment is no treatment from your side. So please do not investigate, and that is the only treatment. So remember, this is a treatable mimic. Again. Yes. So gratification behavior. Again, don't misdiagnose them. They're none of the above. All right. So let's move to the older children. Older children doesn't mean that the movement any of the IEMs are out, which means now you have more categories of IEMs which can present later also, right? But the more common IEMs in children are organic acidemias. The small molecules are in general most common. So again, you will see more of organic acidemias and mitochondrial disorders, plus you will start seeing other disorders as well and more types of movement disorder because an infant has a limited expression. You won't see frank ataxia in an infant. What you will see is probably dystonia, tone changes, ocular changes. But in an older child, when the child is walking, you can see so many other things. So this was a 3-year-old boy. Remember, most of these disorders will have onset early. When I say 3-year-old, it doesn't mean that he had an onset at 3 years old. He had a global developmental delay. He had excessive irritability, and then he started developing these abnormal involuntary movements, and his perinatal period was not responsible for these conditions. So as you look at these bizarre movements, I'll give you the other clues. So he had microcephaly. There was mild hypotonia which improved. The fundus was normal. There was no organomegaly. The power reflexes were normal. His cognition, of course, was severely impaired. The speech was delayed. He was poor. He had poor eye contact. In general, he had severe autistic features. So what are the types? What is this type of movement disorder? So very complex stereotypies are happening. And there is very poor eye contact. So the child appears to be severely autistic, and there are marked complex stereotypies, right? All right. So when you have this setting where you have an underlying delay, you have microcephaly, you do not have a crisis-like presentation, there is no dysmorphism, organomegaly or fundus to make you think of storage disorder, but you just have microcephaly with or without seizures and bizarre behavior disorders. There are 2-3 common disorders in this age group that you should think about. One of them is Angelman would be a close genetic differential, okay, but they will generally have some facial clues. We do not truly call that dysmorphism, but of course, okay, Angelman. Among the IEMs, the treatable ones that we're talking about, you should think of phenylketonuria, biotinidase deficiency, and homocystinuria, right? So this was a child with phenylketonuria. Remember, this is again one IEM which will not have crisis-like presentation, will not be much on MRI. You may have only diffusion changes, just like in this image, you see diffusion restriction, but the MRI pretty much is normal. There are non-specific white matter changes. The first clue comes from your TMS. So there will be markedly elevated level of phenylalanine in the blood. The urine will also show the signature. And you know this is the first IEM, one of the first IEMs which was described. what is the treatment implication? The child has to be put on phenylalanine restricted diet. The early you diagnose, the better for the patient. That is the only treatment. The other thing that you can do is actually tetrahydrobiopterin has to be added. This is in fact said to be a trial. So you have to give tetrahydrobiopterin trial to your patient for at least 1 or 2 months and see whether it makes a significant drop, because some patients are known to be responsive to tetrahydrobiopterin. If not, this is a costly drug. Most of the patients may not afford. But remember, the treatment has to be lifelong. Unfortunately, because of the absence of newborn screening, we miss these patients and we see them with severe autism. All right. So this is a second case. This was a 2-year-old girl with developmental delay. She had 3 episodes of seizures, and parents had come. She was normal in between these episodes, and parents had come with these videos, home videos of these episodic events which would occur without any warning, last for 1 or 2 days, and then she would spontaneously recover. So this condition has already been alluded to in the morning. I am just doing a recapitulation. So we clearly see that she is. So we'll not jump to diagnosis, sir. Although I know that for all the senior people here, every case is a spotter, but I would still like to engage the audience. So what is the phenomenology? Ataxia. The parents are also saying she's wobbly, she has incoordination. So this is an episodic ataxia, right? This list also you have seen in the morning. I'll just tell you to the IM. So when there is intermittent ataxia, you think of aminoacidopathies, you think of mitochondrial disorders, urea cycle disorders, and heart nerve disease, right? The most common ones. Now, this is what the MRI sir was talking about. So when you have MSUD, it has a very good signature on the MRI. So MSUD generally involves the brain completely, even if your patient is polysymptomatic, and the branch chain amino acids have a myelin splitting effect in the brain. So they cause a lot of vasogenic edema, and that is why you will have intense diffusion restriction, which is a signature of MSUD. So these are the 2 things that you should look for. Now, this patient we tested with the usual steps, and everywhere we could find elevated levels of branch chain amino acids. So as sir was saying before, that the classical MSUD is a neonatal MSUD you see. But the one which we are talking about is the intermittent form of MSUD, and that is why it's a tricky disease, because it can come and go at any age, in child or as an adult, or sometimes it's also seen in pregnant females. So the stress of pregnancy makes the MSUD come forth. So this intermittent form of MSUD is quite reversible. The long-term management is again via diet, which is restricted in branch chain amino acids, and many of them are thymine responsive. So remember, one cofactor with MSUD is thymine. You have to give mega doses. This child luckily had a reversible presentation. So her ataxia went off. She remained in a long remission. And interestingly, her MRI also recovered completely. And she continues to be in remission, which is good for her. However, we can't really predict. Now, this is an interesting case. This was a 5-year-old girl with global delay, and she came with this gait abnormality, which was not just ataxia, but there was a component of spasticity as well. In the background, she had global developmental delay and poor scholastic performance, and this interesting hair loss was there. So she had episodes of this. Yes, very right. So when you have this additional history, these are additional clues, right? So what do you know biotin-based deficiency as? Infantile onset seizures, right? The second presentation that everybody knows about nowadays is the late onset ones, which is presenting as demyelination. So they commonly, so the first one is the neonatal seizure presentation. The rash can sometimes be missed as a diaper rash. Otherwise, so this is not a diaper rash, this is a rash in biotin-based deficiency. And the second case that we had seen was the one which came later, mimicking demyelination. The child went up to the treatment for multiple sclerosis, eventually was diagnosed to have biotin-based deficiency. So remember, there will be some intermittent forms which will escape the neonatal presentation, will not come with seizures, will just come to you with delay and movement disorder. So since biotinidase is the, and as Dr. Wolf has described it, he says if you have to have one IEM, if you can select your IEM, then you should have biotinidase deficiency, because it is eminently treatable. One single tablet of at least 10 milligram lifelong is the simplest type of IEM treatment that you can have. So remember and try and exclude in every possible condition. Sorry?
Very low cost.
Very low cost, sir. And if you don't look at the long-term hearing and optic changes, then probably this is one of the best IEMs to treat with, and very gratifying to treat. So remember. Now this is one disorder which you have seen again multiple times since morning. So this was the child who had mild delay, but she was otherwise very well. The mother was fond of making TikTok videos. Then she had a deterioration where she started having the severe dystonia, You can see she had started losing milestones. Now she was barely able to sit. And after therapy, she again was starting ambulation, but of course there are some sequelae. You can still see the residual dystonia, asymmetric dystonia in one of the limbs. All right, so what is the next investigation? Of course the MRI, and the MRI here is the signature of, you have seen at least three references to this disorder since morning. Either everybody was sleeping, or this disorder is very insignificant. This is the, so remember this MRI, this patchy bilateral involvement which almost looks like MOG disease. If you have seen the white matter in MOG, you will see these puffs changes, but there are typical areas like, you should look at the thalami. Besides basal ganglia, if the periaqueductal thalami are affected, basal ganglia, the midbrain is affected, then this is one typical disorder which is biotin thiamine responsive basal ganglia disease. I was thinking of skipping this case because I thought three times we have shown the MRI already. Anyways, what is the treatment implication? That is why I still kept the case. What is the treatment implication? Nobody asked this question when cases were shown to you in the morning. Nobody asked how should you treat them. So it is biotin thiamine responsive. You'll give biotin and thiamine. What is the catch? You'll give high dose thiamine. If you just give 50 milligram, 100 milligram of thiamine, it won't work because there is a block, and to overcome that receptor, you need to give supratherapeutic doses. So your thiamine has to be in the range of 400 to 500 milligrams per day. And same is true for biotin, has to go in 5 to 10 milligram per kg per day. When you treat biotin-based deficiency, you just give 10 to 20 milligram per day. This is mg per kg. There is no harm, don't worry. Whatever extra is there in the body, the kidneys are going to excrete it. So importance of BT-BGD is this, that you give high doses of biotin and thiamine, else your patients are going to make less optimal recovery and you can actually lose them. So the typical classical presentation is early infantile onset. They come with encephalopathy, but later onset, they can come with movement disorder accompanying underlying neurological deficits. So I will still not say that they will come only with the movement disorder. This is a typical disease which will tell you that the child will have much more to say that, okay, I am an IEM and IEM, and additionally I have a movement disorder, and maybe the MRI will give you the clue towards my diagnosis. Right? So remember, high dose thiamine, high dose biotin. Okay. So this was another 6-year-old girl with developmental delay. She had swaying while walking from 1.5 years of age. Thank you. And there were episodic behavioral arrest and vacant stares also. So these looked like epileptic events. There was no family history, nothing else was suggestive. So, I'm sorry. So she had a lot of incoordination, instability, and gait impairment. She was not very cooperative because of her baseline cognitive impairment, but you can see we're trying to ask her to walk on a straight line and she was unable to do so, and she appears wobbly. Besides that, she had microcephaly. There in the history, there was a clue that she had multiple episodes of vacant stares. So when any child gives you that history, there are multiple episodes of vacant stares. What do you want? What instantly comes to your mind? Absence seizures. Sir, every case is a spotter to you. I may have to ask you not to answer. Okay, so that is an important clue. Remember, if you have a child who has neurological signs and there's a history of early onset vacant stares, then this could be an early onset absence epilepsy which you want to label, but there's nothing called early onset absence epilepsy. If you have this history, you want to look at the genetics, right? And this condition is important because it is treatable, and so the MRI is normal. The EG shows typical absence pattern. What is the important investigation? CSF glucose. Very good. So CSF glucose absolute value look less than 40. And the ratio? Very good. Everybody knows everything. The highlight is, what is the treatment implication? Why do you want to diagnose this condition early? Ketogenic diet. So you'll put the patient on ketogenic diet. So which are the conditions? So from infancy to later childhood, if you have unexplained epilepsy with underlying neurological issues, if you have untreated epilepsy, poorly responsive movement disorder, microcephaly, any combination of these, remember, GLUT1 is an eminently treatable condition, so that is why you should always exclude it. You may say that you are sending the whole exome and everything else will be excluded, which is a valid point, but still I would like to say that clinical diagnosis is fun. All right. Again, neurotransmitter disorders and the typical oculogyric crisis. I will skip this presentation. So now coming to slightly older children, you know the prototype disorder, treatable disorders would be Wilson disease, mitochondrial disorders. Now among the organic acidemias, the ones which you have seen which will now hardly come like a sudden presentation. So when you see, let's say when you have an 8-year-old child and you want to think of propionic acidemia, you will know instantly that this child probably has problems in infancy. But there is one disorder which you should remember is MMA, which can mimic a multi-system disease and can come later also. So even in older children, the one organic acidemia I would like to allude to is MMA, and the second one is of course biotinidase deficiency. And just like intermittent MSUD, there are intermittent forms of urea cycle defects, which now can trick you. So remember, urea cycle defects, especially like citrullinemia, are the ones which you should keep in mind in your older patients. So everybody knows typical presentations of Wilson's disease. This is just one atypical, slightly atypical. This child had choreoballistic movements at presentation instead of just having frank progressive dystonia. So she was Wilson's disease. Everybody knows that this is a treatable disease. Now the second group of disorders is this combination. So remember 3 metabolites, B12, homocysteine and methyl malonic acid, and the various combinations which lead to either classic homocystinuria, MMA or MTHFR deficiency. So you can have movement disorder, that is not the typical presentation. Everybody has seen this presentation in infancy, which is related infantile tremor syndrome, which can again have a combination of dystonia, EPC, tremors, dystonic tremors, Batwing type of tremors, but the clue will be in the general examination. Yes, sir. Yes, sir. But I want to say that when you have a child like this child can also have an underlying MMA, which means just an inherited B12 defect. So you are giving B12. Yes, so differential diagnosis. And so when you have B12 deficiency, you should also look at 2-3 more metabolites. One is homocysteine, second is MMA. So if your homocysteine is in these ranges, if your homocysteine is crossing hundreds, then probably you're dealing with classical homocystinuria or MTHFR. When your homocysteine is like 200, 300. When your homocysteine is little less, then probably you are having a combined effect of, this is called MMA, but it will have a combined MMA and homocysteine pathway. So just remember to check these 3 metabolites together. Yes, which is 4th metabolite, which people don't get to look at because TMS is not available everywhere. But yes, if you have an encephalopathic patient, methionine can really play tricks. So I just didn't want to confuse everybody. But remember, you look at B12, MMA, homocysteine, and methionine if you can, because you may have differential symptoms. And don't think that MMA can't be walking into your OPD. So we have seen older children who will come walking, who will have first presentation later. So again, you'll have to look at the conglomerate of symptoms rather than just focusing on one aspect or one movement disorder. This was one child who had some infantile onset problems, some transient dystonia, had become paucisymptomatic, only had poor scholastic performance for several months, and now doesn't have a movement disorder. Don't look too closely for a movement disorder. He has peripheral neuropathy now, so he's walking with this stomping gait. He doesn't have movement disorder, but the history had a movement disorder, and he has underlying intellectual disability and a normal MRI. Enough clues to make you think that I can be IEM. If you look at the basic metabolites, you will have a clue towards treatment. Why I'm repeatedly saying this? Because the treatment of classical homocystinuria and MMA is entirely different. If you will only look at homocysteine and this patient, you will have high homocysteine, and you will only give betaine to control homocysteine, and you will be wrong. If you don't look at the MMA, this could be a MMA and homocysteine combined elevation, which then becomes disorder called MMA, and in that case the treatment is lifelong supplementation with hydroxycobalamin. If you don't give that, the patient is never going to improve. So just small things which you should keep in mind. And why am I highlighting again? Because they have small treatment implications. And of course your answer could be that, okay, whatever it is, 6 weeks later I'm going to have a genetic test and then I'll be wiser, which is also true, but then the fun is lost. So the clinical presentations, you are well aware of the early infantile encephalopathy presentations. Remember, these disorders, now we have more survival, better management, so they come later on with additional movement disorders. It is very difficult to say that this patient has this type of movement disorder, so he is going to have MMA, he is going to have CBS deficiency. No, it is very difficult, at least to us. All right, so last 1 or 2 cases. So this was a 15-year-old boy, again symptomatic from before, since 4 years of age, when he had slowly progressive ataxia. He had then motor regression, then stabilized, and then continued to achieve a plateau. He did not have much cognitive regression initially, and his MRI is actually the clue. So with this ataxia-like presentation and this MRI, what could be your possibility? If somebody has read about metabolic signatures, that is there. So when you see this MRI, this is not like your propionic acidemia, not MMA, not CBS. At least tell me what it is not, or what it is unlikely on MRI. So in a 15-year-old child, if you see this MRI, which resembles like an infant MRI, every white matter in the brain is white, then probably you're looking at diffuse white matter abnormality, which is going up to the subcortical U fibers, right? So Canavan is also a possibility. Canavan could have been there. So this patient has L2-hydroxyglutaric aciduria. Canavan is a closed differential. Mitochondrial respiratory chain would also be a closed differential, but they will have additional features. So when you have diffuse MRI changes in the brain in a patient who's walking with ataxia, these 2-3 differentials are of this MRI picture. So one is L2HGA, the second is Canavan, and the third would be mitochondrial respiratory chain. Of these, the treatable ones is, partially treatable one is L2HGA, because at least you can offer high dose riboflavin treatment. For mitochondrial, you can offer the cocktail. For Canavan, you can't do much. So movement, coming to this last group, movement disorders in mitochondrial disorders in older children. So obviously hyperkinetic movement disorders are in general more common, so they are also more common in children in mitochondrial disorders. And the most common ones in older patients, you see probably cerebellar ataxia. In our children, we see more common is dystonia. So this was a series that we were working on. I'll quickly show the clinical videos and the images. So when we were looking at the children who had mitochondrial disorders in our cohort, we saw that the infantile onset presentation, which is a typical Leak's disease, is all that we are familiar with. There is a second presentation of childhood onset progressive dystonia, whereas children are normal till 7 to 8 years of age, and then they start having this sudden onset movement disorder. So they have progressive dystonia, rigidity, bradykinesia, Parkinsonian phenotype, and this all is progressive till you start supplementing them. So this was this girl who was completely well till 8 years of age, and then she started having progressive dystonia, bradykinesia. Spasticity will also come, as is very obvious with mitochondrial disorders. They will not just affect the basal ganglia, but this is a prominent movement disorder phenotype. So this was another boy who had this typical dystonia, and as I said, sometimes they can have prominent ataxia also. So he had more of incoordination, a wide base gait, some oculomotor abnormalities, and all these had these typical changes. So sometimes they have these cystic changes in the white matter, which is the definitive signature of mitochondrial respiratory chain disorder. So we use the term of cystic leukoencephalopathy. When you see cysts in the periventricular white matter, small, large, confluent, the mitochondrial respiratory chain disorders is one thing you have to exclude. So the first girl had these cystic changes in bilateral putamen and one cystic lesion in the caudate, and the typical signature was there in other patients. All right, so this is probably the last case. So this was a 13-year-old boy who had been symptomatic since infancy. So initially he had fever and seizures. There was some history of intrauterine growth restriction. Then over the years, seizures became infrequent, but he had marked intellectual disability and he could never go to school. He had speech and language disorders, and over the time, he also started developing poor eye contact, behavioral abnormalities, stereotypic. So this video will just show his stereotypic behavior. Some appear like tick-like movements, and he has a lot of speech and articulation problems. So basically, overall, his diagnosis was intellectual disability with ASD-like features, which is autism spectrum disorder. Now, you can choose to ignore that, okay, this child probably has autism spectrum disorder and he is diagnosed late, or you can try and look at the subtle clues. So in his case, his MRI was showing these non-specific white matters hyperintensities in what we call as terminal zones of myelination in an older child. But the MRS is very important in such cases. So this is another important cause of GDD, IDD, ID, ASD spectrum. So one we read was phenylketonuria. The second one is this condition. You should keep in mind because it is treatable and better if you diagnose it earlier. So what are we trying to show you in MRS? Sorry? See, there are 2-3 things only we try to show you in the MRS. One is the lactate doublet, which you see is the inverted W shape, right? So if somebody is showing you MRS, common sense says there are only 2-3 conditions they are trying to show you. So one is presence of lactate doublet, which is not there. So lactate doublet will come somewhere here. It's not there, so I'm not showing you that. NAP could be there, but then the MRI is not like Canavan's. what I'm trying to show additionally, you see here there is a creatine peak. So there's an attenuated creatine peak. It can be absent or it can be attenuated. So this is the third important thing you should answer when somebody is asking you in your exams about MRS. So what we are trying to tell you here is that the absence or attenuated creatine peak on the MRS is a clue towards cerebral creatine deficiency disorders. Genetically, there are 3 types. It is an eminently treatable condition because creatine is available to be replaced. So you can give creatine. Unfortunately, this patient is quite old, but if you diagnose early, you can supplement creatine and reverse some of the features. So last few slides. When do you suspect an underlying neurometabolic disorder in a movement disorder? It is same. When you suspect a neurometabolic disorder, same is the principle when you suspect a movement disorder additionally, right? So when there's an underlying diffuse clinical picture with a lot of neurological signs, when there's a combination of different types of movement disorders, acute, subacute onset, presence of triggers, or in a chronic patient, there's insidious onset or evolving symptoms, which is pretty much a setting when you think of IEMs. Specific clues, if there's consanguinity, if there are distinct MRI signatures or distinct metabolic signatures, then there are instant clues towards the underlying etiology. So the take-home message is movement disorders are common, they are important, it's a niche area and it is very nice, but I would still stick to my statement that in children, especially the young ones, movement disorders will hardly come alone. You should tune yourself to looking at the bigger picture. Look at everything and not just movement disorder, because children hardly come and say that, okay, I have creatine deficiency, I have this and I have this. And often you are left to make a sense of so many things at the bedside. So, and that is the fun. So remember, movement disorders are important. They are sometimes clues, but your bigger underlying clinical picture is always, always much more important. But yes, treatable ones will be far and few, still very important, and you all missed BT, BGD. So that means we can still talk about it in one more session. All right, so this is the last spotter. I will request sir not to answer, and I'm sure everybody else will answer. This is a very young age, so that is why I just kept this video. Tell me the phenomenology, and then it's a treatable condition, so tell me the treatment. What you see here is erratic myoclonus. So what appears here is like an erratic myoclonus. So sometimes there's a jerk in the upper limb, sometimes it's in the lower limb, and we can also go to so many genes, which Shayoni nicely told us about, but we'll just wait for one more minute, right? So he was thought to have erratic myoclonus, came after birth, came to the emergency, was put on oxygen, thinking that these are so many seizures. And let's say you give 3 anti-seizure medications, and still your patient is keeping this. What are the 1 or 2 things that you're going to ask? One thing you should see, whether this is happening only during sleep. Second important thing, whether this is happening only with stimulus, because this is not pyridoxine, this is benign sleep myoclonus. So if your patient has this only during sleep, the simple bedside treatment is you awaken the patient, ask the mother. When she awakens the child, does this disappear? And otherwise the baby appear normal. Secondly, there should be no exaggeration or no elicitation of these with stimulus, because then you are trying to exclude hypereplexia also. So these are 2 common mimics which are easily treatable, not truly metabolic disorders, but if you see a neonate with these are 2 things which you should exclude. So benign sleep myoclonus, trust me, they get admitted for treatment of refractory erratic myoclonus. So it happens. So 2-3 things that you should ask. The patient may be very sick, may have an underlying severe genetic condition, but if your patient appears slightly well, you should ask these 2-3 questions at the bedside, because the neonate, the smaller the baby, the more difficult it is. So this was a case of benign sleep myoclonus. The only observation mother had made is that I see this, I tickle the baby, he wakes up and it is gone. You give more phenobarb, more deep sleep, more movements will come, right? And then they can appear sometimes as stonic movements, myoclonus, etc., etc. This was the second baby with hypereplexia. So you can see the stiff baby. Once he has the stimulation, he becomes very stiff. So he's stiff like a board. See, the grandmother is only holding the baby with the head. And the simple bedside test is, when the baby is not crying, you can give the glabular tap, you can give this tap, and you see the non-habituation. So the startle is non-habituating. So that is the clue that this is probably hypereplexia and not anything else. The simple treatment is clonazepam. And you can also make a genetic diagnosis, because they may have manifestations later on. This I will probably skip, because this is not a treatable condition. This is an infant with regression after a febrile illness and has So what we are trying to do here is auditory stimulus, loud auditory stimulus, and he again has a non-habituating startle. So in an older child, the startle has to go. As you become old, your habituation has to come in as a part of normal brain maturation. But if this comes in any child who has had a regression, this is a clue towards degeneration in the brain. Degeneration means Tay-Sachs. So any of the storage disorders where true neurodegeneration is happening. So when the neurons are dying, they'll start manifesting as some of these abnormal behaviors. One of them is startle. So in any infant with regression, if there is a history or examination of abnormal persisting non-habituating startle, you should look for fundus. There may not be organomegaly in Tay-Sachs disease. So you may go wrong at several places. Remember, the MRI will be second clue, but that probably we can leave for radiology. So another important bedside sign. Infant with regression, look for non-habituating startle. Thank you.
Thank you, Dr. Arushi, for a very illuminating talk, and I should say that our audience will be get benefited that there is so much of treatable conditions are there, because mostly we see movement disorders are not treatable and not, I should say it's curable. If you go on treating, the symptoms will not recur again. So without wasting time, may I ask some questions from the audience? Or any comments?
Comments is fantastic.
Yes, that's good.
Thank you, sir.
So big hand for Dr. Arushi. Thank you for coming and delivering such an information.
Thank you. Yes, sir.
Yes.
Thank you, sir.
May I please request Dr. Bhaskar Ghosh sir to give the memento to Dr. Arushi Sami.
Yeah, so we'll break for lunch. Because of the shortage of time, we'll be joining here at 2 o'clock. So you can take your food, you can wait outside, or you can grab it and come here also, no problem.
But we've come to understand that that underrepresentation will never change till we do something about it. So what about variant classification? That is where the laboratory steps in. What we need to do is sort out relevance from the noise. It's very easy to introduce all variants. And it's not very tough to get multiple variants when you have a diagnosis like intellectual disability, seizures. There are so many genes which are implicated. There are so many mutations which are not reported. And there are so many variants which are not very common in the population and nomad. What is more difficult is we are trying to look in the laboratory through your looking glass, meaning we've not seen the patient, you've seen the patient, and again, that is the importance of clinical phenotyping. A confirmed genetic diagnosis is when you detect a pathogenic or likely pathogenic variant, which is clinically correlating, associating with the appropriate zygosity, which is known in the disease, and in a gene where gene disease validity is established. I'll be talking about this later. Why is a variant called VUS? Because the American College of Medical Genetics laid down criteria in 2015 which have stood the test of time. They are blamed to be overcautious even by our own tribe. But what they say is very simple. Every variant is innocent until proven guilty. You take a change, you say that probably it could be serendipitous, even if it matches your phenotype, and then you try to find evidence in literature to try and see whether you can take it up to likely pathogenic or pathogenic. A pathogenic or a likely pathogenic variant will retain its classification irrespective of the clinical phenotype. So if I have a pathogenic mutation in Tay-Sachs disease and I find the same variant in heterozygous state, when I'm looking at a person suspected with primary immunodeficiency, that variant still remains pathogenic. There is no way that classification is going to change if it has been classified properly based on the clinical phenotype. And the most important point is a variant is good until you find a better one. Today, you might be really finding it great that we found a variant which was VUS in a rare gene with intellectual disability. Tomorrow, your patient might undergo a prenatal testing, but then day after, they might go into WGS and you might find a pathogenic deep intronic mutation. We've seen this happen in Col6 myopathy, where there's a common deep intronic variation which is responsible for 40% of cases. So as tests increase, improve, widen their approach, there's always a possible that something better is hidden in a nook or corner where you're not looking at. But what is the commonest bone of contention between the laboratory and the clinician? The variant seems to be clinically matching. You're still calling it a VUS. You're calling it a VUS, though it has been reported previously. Why? The American College of Medical Genetics says that all our clinicians who are ordering genetic tests are very good clinically. It is not at all surprising that you suspect a muscle disorder and I get a variant in a muscle-related gene, and so I call it VUS. What they say is, how unique is your phenotype? So if you have a patient who has seizures and he has an SCN1A mutation, is it enough to say that that SCN1A is damaging? Or if you have a patient who has adenoma sebaceum, who has ash leaf, who has cortical tubers, and you have a mutation in TSC1 or TSC2, what do you think is more unique of a phenotype where you'll have lesser differentials? So what the American College of Medical Genetics calls consistent with phenotype is that you have a phenotype which is so typical, so very specific that probably there are hardly any differentials. That is when you can say just based on the phenotype, we are agreeing to the fact that that variant is the sole cause of disease in your patients. So that is why I would like to explore the clinical relevance. So this is case 1, and I've not taken movement disorder cases. Microcephaly, developmental delay, a prominent nose. We found a homozygous missense variant in ASPM, a gene causing primary microcephaly. Case B, hypotonia, motor developmental delay. The diagnosis was myopathy. We found again a homozygous missense VUS in NEB, which causes Niemelin myopathy. Would you say that it is consistent with the phenotype provided by the clinician at least? Yes. Then why are they VUS? How do you change? I mean, it's easy to say we'll wait over years, we'll find another patient. It's very difficult. But basically, if you look at ASPM, there are hardly any missense mutations which are reported to cause primary microcephaly in ASPM. And this is a well-researched gene. So when you're talking about such statements, you also need to see how many patients have been described in literature. If there are only 4 patients, I cannot tell you that, okay, all disease-causing mutations will only be termination. There are too small a number of patients to pass such comments. But this is a well-read gene, a well-researched gene, and the consensus says that hardly any missense mutation in homozygous state can lead to primary microcephaly due to ASPM. The same is true for NEB. Nebulin mutations usually are not missense changes. If you look at any exome data, there will be one nebulin missense, there will be one TTN missense because these genes are very large. So they're going to have some variations. So it is probably this in-depth or slightly better knowledge of genetics that we possess when we get trained into medical genetics that makes all the difference when we say that I'm not interested in introducing that homo missense VUS and ASPM, not because I don't want to give you a report which has something, but because I feel it's not the disease in your patient. It's not the cause in your patient. You just have to look somewhere else. I'm not saying that your patient does not have myopathy. I'm not saying that your patient does not have primary microcephaly. Your patient probably needs more genetic testing. That's all that I'm trying to say. So why are previously reported variants sometimes called VUS? We often get calls. Your own report states that that this mutation has been previously reported in a patient, और आपने ऊपर table में VUS लिखा है. Why? Again, the American College of Medical Genetics forces us to think about serendipity. They are in love with this word. They say that you go back to literature, see what has been reported, see how well that initial case has been worked up. Has everything been done to say that the reported mutation, without doubt, is the reason for this disease? And we have learnt it the hard way in genetics. If you look at ClinVar, the publicly available database for variants, this was a report published in 2020. 40% of pathogenic and likely pathogenic variants were downgraded. And it's very common in the genetic community. Rather than upgrading variants, we are actually downgrading variants because we have realized that a lot of them are much more commoner than what we thought. Now, the biggest disturbing portion here is the term that variants were pathogenic also. Pathogenic literally means that the classification should not change, meaning that at the initial portion of all genetic testing, probably as geneticists also, we were only learning. As collaboration grows, as more and more information is out there, we have understood that we will just have to keep on revisiting variants. And this is very important, especially for neurologists, because I've seen families that when they get pregnant, it's very difficult to convince them that before you enter the obstetric clinic, go back to your primary doctor. Ask them to review your phenotype. Ask them to recontact the laboratory. Ask them to see whether the VUS is worth prenatal testing. Rather, what happens is we get an amniotic fluid for a VUS testing and we really don't know what to do. We just release a report saying that, reproductive decision making is not recommended. But it's happening right, left, and center. So I think that is something that even as medical fraternity, you need to communicate with your obstetric and fetal medicine clinics before putting the needle. Just reconfirm what we said probably 3 years back. We ourselves will be refuting when you ask us again. So this is a case with 2 children, seizure, severe global developmental delay, and undefined abnormal dystonic-like movements in the daughter additionally. Now, when we did a whole exome, we found a homozygous variant of uncertain significance in a gene called TBC1D24. If you look at OMIM, there is a host of disorders associated with TBC1D24, including deafness. Now, they say it's a phenotypic continuum, except, of course, the autosomal dominant kind of deafness. So, as you looked at the pedigree, we first did the brother. So then we advised segregation analysis. So the clinician got the affected sister done. She was also homozygous for TBC1D24, and they tested the parents. The parents were heterozygous carriers for this autosomal recessive gene, which can explain epileptic encephalopathy. Can we reclassify? Or are we missing a limb still? I think you can think about it. I don't want to give the answers. We can always discuss it later. This is the main concept that I wanted to introduce. We're just making life complicated for everyone. We first gave you VUS. Now we have a new term called GUS. This was introduced by ClinGen, which is another body similar to American Medical College of Genetics. So what they say is, before you classify a variant, first make sure that when literature said that this gene was associated with this phenotype, how robustly was it associated? Was it seen only in one patient? Was it seen in more than one patient? Were those patients related? Are publications duplicated? They did happen very commonly earlier. So this is a patient who came in with a consanguineous patient, 11-year-old, ataxia, MRI brain, showed cerebellar atrophy. And what we did was, in consanguineous, the onus is much more. You keep on hunting because you want a homozygous variant. And consanguineous, when we send out negative, it's really, really depressing because the clinician also says, there's a recurrence risk of 25%. We understand. So there was this homozygous termination mutation in a gene called TSPOAP1. Let's not talk about the gene names, but basically when we search literature, there's just one article which describes 4 unrelated individuals from 7 families, and they say that biallelic variants cause dystonia. They were very specific in mentioning that cerebellar atrophy was observed in those patients, but none of them had features, none of them had cerebellar symptoms, all had dystonia. Now, you can always argue that it's very well known that one movement disorder gene can cause another movement disorder. There's a lot of phenotypic overlay. Can we just go ahead and call it disease causing? I mean, it's a eureka moment for a lab when you find something which is so rare. There's only one publication. It's a eureka moment for the clinician. Probably you've diagnosed the family. How long will we keep them waiting? The ClinGen says that no, wait. You just can't put 2 and 2 together. Currently, at least for ataxia, this is a gene of uncertain significance. There are absolutely no patients in literature with ataxia. So it can only be reported as VUS. All variants in a gene of uncertain significance remain variants of uncertain significance. And so is the case in a lot of movement disorders, including Parkinson's. So there's a huge panel, expert panel set up both by ClinGen as well as the Movement Disorder Task Force, where what they are doing is they are painstakingly taking literature and gene reports in literature. They say there are 80 genes implicated in Parkinson, but most of them have been reported only once. Is this purely by chance, or is there something hidden? Is there oligogenic inheritance, etc., etc., etc.? Or can you just say that, yes, now you widen the panel of Parkinsonism, push all 80 genes, and whenever something comes out, of course your patient has Parkinsonism. I mean, when Dr. Ganguly sends a patient saying, query Parkinsonism, I am not in a position to question him. He is an expert. So if I get a gene among those 80, can I just say that is the diagnosis done? No, they say, wait, you'll have to establish gene disease validity. Prove that these genes have been reported repeatedly in patients with Parkinsonism. They were not observed by chance, and only then you can take the classification above the notch of VUS. This curation is going hand in hand with the Movement Disorder Task Force, and they have a beautiful paper published, I think it was 2 years before, which talked about genetic nomenclature of genes in movement disorder, where they talked about curating gene disease validity in Parkinson. So I would end by saying the cautious seldom err, but again, the policy of being too cautious is the greatest risk for all, and that is where the laboratory plays a role. We play that small gap. There's a huge difference between diagnostic and research reports. Diagnostic reports are very, very limited to the knowledge and to the current scientific evidence. Mouse models cannot go into diagnostic reports. So if you're doing a research study and you do take a diagnostic report, don't be surprised that when you take the raw data, there are multiple other variants lying there which we have not reported. We cannot report. It is not allowed for a diagnostic laboratory. Thank you.
Thank you, Dr. Udaya. That's wonderful, and that's very practical, I would say. There's a link between clinicians and lab. And we'll take up the questions together after Dr. Vikram speaks. Next speaker is Dr. Vikram Holla. He's Assistant Professor of Neurology in NIMHANS, Bangalore. And he will be talking about how to approach once the gene test comes negative or VUS. And that's the bane for everybody. We think that we are near diagnosis, we send the test, it's either negative or VUS. After that, the road is blocked. So Dr. Holla will tell what to do further.
Good afternoon, everyone. So at the outset, I would like to extend my thanks to Rishikesh sir, Jackie, and Yashodhara, and all the organizing team for giving me this opportunity. And I presented a similar topic in AOPMC Kolkata, so if you have attended that, it may look very similar to you, but there are some different cases as well. So as sir told, it is always, I mean, like when you send a genetic testing, we will always be waiting for final diagnosis. Like there is no test beyond this. This is it. And let us, I mean, at least not only for us, for the family also, the patient also, that the clarity is very important. Even if it is not treatable, curable, still to know what I have is always sort of one of the most important reason why patients agree for genetic testing. But when the report doesn't sort of come as we expected, again, I mean, more tests, and we cannot give the clarity to the patient. It will sort of add to the burden. I mean, not only the therapeutic, but also the diagnostic burden as well. So coming to this, I mean, so it is not very different. I mean, when we send a genetic testing, we get a VUS, we get sort of flustered. But then if you see in a patient of syncope, if you get remote history of febrile seizures, it is also a finding of uncertain significance. So these are all, I have listed out quite a few. You can see uncertain significant findings are, a norm in our practice. I mean, in any clinical this one, that there are various other things that we may ignore, or we may decide that it is not of significance. We'll wait for it, let it, evolve, or maybe we'll say that it is unrelated to the illness that I'm sort of managing currently. So just because, we get VUS in genetic reports, we shouldn't be sort of flustered and say that something is wrong, or we have done something wrong, somewhere else someone has done wrong. I think these are all day in, day out, experience. It will happen. Nobody can run away from the VUS. Just a brief, this one's because it is very important to understand what all the variants. So it is, the variant is the preferred term because mutation, the connotation is it is something abnormal. So all the mutation is just a sort of changes, but always we assume it as abnormal. And as Dr. Udaya told, a variant is benign unless proved otherwise. So, I mean, in the sense, it is not a sort of a pathogenic one. So, that is why we don't want to, when we say a variant, it is still not decided whether it is actually pathogenic or not. So, instead of the term mutation, it is preferable to use the term variant. So, we are still undecided. So, with that aspect, there are various variants in the form of synonymous when the change in amino acid does not happen despite a change in nucleotide. There can be missense where a different amino acid is substituted. There can be splice site variants in the plus or minus 2 next to the edge of the exons, exon intron boundary. And also there can be nonsense of the stop gain when there is a premature termination of codon because of the amino acid is changed to a stop codon. Or there can be large indels or smaller indels also. If it is multiples of 3, it will be in-frame deletion or insertion. If it is not in multiple of 3, then it will lead to a frame shift and premature truncation of protein. And also there can be large structural variants, and these are the ones usually may get missed in whole exome sequencing or the next generation sequencing. But there are various pipelines which can pick up these things also, but they depend, I mean, the accuracy may be less compared to the SNVs that we get to see. So, coming to the variant of uncertain significance, basically there is the circle is not completed. So, there is something mismatch. There is either a phenotypic genotypic mismatch can be there, or the current knowledge is insufficient to say a variant is pathogenic, or there is insufficient information regarding the variant. It may be a novel variant. We don't know what it does. I mean, nobody else has identified this variant. It may turn out to be pathogenic. It may turn out to be benign. But currently, we don't have sufficient evidence to say either way. Or it may be a type of genetic testing that is wrong. I mean, as Dr. Udaya told, if I get my genetic testing, then there may be quite a few variants of uncertain significance. There may be quite a few pathogenic heterozygous carrier state also. So, just because I have some variants, it doesn't mean I should be affected. And if I have not sent the correct test, there may be some other genetic abnormality which may not have identified with NGS, and I may be wrongly labeled as some other disease altogether, where I will be discussing these cases in the later part. So, I just skip this. So, why is it perceived as a menace? So, as I told already, what next? Many times we know we have to send genetic testing. After that, what to do, we may not be very well aware that what to do with the report we get. So, that is always a sort of how to approach is always a sort of a conundrum. And when we get a VUS, we don't know whether it is actually genetic. Sometimes we may be thinking it is genetic, but still not ruled out, acquired completely. Again, the dilemma continues, and lack of diagnostic clarity, and often thinks the genetic testing is even when you send the test, the patients think this is the final test. I'll know everything after this. So, when we tell the patient it is still not clear, so there is still a sort of uncertainty is there, then sometimes the patient and the family may lose hope in us that we don't know how to diagnose. So, it is very important to inform to the patient before sending the genetic testing the realistic possibility of having a VUS and not getting a diagnostic confirmation. And others are like additional financial burden, because each of these tests cost a lot, and it is not available everywhere, and sometimes it is just available on research basis. And if at all we have a VUS in a probably treatable condition, and the treatment is quite costly, so the patient will always be in the family will also be in dilemma whether to go for the treatment, because they will like for instance Dr. Rishwadhara asked one question regarding the PRRT2. The patient will read and come, this gene was identified, this treatment is there, why are you not giving it? So, sometimes it is difficult to explain to the patient that this is a VUS, we don't know what it is, we don't know whether it is pathogenic or benign, we really don't know. And when we say we don't know, sometimes the patient may not take it well. So, we have to understand that VUS is one of the most important finding that you can get in the genetic testing. So, as you can see, there are so many, I mean the most, especially with respect to the missense, more number of VUSs are there compared to benign and the pathogenic. So, it is a reality. So, I mean you will, if you are sending genetic testing, you will get more VUS than a positive or maybe a negative report. And it is same across the neurological disorder, also beyond neurological disorders also. As you can see, around 42% had pathogenic, whereas around 31% had VUS in this pediatric movement disorder study. And there are 33% VUS in our study, in another study. And again, same, I mean, in one of our dystonia cohort, we had around 24% pathogenic, whereas 24% VUS. So, VUS will be there. I mean, so we have to know how to tackle it. And this is also same with cancer and various other disorders as well. So, as Dr. Udaya was mentioning that when test is sent, so there will be a lot of variants. Based on the clinical phenotype, some of the variants will be considered of some relevance, and they will be prioritized and reported as whether it is of some significance to the clinician or not. Sometimes we cannot elect any report for that matter. When we send for a nerve conduction study, there will always be correlate clinically. The findings will be given, they may not have given the exact report because we don't know in a given clinical context how important that particular finding may be. So same way the variant also sometimes VUS is reported to tell us that there is something, you see whether it is clinically relevant or what you can do further so that to either make it, look whether it will become a pathogenic or likely pathogenic or maybe a benign or likely benign based on further tests. And as you can see, the more wider the test, like for instance, whole genome sequencing will give you a lot of variants of uncertainty. Some of them may be pathogenic variant of not relevant to the clinical presentation, may develop in the future. And same way, if we go for a targeted variant, we know that variant is pathogenic. That is why we are going for a test. So VUS doesn't happen. But if we send whole genome sequencing, more than 1,000 potential VUS can be there. So if you are sending whole genome sequencing, be prepared that you are going to get a lot of VUS. Maybe it may confuse you more than helping you sometimes. So you have to be prepared for that. To improve, to make us understand, we all clinicians go by criteria. We want criteria, we want guidelines, wherever. If we have criteria, we are a bit confident that, okay, maybe what I'm diagnosing, if it is fitting into the criteria, more likely that my diagnosis is correct compared to it being wrong. So same way ACMG gave a guidelines, how to prioritize variants, how to classify the variants. And just briefly to introduce, there are 4 different pathogenic divisions. Like supportive, there is very strong pathogenicity, only one criteria is there where there is a truncation of protein. That too, only those variants in a gene we know truncation can cause a disease. There are various autosomal dominant disorders where truncation will not cause any problem at all. For example, Alexander disease is one such disease where most of the variants that have been reported missense, because the missense mutation gives to a gain of function mutation, it causes fibrils and causes the disease. If there is a truncating mutation, although we feel that any frameshift mutation, truncating mutation should be pathogenic, but in certain diseases, truncation will not cause any problem at all because the other allele is normal and takes on the work without any hindrance. So we have to know if a gene is actually can cause a loss of function, truncating mutation can cause a disease or not. Then only we can apply this first criteria. Then there are strong pathogenicity 4 criteria like different nucleotide, but same amino acid change has been reported previously in a different study. Or established de novo. De novo in the sense, a heterozygous variant is identified in the patient, whereas the parents are not carrying, both the parents are not carrying this variant. So it has originated in the index patient only. So that is called as de novo. And we have established the paternity. So then it will become PS2, other it will be only moderate pathogenicity. Then are there any functional studies for this particular variant? And also case versus control studies that suggest that variant is quite frequently seen in the cases compared to the controls. Then there are moderate pathogenicity and supporting pathogenicity. So based on particular variant, what all criteria are being satisfied. And same way we have for benign classification also. And the permutation combination of these various findings will tell us whether a particular variant is pathogenic, likely pathogenic, VUS, benign or likely benign. So for instance, if there is very strong criteria, along with that, even if there is one strong criteria, it will become pathogenic. So if there is 2 moderate criteria additional to the PVS1, that is very strong criteria, then it will become pathogenic. So that way, it is again a combination of earlier set criteria will tell us whether a particular variant is pathogenic, likely pathogenic, VUS, benign or likely benign. And these all, can be classified into these attributes can be classified into different groups. Like for instance, with the population data set, PM2 means that variant is very rare in a normal population. So then they will give PM2. Nowadays, some of the genetic labs are giving you these criteria also. You can see many of the variants, VUS may be just PM2. That particular variant has not been reported in any other population in India, Asian population, or is very, very, very rare in a normal, assumed to be normal population. So same way there are multiple other attributes. So when I get a report, so we have to step back and see, analyze that report in the sense that variant I have got. So this variant, how strong the variant is. Just because it is a rare variant, we need not go and do all the other further tests. We have to see that particular variant, is it matching the phenotype, and also that phenotype, as Dr. Uday told, how unique is that phenotype. If I get, like for instance in PD, if I get one VUS in maybe VPS 35, that is one of the autosomal dominant Parkinson's disease, so far only one variant has proven to be pathogenic. Other variants have not been proven to be pathogenic. I get one variant in VPS35 gene. PD has so many genes, so it is very sort of a non-specific clinical phenotype. Just because I got a variant in VPS35 that can cause a disease, and this patient has PD, that doesn't mean that it is a high probability. So very likely it is going to be VUS or benign only. If we have a measure, like there is another family member affected with the same phenotype, then we can see, test in that patient, segregate and see whether it is going to change anyway or not. Otherwise, we cannot, go ahead. We have to accept that at current condition, it is still going to remain VUS, and we can do nothing about it for now. Maybe in future, some other studies can come which can check the functional status of particular variant, then we can change it. And also as she told, in a autosomal recessive disorder, even if you get a pathogenic variant in a particular gene, it will still be a carrier state. So unless we are strongly considering that particular gene gene causes, like for instance Wilson's disease. If I get a pathogenic variant heterozygous carrier in a ATP7B gene and the phenotype is Wilson's disease, there has to be very likely another variant sitting somewhere which I may have to look for. If it is just one of the 100 genes that can cause the phenotype and one pathogenic variant is there, sometimes we may not be able to, it may just be a carrier state and we may not be able to identify a second variant. It may not be there, or it may be there in the deep intronic. Current sort of a technology may not be able to, or we may have to send the patient for WGS. It all boils down to how strongly you are suspecting clinically that particular gene can be the reason for your phenotype. So anyway, whenever variant, so go back to the clinical phenotype. Is it matching to the gene that is abnormal, identified or not? Are there any investigations? Say for instance, there is a neurometabolic disorders. Are there any enzyme estimation which can sort of give me a better confidence in saying that this patient is actually suffering from the particular disease? And population database, you can go back to the publicly available database and see this variant has been identified either in the normal population or in affected patients. Also literature and annotated database. So usually nobody can be 100% up to date. Sometimes the labs may not be up to date. Maybe just yesterday one report has come, the lab may be up to date for a month before. So once you get the patient, it is easier for you to go back to the literature and search. For a lab, it may be very difficult to process so many samples. But for you, there may be very few reports, very few patients where you can spend extra time and see, is this variant recently has been reported again. Also, tissue and function studies most of the time is beyond our reach. Only on research basis, most of the things can be done. Family pedigree, we can again ask, are there any similar family members affected? What is the pedigree? It is autosomal recessive inheritance or dominant type of inheritance. Consanguinity is there or not? Or in the near geographical area, are there any other affected patients? And also, so these all sort of input will help us in deciding whether a variant is still a VUS. Can it be more likely? Can it look like a pathogenic? Is it advisable to do further tests? Or the probability that it is being pathogenic will be less likely. No point in evaluating further. So as I told, there are certain things that we can do at our level, clinicians level. Like for instance, if a patient, we have a heterozygous variant in a autosomal dominant disease, and the parents are unaffected, then we can get a Sanger sequencing in the parents, establish it is de novo. If it is de novo, the criteria of pathogenicity will increase by one criteria, that is PM2. That will not label it as pathogenic, but along with the other finding, it may shift to pathogenic or likely pathogenic. Same way we can see if it is compound heterozygous. So these are the, when we say segregation, if the affected family members, 2 people are there, both of them carry this variant and the unaffected family members doesn't carry this variant, then we say it is segregating with the disease. Same way cis or trans. If there are 2 variants in an autosomal recessive disorder, both are heterozygous, we have to establish that one variant has come from the father and the other variant has come from the mother. Then only both the alleles are affected, like for instance in this, and it is a biallelic. When we say autosomal recessive, we imply it is biallelic disorder. That means both the alleles are affected. So for that, again, we can do a Sanger sequencing in the parents, and if one variant is in father carrier and one variant is in the mother carrier state, then you can establish it is in trans state. That again increases the likelihood of it being pathogenic, but alone will not say it is pathogenic. If both the variant comes in one parent only, then it is in cis. That means the other allele is relatively preserved and should be able to, should be normal. So it is unlikely that this particular, only these 2 variants is causing a disease, or either these particular variants are not the reason for the disease that we are evaluating, or there may be another variant that we have missed. So these are the possibilities, and the decision can be made only based on the clinical suspicion. And de novo, as I told, if a patient has a heterozygous variant, check in the parents. If the parents don't carry the variant and they are asymptomatic, then we can say it is a de novo variant. So with these criteria, at our level, we can plan and send the Sanger sequencing. And then there are other things we can talk to the geneticists with regard to the population database. How rare is that variant? How common is that variant? You can also do with the publicly available database. If you are not well versed, then you can ask the geneticists also these questions. And what about the, different, like, are there similar variants described? Similar variant with the same amino acid but different nucleotide? Maybe different amino acid at the same location. So all these things can be sort of looked in the literature, publicly available database, and understand the variant better. So for these, so these criteria are very difficult to remember, apply. So there are publicly, websites, the Warsome and Franklin. So these are the websites where you can put in your variant details. It will give the interpretation is, it is not always perfect, but at least rather than, if you cannot remember, I also don't remember all the criteria. I'll just put in the Franklin and see what are the criteria that is being satisfied, and just take a quick look that is it appear correct or not. Franklin is completely free, whereas Warzone you have to have some subscription or institute ID to log in and use it. So, and similarly there is Genomad. Genomad is a publicly available database to know a particular variant occurrence in the normal population. So Genomad is, they have identified, tested in normal population and see this variant, what is the frequency of a particular variant. We have to understand that this is assumed, sometimes if the particular disease happens at the later age, and the person may be carrying this variant, may be asymptomatic at that point of time, but later may develop disease. So we have to always use this database with understanding. So Genomad database will give us that variant, how frequent is in normal population. If say in 0.1% of the population it is found, then it is 1 in 1000, it is found, and in an autosomal dominant inheritance, if 1 in 1000 of the normal population carrying this variant, that cannot be pathogenic. 1 in 1000 will be having this disease. So that means it is a more likely a benign variant. So likewise, if a autosomal recessive variant is found in homozygous in a normal population, very likely the patient should have got a disease. That patient cannot be normal. So if it is found in homozygous state, autosomal recessive variant, more likely we take it as probably benign. But again, single criteria will not sufficient to label a variant as benign or pathogenic. So there is also, we are very interested in scoring. So there was one more update in the sense of we can score. Even in the VUS, there are certain VUS which are sort of leaning toward pathogenicity. There are certain VUS which are leaning toward benign. So, and as you can see, when we say likely pathogenic, more or less sometimes it means that 90% of the time we are correct. Sometimes it may be wrong also. When we say it is pathogenic, 99% of the time we are more likely correct. There are instances, as Dr. Udaya told, that it is downgraded also. So it is not always, 100%, but majority of the times this sort of criteria holds true. In a VUS, you can again put the criteria, scoring, and if it is as they have mentioned here, so it is hot or warm, towards the pathogenicity score, if that VUS is, then there is some, you can invest your time further and see what other tests you can do, family studies or segregation studies, or Sanger sequencing the parents, sending enzymatic tests, because very likely 1 or 2 additional criteria will push that variant into a pathogenic or likely pathogenic group. Whereas if the variant is very, cold, even if you identify 2 or 3 criteria, it will remain VUS. Very unlikely that you will be able to push it to likely pathogenic. So this is also one of the things that I do, that it is only one criteria satisfying PUN to 1 or 2 points. Very likely that I will not be able to push it across to pathogenic or likely pathogenic unless I am very sure that this particular gene and the phenotype is perfect match. There is no other reason for this phenotype, and there is no other gene for this particular phenotype. So then we can still go ahead, but otherwise if it is a sort of non-specific phenotype, then the colder the VUS, the less likely that it is going to be converted. So coming to the cases, just to see how, once the VUS comes based on the phenotype and the pedigree, what are the other tests that we can offer. So this is one patient with chronic progressive cerebellar ataxia, pyramidal signs, and MRI showed cerebellar atrophy. So patient was not a non-consanguineous parentage, and because cerebellar atrophy was there significant, Friedreich's ataxia was not the likely possibility. Otherwise, we should always send for a repeat disorder Friedreich's ataxia in this age group, with a cerebral ataxia, especially if there is areflexia and extensor plantar. In this case, we had sent for whole exome sequencing, and it revealed two variants of uncertain significance. One was homozygous TPP1, which can cause spinocerebellar ataxia recessive. That there is a spelling mistake. That is spinocerebellar ataxia recessive type 7. That is CAR7. So this is sort of fitting with phenotype. There is another variant in the SAMD9L which causes heterozygous. It is a heterozygous variant, dominant disorder, which can cause CAR14. So both can cause ataxia. The recessive disorder is a homozygous variant. The dominant disorder is a heterozygous variant. So on the first look, both can be a possible cause for this particular phenotype. So next we'll look at the variant. What is the criteria that has been satisfied? So both are novel. Both are relatively concordant with the phenotype. So once we apply the criteria, so this particular, so this particular variant is sitting in the important part of the polypeptide where the enzymatic activity is there, which can be identified by either putting in the Franklin or Uniprot website is there. So this is in a mutational hotspot, very important region of the protein. And then it is extremely low frequency in the general population in the genome. And also in silico predictions, you might have read SIFT, mutation tester, or polyphen. So in that also it was told to be deleterious. But even with these three, it will be still be a VUS. Whereas in the other variant that was there, only criteria that was satisfied, it is rare, that's all. So only one criteria was satisfied. So it still remains VUS. So what can be done next? So with respect to the TPP1, we have an enzyme, to look for the enzyme abnormality. So TPP1, enzyme was was in the lower level. Further confirming this, it is a very close phenotype. It is a TPP1. We are dealing with the ataxia that is because of the TPP1 deficiency, and the gene is also TPP1. So it will become very likely that phenotype fits perfectly. So that is what Dr. Uday was mentioning, that the phenotype has to be very narrow or very sort of up to a certain extent very specific phenotype. So that is why it became PP4. Whereas the other variant, we did Sanger sequencing in the parents. Father who was unaffected carried this variant. So it is not segregating. If this variant was actually a pathogenic, the father also should have got affected, but he is not affected. So this will downgrade the VUS into benign. In those patients where in those genes where there is incomplete penetrance, this can happen, especially with dystonia. But most of the ataxia genes are most often than not are fully penetrant. So in this case, the second variant was benign, the first variant was pathogenic. So finally the diagnosis was this was a SCAR7 because of the TPP1 deficiency. So when we have some enzyme estimation availability, like for instance, especially inborn neurometabolic, most of them, we can utilize them, narrow down the phenotype, and see that whether that phenotype can be explained by only 1 or 2 genes. And if there are like 3-4 genes that can responsible for this phenotype, the other 3 genes does not carry any variant, and only this gene is carrying the variant. That makes it more and more likely that that particular phenotype and genotype matches more likely. So with addition to the PP4, along with the other 3 criteria that were there, this could be labeled as likely pathogenic. So second case is again a pediatric ataxia with additional features of seizures, oculomotor apraxia. So because the oculomotor apraxia was there first decade onset, unlikely to be Friedreich's ataxia, we thought of in lines of AO or ATM like disorder. And with that in mind, although AFP was normal, with that in mind we had sent the whole exome sequencing, which revealed a heterozygous novel variant in the ATP1A3 gene, which can cause Kaposi syndrome, cerebral ataxia, osteoporosis, and forgot this one. So it was again uncertain significance. It is a autosomal dominant disorder, novel heterozygous variant. So just based on the variant, the knowledge that we have as of now, so based on the ACMG guidelines, again, as you can see, this is the exon that the particular variant is in, and this is from ClinVar on activating the missense filter. In this particular exon, so far reported all the variants, missense variants were either pathogenic, likely pathogenic, or VUS. There were no benign variants in this particular region. So this particular region must be a very important region. So mutational hotspot can be sort of mentioned. There are other criteria also, just to sort of make you understand what is mutational hotspot, what are the ways we can sort of come to understand that that particular region is important. This is one of the example. And then also this is another website, GRCS37, where we can identify the population frequency. You can also get the scores for SIFT and polyphen. So in this particular variant was not identified in the normal population of Asian, this one also, and both SIFT and polyphen predicted it to be deleterious. So PM1, PM2, PP3. So still one more at least possible pathogenicity criteria is required to call it as a pathogenic. What can be done next? So autosomal dominant disorder with a heterozygous variant, novel, parents unaffected. So when it comes to autosomal dominant heterozygous variant, you can go for a Sanger sequencing in parents. So to identify whether it is a de novo variant or not. If it is not a de novo variant, then still we are left with only VUS and it may be even downgrade. But in this case, in the Sanger sequencing, this variant was there in the heterozygous state, that is why it is double peak, whereas in the parents it was not identified. So this variant is a de novo variant. So de novo variant will increase the one more criteria, that is PM6. So with this additional criteria, it can be labeled as likely pathogenic based on the table that I had shown. So there are 3 moderate pathogenicity score, 1 possible pathogenicity score, which put together it will become a likely pathogenic. So if you are coming across an autosomal dominant inheritance gene and with heterozygous variant, it looks like it can explain the phenotype, then you can advise for a Sanger sequencing in the parents to establish whether it is de novo or not. So case 3, again a pediatric ataxia with pyramidal signs, facial dysmorphism, night blindness, retinal dystrophy, and ichthyosis was there with mirror movements and Vermeyen atrophy. So again, I'm just not analyzing the phenomenology much because I want to focus on the genetics. So the gene that was identified was SRD5A3, which is responsible for the congenital disorders of glycosylation 1Q. So phenotype more or less matches, and it is a recessive disorder, whereas we have identified 2 variants. So this is compound heterozygous variants. One of them is pathogenic because it is already reported previously. It is a terminating variant, a stop gain variant. So most of the recessive disorder, if it is a premature truncation of protein happens, very likely to be pathogenic. So this is a pathogenic variant, no doubt about that. There is one more variant, that is VUS. Unless we change it to pathogenic or likely pathogenic, we still don't have a definitive evidence that this can cause the disease. So as I told, the first variant was based on the criteria, it was actually pathogenic, previously reported also. Whereas the second variant, it was extremely rare. As you can see, again, I used the publicly available database GRCH37. You put the variant, it will give these details. So it is rare variant, not identified in the general population. Deleterious based on these in silico tools, but still. So next step would be Sanger sequencing. Again, we have a compound heterozygous variants. We have to establish that these variants are in 2 different alleles. So for that, we can go ahead for the Sanger sequencing of the parents. So after that, we identified that variant 1 was there in the father, whereas not present in the mother. Variant 2 was there in mother, but not there in the father. So this is the configuration that was identified. So one variant was in father and another variant was in mother in heterozygous state. So this configuration, we call it as compound heterozygous in trans. Whereas if both the variants were identified in father alone and mother did not carry the variant at all, then we will label it as in cis. In that case, this allele is normal. So in a recessive disorder, if it is a carrier state, should not cause the disease. So because this allele is normal, if this was the configuration we identified, then it would still be a VUS. Because in this particular patient, one variant was in the father, another variant was in the mother, and this variant was identified in trans to this particular pathogenic variant. One more criteria could be applied, that is PM3. So with that, and the phenotype was also classical phenotype for this, we could step up the variant into likely pathogenic. So again, if we get a compound heterozygous variant in a recessive disorder, we can advise for Sanger sequencing in the parents and see what is the configuration of the variant. So we should see that one variant should be from the father and one should be from mother. Then it will become compound heterozygous in trans, and that can increase one criteria. Again, that will not say it is pathogenic or likely pathogenic. One additional criteria for us to say it is likely to be a pathogenic or a pathogenic one. So this is an adult case of levodopa responsive Parkinsonism. So it is a so just early onset classical garden variant Parkinsonism with a similar illness in the sister and consanguineous parentage. So probably we are dealing with some autosomal recessive Parkinsonism. So most common type of autosomal recessive Parkinsonism is usually Parkin gene related Parkinsonism. So MRI was normal, and we did get a Parkin variant. We suspected also Parkin gene. We got a variant, but again was a VUS. So why it was a VUS? As Dr. Uday told, just because we have a phenotype, the gene is also matching. It cannot be implied that it is pathogenic. We have to, because we are sending a test thinking it is Parkinsonism, very likely they will be looking for genes in the Parkinsonism, and there may be one or two variants. So that doesn't mean that the variant is identified, so it is pathogenic. So what can be done next? So again, we go to the literature, see what is the criteria that has been satisfied so far. So based on the criteria, again, we can use the Genomed publicly available database or GRCH37. If you put in Google, you will get the links. It is easily available. So based on that, it is an extremely low frequency in general population. So that will satisfy PM2 criteria, one criteria. Then in silico prediction also, it predicted it to be deleterious, one additional criteria. Still, it will be a VUS only. So we have not yet attained the pathogenic, even though we know it is most likely the cause. What can be done next? Because it is a similar illness is in the sister and consanguinity is there. Yeah. So here we can do the segregation analysis. We are lucky that sister is also affected in a sense that we know we can know exactly what is the type of variant this is, or is it pathogenic or not. So Sanger sequencing in the sister can be done, and in this case sister also carried the same variant and parents were carriers only. So whoever has the disease carried this variant in homozygous state, whoever are asymptomatic either did not carry or carried in carriers, only in the heterozygous state. So it is segregating with the disease. The variant is segregating with the disease. So that is one additional criteria. So that is PP5. And then also on reviewing the literature, there is similar variant that is in the same codon, different amino acid was already been reported in a classical phenotype. So it is a previously reported variant in the sense, in the same 329, our patient had glycine 329 aspartate, whereas another reported patient had glycine 329 valine. So there is already a reported variant in that codon, but the different amino acid. So in such cases, another criteria that is PM5. So this criteria can be activated if you find a different amino acid in a previously reported pathogenic variant. So with this criteria, we could establish that this particular variant is a likely pathogenic variant. So again, even though, as I told, sometimes the literature is so vast that you cannot be going through all the literature. Sometimes the lab may not be able to do that. So because you have very limited cases, we can do that better sometimes because we are interested in only few cases. For a lab, there will be a lot of cases, and sometimes it may not be possible to be up to date all the time. So we may have to again go back to the literature, see if the same variant is identified, similar variant is identified, maybe a variant next to this particular codon is identified, then that means it may be a mutationally hotspot sort of region. So all these things can be done with the literature review. So without any additional tests. So case why, this is a case again, oculogoric crisis. So you would be suspecting, thinking of possibility of neurotransmitter disease. But one other differential is, this patient came with the dystonia Parkinson's with oculogoric crisis. 18-year-old boy, consanguinity was present, and total duration of illness was 2 years. So neurotransmitter disease is one of the possibility. Apart from that, the other possibility is also Kupffer-Jakob syndrome. So that also, those patients also can have upgaze restriction and also oculogoric crisis in certain patients. And we got a gene. We got a variant in a gene that is responsible for Kupffer-Jakob syndrome, that is ATP13A2. Again, but it is a VUS. The clinical fit is there. Patient can have oculogoric crisis, upgaze restriction, dystonia, Parkinsonism, and a variant is there in a homozygous state in a recessive disorder. So again, we'll go and see currently what is the criteria that has been satisfied. So Franklin, if I put the variant in the Franklin, it is showing me that it is a rare variant, that is PM2, and also that this is a deleterious variant, PP3. So with this, only one moderate criteria and one supporting criteria has been satisfied. But based on the table, we need more criteria to label it as pathogenic or likely pathogenic. So it will still remain VUS. But sometimes we need to see where exactly that variant is. So when we picturize that variant, where is the location of the variant, we can understand better. So if you see the variant in the exon, so it is in the edge of the exon. The edge of the exon or the exon intron boundary is very important for splicing. So if there is any changes in this area, the splicing mechanism or the system cannot identify this boundary. So if it doesn't identify this boundary, it may not include this exon, or it may splice somewhere else, leading to a aberrant splicing and a aberrant protein. So even though it looked like a missense, it just prediction, we predicted that it is going to change glutamate to aspartate, but the location of the variant predicts that it may be a splicing region, and we have a prediction tools also for that. Like for instance, Splice AI, it is again publicly available, free. If you put the variant details, it will give a prediction. That also predicted that there is a donor loss. So that particular region will not be identified as a splice donor, and the splicing system will miss that particular exon, and there may be aberrant splicing leading to an abnormal protein. So even though it looked like a missense variant, in actually it may also affect the splicing. So maybe splicing is actually more severe abnormality in the protein formation. So it is predicted that it is a likely pathogenic splice site variant with consistent phenotype. So RNA sequencing has to be done to confirm. These are all our prediction that it is going to miss the exon, or where it is going to, there may be another splicing nearby. So these are all prediction. To confirm it, we have to do RNA sequencing, which nowadays being offered by some of the labs. So if we do RNA sequencing and see what is the mRNA that is being generated, then we can see what is being skipped or what is being added, and based on the RNA and DNA comparison, we can predict that whether the particular splicing abnormality has happened or not. So this is again, sometimes a variant may look like missense, but in reality, if you see, especially it is always better to look in the region where that particular variant is it. If it is in the exon intron boundary, there may be additional splicing abnormality also that is happening. So this again, pediatric ataxia with progressive sensory predominant, ataxia with dorsal cord atrophy, and they had come with the CS clinical exome sequencing report. And as you can see, there is only dorsal cord atrophy with no significant cerebellar atrophy. So what is the next step? So we have a variant that is uncertain significance in a disease that can be inherited dominant, and the variant is also heterozygous. So heterozygous novel variant of uncertain significance in a dominantly inherited disorder. As I told earlier, when we get such autosomal dominant heterozygous variant, we can always look for Sanger sequencing in the parents. So to establish whether it is de novo or not. But then we have to sometimes, so that is the usual logical step we may consider. But then sometimes we have to go back and see whether that variant is actually important or not. Because before sending the Sanger, is it really a VUS or is it even less probability than VUS? This particular variant is frequently seen in the general population, and also in silico it was predicted as benign, and even in the ClinVar it was conflicting interpretation. Someone had labeled it as benign, someone had labeled it as likely pathogenic. So all these things resulted in this being a benign variant. So if it is a benign variant, even if you check in the parent, it is not going to yield you anything. And also the phenotype was actually, when we examined, the patient had plantar extensor and pes cavus. So it is not at all a, it is a Friedreich's ataxia. So if you send a whole exome sequencing for a Friedreich's ataxia, if you get a negative report, we are lucky there, because then we will think for some other alternative diagnosis. Sometimes a VUS or a relatively positive report may lead us astray, and in this case, if we would have got a Sanger sequencing in the parents done, additional 10,000 cost, that also may not have a result in the diagnosis. Sometimes where we start, we should always go back to the clinical phenotype, see whether the test was appropriate or not, and then you analyze the test further. If we order a wrong test, the report is going to be wrong, and whatever we do further will always be wrong. So this is a case of early onset generalized dystonia with some intellectual disability, was considered to be a CP-like and with relatively normal MRI. But there was some mild progression and there was no perinatal delay, perinatal insult, or there was no kernicterus or anything. So we thought there may be a possibility of underlying genetic etiology. So we got a homozygous variant, which is a frame shift truncating, that is 5960, there is a deletion which results in a frame shift and termination of the protein. So usually terminating or truncating proteins are, most of the time it is pathogenic, or very likely to cause the disease. but still it was labeled as uncertain significance. So I mean, when we see a truncating mutation, deletions, duplications of out of frame, so very likely that you might have seen that it will be reported as pathogenic or likely pathogenic. So in this case, it was reported as uncertain significance. Any particular reason? I explained in the first. So in order to apply that PVS1 criteria, that is very strong criteria, which says that if there is a truncation of the protein, very likely to be a pathogenic or likely pathogenic, we have to first establish that particular gene can cause the disease in a loss of function type. So if it is, you have to show that there are variants that have been identified where frame shift or truncating variant has caused the disease. There should be some precedence or some evidence for that. So when the lab reported to us, they had mentioned specifically that though the frame shift variation could be significant, it currently being classified as a variant of uncertain significance, since protein truncation are not well reported in this gene for this phenotype. So I mean, that is the reason they had reported as VUS. It may be pathogenic, but with the current understanding and the literature, we cannot label it as pathogenic or likely pathogenic, because it is still not established whether a loss of function can cause the disease or not. But then again, sometimes all this literature may be a bit outdated, because just in 2023 there are 2 reports of truncating mutation causing this particular phenotype with the functional studies as well. So with this new evidence, now we have a evidence saying that truncation can cause this disease. So that PVS1 criteria can be applied. So then it will become a pathogenic or likely pathogenic. So always we have literature at our service. We can go back to the literature, see there will be day in, day out, new reports will be coming. So you should always go back to the literature and see what new has come in this particular gene and the phenotype. And case 8, this is again a garden variant of very long standing, very benign tremor dominant Parkinsonism, lower body predominant with dystonia. So this is a sort of a clinical diagnosis for us. I mean, as I told, autosomal recessive Parkinsonism, dystonia, very well responsive to levodopa with early dyskinesia with no other non-motor symptoms. We usually predict Parkin-related PARK2 or Parkin-related Parkinsonism, which can start as a juvenile Parkinsonism as well. And with that suspicion, we had sent a exome sequencing which revealed heterozygous variant in a Parkin gene, the gene we are interested in. Splice site, I mean, when they say it is plus or minus, that means that it is in the exon-intron boundary. So it is a splice site variant. Usually splice site variant is considered to be significantly abnormal, but still they had reported as an uncertain significance. As Dr. Udaya told, it doesn't matter the zygosity. If the particular variant is pathogenic or likely pathogenic, it will be labeled as pathogenic or likely pathogenic. So just because a pathogenic variant is pathogenic, it doesn't mean it can cause the disease. In the sense, pathogenic heterozygous variant in an autosomal recessive disorder cannot cause the disease unless there is another variant. In this case, still they could have given a pathogenic, but they have reported as uncertain significance. My only understanding is in Parkin, there have been a report where heterozygous carrier state can also increase the risk of Parkinsonism. That is why they have reported it as, we don't know whether this can cause the increased risk or not. That is why it is reported as variant of uncertain significance. But our clinical phenotype was so closely matching, and there is a variant of very significant pathogenic variant in Parkin gene. I wanted to look for another variant. So there has to be another variant because the phenotype is very close match. So that time you can always go back to the geneticist and ask, see, I mean, this is very close match. Are we missing another variant? That time the geneticist informed me that there is a possible heterozygous deletion, but it is not of good quality. So that is why we couldn't report it, because we are not very certain that deletion, heterozygous deletion is actually there or not. We have to understand that NGS, the large deletions, duplications are predicted by pipelines. So I mean, sometimes the pipeline may not be very perfect. So that is why they suggested that there is another variant, but we are not very sure. But I mean, we need MLPA to prove it. And on doing the MLPA, we actually found another deletion variant in a heterozygous state. So just where we don't write everything that we see in the file, sometimes we may feel it is not significant and we may not put in the file. Same way, geneticists also may have additional information which they may feel that it may not be, I mean, they are not very confident, because once they put it in the report, it may sometimes be a medical legal issue also. The doctor may think it in another line and proceed further. So they may also be a bit, I mean, on the back foot, saying that let the clinician come to me and ask whether this variant is of really significant or not. So it is always better to go back to the geneticist and ask the question that is there any other variant. My clinical and genetic fit is almost a sort of, it suggests that there must be another variant. And this is again, I mean, this is a spotter. If I show the MRI, so again, I mean, Dr. Arushi had mentioned, showed the almost typical ditto MRI with the dystonia, basal ganglia involvement and white matter involvement with thalamic sparing. So this is a case of L2-hydroxyglutarate dehydrogenase deficiency. This is sort of, this MRI is very classical, the rarefaction that you can see in the flare. The T2 hyperintensity is more compared to the flare, and also thalamic sparing. There will be dentate hyperintensity also, but it need not be there always. So clinical and radiological only we were thinking, okay, we are dealing with L2-hydroxy, we just needed genetic confirmation. Even the urine organic acid was also positive, so we just needed a genetic confirmation. But then we got a genetic report negative. Now we go into the negative reports. So as Dr. Arushi was sort of mentioning that nowadays all depends on the genetics. Clinical, examination may not be that relevant. Maybe the time will come when the clinical sort of input will become more relevant, especially in such cases where we have to go back to the clinics and see where are we, are we sure or not? Because in this case, as you see, clinical phenotype is can be explained, radiology is fitting, urine abnormality is fitting, everything is fitting except for the genetic. If 3 people are right, 1 person is wrong, the person, no, there is a majority. So obviously genetic testing, there must be something must be there that we are missing. So again, when we look at the literature, we can see that many variants are reported, out of which 85% are single nucleotide changes, whereas 15% will have large deletions. So usually NGS has a limitation in picking up large deletion, exon deletions or multiple exon deletions. Although these days, if you have seen the report, they also report that based on prediction models, but it is not a good test for a large deletion duplication. Because 15% of the disease may have a large deletion duplication, we suspect that there may be an exon deletion somewhere. And again, it can be looked at in the raw data in the NGS itself. So these are the reads that are sort of aligned to the each exons. And this is exon 10 where there are no reads at all. Everywhere there are reads, but here it is not there. And the lab also told this gene is usually can be sequenced quite normally, perfectly. So there is something missing the exon 10, which made us think that exon 10 deletion may be the cause. And MLPA picked up the exon 10 deletion. So because we are clinically sure that this is the disease that we are dealing with, we could ask the question that there is something abnormal in the this particular gene, although it is not being picked up by the exome sequencing. So it all boils down to again how sort of confident are you in your clinical sort of approach and decision or interpretation. So coming to this case, we
can sum up of this, please.
Yeah. Yes, sir. Just 2 cases. That's all. So just this is again straightforward case. As you can see, patient with visual impairment, ataxia and perido-occipital white matter hyperintensity with, So we also thought the same thing, and someone had already done the work for us, sent a genetic report, testing, but it was negative. Again, the same way as before, because everything is matching. There is an elevation of VLCFA also was elevated, radiology is fitting, clinical it is fitting, there has to be a variant. So then again we asked for the raw data and analyzed it again. Once the raw data was analyzed, there was a variant here which is likely pathogenic, but in a different gene, not in the APCD1 gene, but in a different gene in a heterozygous state. But this is not the cause of the disease. This is just to emphasize there are a lot of pathogenic variants in the gene. Just because it is pathogenic, it doesn't have to be reported because it is a heterozygous state and not with the phenotype. When we looked for the ABCD1 particular variant, there are 4 variants. In that 2 variants were already reported as benign. There is one very deep intronic variant. This is -385. It is somewhere very deep. Deep intronic variants are usually not the cause, but not always. As she mentioned in call 6, 40% of them can be deep intronic. There is one variant that is -32. That is, from the exon intron body, 32 base pairs difference. There is one more variant, and that has been predicted to be deleterious by Splice software also. So this variant can cause aberrant splicing. This particular region should not be picked up by the splicing mechanism, but because this particular change result in a change in the sequence of this AGGT. AGGT sequence is usually picked up by the splicing machinery as a exon intron boundary, and it will get attached there and it will start splicing there. So because it was aberrantly picked up, so as you can see, this particular AI tool picked up it as a donor gain. It should not have been picked up, but because of these changes, the splicing is happening here, and it will predicted to result in an abnormal protein. So even though again RNA sequencing is underway to confirm this particular prediction, but if we have a strong clinical suspicion, then we can actually go for a particular gene or a particular few set of genes and see where are we missing out on the particular genetic variant. So another, just one or two cases to demonstrate the. So this we had seen in 2016. Many might have seen because I had discussed this case earlier also. At that point of time, we thought it is just a combined dystonia, generalized, predominantly craniofacial, 2016, and MRI was showing some mineralization in the GPI, and exome sequencing was sent where they had reported there is no significant variant, but additional variants were there. So some of them could be sort of matching with the phenotype, but on putting the criteria, one of them was benign, two of them were VUS. Luckily for us, the patient was lost to follow because we did not pursue these two variants. Otherwise, we would have unnecessarily pursued these variants, and it was a financial burden. Again, the patient came back in around 2022 or 2023. On revising the phenotype and looking at the radiology, so we realized it is a strong fit for KMT2B related dystonia. The microcephaly, the bulbous nose tip, and also the patient is having GPI mineralization. All this is very classical phenotype of KMT2B related dystonia. So without genetic also, based on this phenotype, because we know now what is KMT2B dystonia, we could identify this is most likely looks like KMT2B. Then on reanalyzing it, we realized there is a variant sitting in KMT2B, but that particular gene was not yet identified when we sent for the whole exome sequencing as a cause of this disease. The gene was identified, but the gene can cause this phenotype was not identified. So although the variant was sequenced, it was not analyzed because we didn't know that this gene can cause dystonia. So once we know this gene can cause dystonia, if it is a whole exome sequencing, we can go back to the raw data, see whether this particular variant is there or not. So without ordering an additional test, just on checking the raw data, we could identify there is a variant in a gene that is recently described that can describe the phenotype. So sometimes the negative report may be just you are ahead of time. The gene is not identified yet to cause this phenotype. Maybe you have to revisit it at a later date. And this again was a similar. So Dr. Arshi again mentioned that if I am showing T1, there has to be only one particular reason. So it is a very classical feature of hypermanganesemia, elevated manganese, everything. But there is no anemia and hepatomegaly that is usually seen in type 1 type of hypermanganesemia. And again, we had sent the report in 2016. The report had come negative, and patient was lost to follow. But later on in same year, or within 2-3 months of sending the report, a gene was identified that can fit the phenotype. Again, because we had sent whole exome sequencing, the gene was sequenced, but it was not looked at. So we can go back to the raw data, analyze it, and demonstrate that there was another, again, a variant already sitting there that can respond, that can is responsible for the disease, but was not looked at that point of time because we are not aware that this gene can cause this disease. So sometimes this is the last case. Sometimes what happens is we send whole exome sequencing, but still we may not get a proper report. This case, a patient had central and peripheral abnormality and also leukoencephalopathy in the brain. So there are very few DDs for this particular findings, and also the patient had some frizzy hair. The diagnosis that was clinically considered was giant axonal neuropathy. But on sending the exome sequencing, not sure, no variant was identified in GAN. There are two variants of unrelated in different genes. But when we checked at the phenotype, they had not mentioned the patient has leukoencephalopathy and peripheral neuropathy because the phenotype was not given properly. Although the patient underwent whole exome sequencing, the genes that were tested in the table did not include GAN. So GAN was sequenced but not analyzed because we didn't give a proper phenotype. So when the proper phenotype was given, again mentioning that leukoencephalopathy is there, neuropathy is there, they looked for GAN, and there was a variant, homozygous variant, although uncertain significance, available there. And the nerve biopsy also confirmed that there is a giant axonal abnormality, so confirming that variant. So if we don't provide the proper clinical phenotype, it doesn't matter even if we advise whole genome sequencing, we will not get a right report because it is not usually humanly possible to look at all the genes and assess all the variants and go through that. It will take months together. Usually they will be targeting certain genes which are most likely responsible for our phenotype. So it is always important to provide a proper phenotype. So as I told, unfortunately doing all these things, this is just a few of the cases. Many cases are there where it will still be VUS, it will not budge. So, and it may be because of lack of family member for segregation, financial limitations, lack of infrastructure and finance, this one. And as you can see with the VUS, after all this, there are very less likely chances that it is going to become a sort of a possibility of pathogenic. Majority of them will still remain VUS. So we have to understand that just because it has come a VOS, it doesn't mean it will someday become pathogenic or likely pathogenic. It may just be a VOS and of no significance, because mutation or variation happens in each and every individual, and all of them, majority of them, are not abnormal. And this is one of the, I mean, I have already showed, you can score the VOS and see, are you more likely to be closing towards pathogenic, likely pathogenic, or towards the benign region. If it is more towards the pathogenic or likely pathogenic, there is some sense in sort of going ahead and getting the further investigations done, Sanger sequencing or other function study. If it is more towards benign, very unlikely that it is going to become pathogenic or likely pathogenic. So this I have already mentioned. So when we, regarding the VUS, when we tell the patient, we should always mention before testing itself that there is a possibility it may come VUS. There is a possibility we may have to go ahead for further tests. There is a possibility that even though there is some variant identified, we cannot understand what that variant is, I mean, whether it is important or not. And also that, I mean, that it is, in certain cases, even though there is a VOS, clinically, if it is a treatable one, it may be a clinical decision that, okay, we'll treat considering it as pathogenic. So all this uncertainty has to be advised to the patient. And as a clinician, we have to go back to the phenotype and see how it is fitting. And as Dr. Udaya told, sometimes a variant may be labeled as pathogenic, but the first report who labeled it as pathogenic may not have done it properly. Just because there is a report in the literature, it doesn't mean always it has to be correct. We have to go back to the literature always. And it is better if we maintain a VOS database, because each population is different. So as she told, Indian population is not that, I mean, sort of big, I mean, in the sense the representation. So maybe we have to maintain our own database and see if there are 3-4 same VOS occurring in our population. Maybe that may be of interest, and we can proceed further with some further functional studies. So I have already mentioned this more or less, and just to, I mean, there is a genetic in movement disorder workshop that will be part of MDS-Econ in February 2025. So if anyone is interested in that, you can definitely apply for it. The registration are open for the conference, and I would like to extend my gratitude to our team, headed by Professor Pramod Kumar Pal and all the other, I mean, and also Dr. Baby Lakshmi Muthuswamy, who is our geneticist, and Dr. Gautam Arunachal, our in-house geneticist, from whom I have taken many of the cases. Thank you.
Wonderful talk. Thank you, Vikram. I think still time for one question, 1 or 2 questions.
Just a comment, the case you showed that crises ataxia. So normally there is atrophy of the cervical cord. So here it was clearly shown the cervical cord is okay, but the dorsal cord was at problem. But how, as a clinician, I will order GAR repeat in that case and
So,
the first group. That's why I asked.
So that's what, I mean, like, not only genetics, like for instance, any etiology for that matter, we don't have, as you were asking, which, I mean, which is the best test to send. There is no one single test that can cover everything. Even when we are suspecting autoimmune encephalitis, there are multiple panels, and even after sending panels, we'll still get negative. Same in genetic also, we don't have one particular test which can cover everything. It is just by sort of understanding Friedreich's ataxia, always follow the dictum that uncommon presentation of a common disease should be common compared to a common presentation of uncommon disease. So even though Friedreich's ataxia, it is a bit atypical, we should always try to rule out Friedreich's ataxia before sending for exome sequencing. I am lucky in that matter, many of these tests get freely done in our institute, so I can always send Friedreich's ataxia, wait for the report and send exome sequencing. But it is, I mean, if there is no cerebellar atrophy, I think we should always rule out Friedreich's ataxia unless there is some glaring contraindication.
Thanks, Professor Holla, for a wonderful and very erudite talk. I learned a lot from it. 2 questions, rather 2 sort of philosophical thoughts. One is that with this immense development in genetics and the clinical neurology, all of us are quite, well trained in that. How to bridge the gap? Because you have spent a lot of hours in EMHANS going through all this. It seems quite an impossible task to suddenly up the game to bridge this genetic and clinical, link. That's one question. The second thing was more about the population study and about the interpretation of VUS. We were referring to the American board that certifies all these things, the various GenomeAd and the MedGenome. Now the population is India. So where is the Indian database? Because I'm quite a novice in all this. So is it all well designed to study the Indian population? and the interpretation of these rather expensive site tests? So 2 questions there, please.
Regarding the first question, I think to fill the gap, we need more hands. One person cannot do everything. So ultimately, I mean, I can be a clinician who has some extra knowledge in genetics, or I can be a geneticist who can have extra knowledge in clinician. It is always better to have some, I may be better, I know better in movement disorder maybe, but if an epilepsy case comes or something comes, I will not be able to handle sometimes. So it is always better to have 1 or 2 people. One person cannot do. Have a geneticist friend, talk to the lab person, identify one person who you can't sort of always listen to, because as Rudra was saying that genetic, I mean, they may not be fully aware of the clinical implications or the clinical finding. So it is just bridging the gap is just sort of partly, I mean, I cannot be a genetic expert. I can just be a clinician who is interested in some genetic details. So bridging the gap is just by involving more and more and sort of having the, and regarding the Indian data, there is project Genome India. I think it is completed. They are coming up with the multi-ethnicity. They have divided into multiple ethnicity for normal population. Even in Genomad also there is Genome Asia, and there is India. There are certain normal population database that is available, and most of the labs use their own in-house database also. So around at least around 5 to 10 tests. That is not exhaustive, but they have in-house database as well. So Genome India is the one. I think that should come up with the database. That is almost complete, and the data is coming out.
Thank you very much. Thank you much.
Excellent talk, Dr. Bikram. So may I ask Dr. Rishi sir to give a memento to Dr. Udaya, please? Now, may I ask Rishi sir to give a memento to my friend Dr. Bikram?
So 2 more felicitations. May I please request Dr. Bhaskar Ghosh sir to come and felicitate our chairperson, Dr. Rishikesh Kumar. Next one. Now I please may request Dr. Jackie Ganguly to felicitate Dr. Arijit Chattopadhyay.
Just a small word about Arijit. He is our first Calcutta's pediatric movement disorder person who used to attend all our movement disorder forum meetings since 2006.
So now, because of lack of time, we'll quickly cut short the cases. Yeah. So, yeah.
Put up the cases. Who is presenting?
Dr. Nilanjana.
Nilanjana, aage aajo.
So be very brief and very quick.
So Adrish, please come forward. Before she fixes her computer. Aajo. Happy birthday, Adrish. Diabetes है क्या? there is a tradition. In my lab, there is tradition, and I cannot break the tradition today.
So let's start.
আচ্ছা মানে একটু জাস্ট স্টার্ট জাস্ট ওটা এদিকে চেকটা দিকে ঠিক আছে স্পিচের ভিডিওটা কি স্কিপ করেছো স্পিচ নরমাল
So okay, we'll start the first case. Dr. Nilanjana, please proceed.
Thank you, sir. A very good afternoon to all my respected faculties and delegates. I am going to present the case. My mentor is Dr. Jackie Ganguly, sir. So, briefly, the history of 4-year-old girl child born out of third degree of consanguineous marriage. This is the pedigree chart. She was had normal perinatal history, but only the walking motor milestone was delayed. After 2 years of age, she got a febrile illness for several days, and after recovery, she was noticed to have some gait difficulty, gait imbalance. That is the regression of her walking milestone. Cognitive aspects was normal. Initial examination finding was more or less normal. This is a speech video of the patient.
You can just explain what's there in the speech. If sound is not there. Just explain it, Nilanjana. Just explain what was there.
Speech was more or less normal, and this is the so something to pick up in the finger nose test. There was dysmetria in right side and also in the left side.
Okay, so normal speech, dysmetria.
Next is the gait. This is the gait of the patient. We can see the broad-based gait. Similar gait it is actually, broad-based. This is the, now importantly, this is the gait before her febrile illness. We can see that the broad-based aspect was not there in the previously, before the febrile illness.
It was more or less normal before the febrile illness, right?
Yes.
After the febrile illness, this broad-based ataxia started.
So summarizing, a long-standing non-progressive ataxia with consanguinity, history of consanguinity, early onset, delayed motor milestone, and worsening by febrile illness. We kept this
possibilities. First, organic aciduria and mitochondrial ataxias. Other things like biotin deficiency, congenital disorder of glycosylation, the INAD subtype of the PLEN, and Joubert syndrome, although the patient did not have any significant eye movement abnormality. Eye movement was
Let's see
normal
the
for the
MRI,
patient.
please.
So proceeding with the MRI that time in 2022, it showed bilateral basal ganglia diffusion restriction over the diffusion weighted image, and there was hyperintensity similarly in bilateral basal ganglia, and notably there was bilateral cerebellar atrophy. So other investigations was not very much significantly showing anything. So whole exome, we proceeded with whole exome sequencing, and it came positive for PMPCB gene, but as VUS. So we proceeded with Sanger sequencing of both parents, and in case of both parents, they are having the heterozygous mutation of the same gene. So our working diagnosis now is the multiple mitochondrial dysfunction syndrome due to the biallelic variant of PMPCB gene.
Thank you, Nilanjana. Thank you. So the teaching point for this case was after the febrile illness symptoms started, and then the MRI clue was there. So ataxia presentation, early ataxia presentation with bilateral striatal involvement, diffusion restriction. Definitely we should think of mitochondrial along with cerebellar atrophy. So any treatment we have given?
Yes, the mitochondrial cocktail treatment was given.
Okay.
These are some referring articles. This treatment is given: biotin, thiamine, riboflavin, coenzyme Q, and also carnitine was supplemented.
Okay.
And this imaging, in imaging, the diffusion restriction has gone in recent imaging, but cerebellar atrophy become more overt. The gait ataxia is actually persistent in the patient. That's all. Thank you so much.
Thank you.
I would now call upon our next resident, Dr. Anirudh, to come upon and present his case. Dr. Anirudh.
Good afternoon. I'll be telling a tale of tumbling child.
Just make the brief history, direct go to the video.
So the patient is a 22-year-old female with normal perinatal history, presented with the following complaints. She had seizure at the age of 1 year, delayed developmental milestones, mainly motor milestones, from the age of 2 years, imbalance while walking at the age of 2 years, and slurring of speech. And for the history of present illness, seizure started at 1 year of age. It was followed by febrile convulsion, continued till 3 years of age, monthly frequency of seizures. She was put on anti-epileptic and seizures controlled till 5 years of age, and then AED was stopped. Remained seizure free till 2022, that is 20 years of age. And the seizure semiology was GTCS with urinary incontinence with post-ictal drowsiness, and monthly frequency was 4 to 5 episodes. She was put on sodium valproate and brivaracetam. Next, mainly the delayed developmental milestone form of motor delay. She had normal cry after birth and started walking at the age of 18 months, and language and social milestones were normal. And she had imbalance while walking, and there is also fear of falling, difficulty in eating food because of the hand clumsiness, and gradually progressed so that recurrent falls started at the 8 years of age. And she had also slurring of speech since 2 years, that is slow and halting speech, but comprehension and language was normal. Patient is wheelchair bound since last 4 years, walks with support of 2 persons right now. And she had below average scholastic performance and could not follow in the class and attend specially abled school.
Let's go to the video, please.
So the first video is showing the bilateral finger nose test positive in case of her, and then the third video is showing the extraocular movement which was normal, no saccadic or pursuit abnormality. And the next video is showing her gait. Mainly it is a wide based ataxic gait with some spastic component also. Next, this is the speech. She had also a slow halting speech, mainly kind of ataxic speech. So other than this, on the clinical examination, on the no cranial nerves abnormality was found, and motor examination there is spasticity, and the all deep tendon reflexes are exaggerated, and plantar or bilateral extensor, and also gait was spastic and ataxic.
Okay, so spastic ataxia presentation. Let's go to the MRI brain.
So we didn't do much of the investigation because I will go to the directly to the MRI, because the MRI is so suggestive that the diagnosis will come forward with this. The MRI showed that there is T2 hyperintensity in the mainly in the diffuse bilateral white matter hyperintensity, mainly involving the subcortical U fibers.
Yeah, so this is the 5th or 6th time today we are discussing the same MRI pictures, and everybody in the hall knows the diagnosis now.
And the hallmark of the MRI is the bilateral basal dentate nucleus hyperintensity. Also, there is no diffusion restriction or ADC changes in the MRI, and there are no brainstem or corpus callosum involvement. So this radiological finding is a hallmark of L2-hydroxyglutaric aciduria. Other radiological correlates will be in the form of leukodystrophies like Canavan or Carn's syndrome, but they will have mostly the brainstem involvement, also involving the subcortical U fibers. So on further investigation, we found we sent for urine analysis for organic acid, and we found that there is a peak with 2-hydroxyglutaric aciduria, and also the qualitative analysis, both L2 and D2-hydroxyglutaric aciduria came abnormal, and the 2-hydroxyglutaric aciduria came as an abnormal level of 23, that is quite high. So this is reported as the suggestive of 2-hydroxyglutaric aciduria. Now, before we go to the genetic sequencing examination, whole exome sequencing, I like to discuss some, because the patient's radiological findings suggestive of the typical L2-hydroxyglutaric aciduria. But we are having on urine analysis, that is the only 2-hydroxyglutaric aciduria, and there is also 2 types of hydroxyglutaric aciduria, that is D and L isoforms, and to separate this, we have to focus on the LCMS, liquid chromatography and mass spectrometry, and only urine analysis, that is we get that 2-hydroxyglutaric acid raised. We can get this also in 2 other conditions, that is a combined D and L2-hydroxyglutaric aciduria, and also lipoyl transferase 1 deficiency. But in case of combined D2-hydroxyglutaric acid, there will be pathogenic mutation in the SLC25A1 gene, and for the lipoyl transferase 1 deficiency, there will be pathogenic mutation in the LIP-T1 gene. But it also shows the raised level of lactate, succinate and the fumarate on the urine organic acid analysis. In our patient, that is not shown. So we put the whole exome sequencing, and it revealed that L2-hydroxyglutide dehydrogenase gene, but it came to positive as likely compound heterozygous and uncertain significance. So I will ask Dr. Vikram sir to interpret this result in background of this so suggestive of clinical and radiological diagnosis.
If someone else will be able to answer it if anyone has listened to the talk. I mean, what may be the next step to do in this case?
So Sanger sequencing of parents.
So that will, I mean, yeah. So possibly we'll get 2 variants in 2 different, I mean, sort of parents. But then in this case, both are uncertain significance. So although, I mean, for all practical purposes, we assume this is this sort of a disease. But still, usually when we apply the trans sort of criteria, it is in trans to a pathogenic variant. So one of them, it is pathogenic. Then the other variant, we can label it as pathogenic or likely pathogenic if we establish that the second variant is in trans to the first variant. In this case, both of them are of uncertain significance. So just based on trans alone, we still may not be able to step it up to pathogenic or likely pathogenic, despite knowing that most likely this may be the cause. We may need to do functional studies or see what other sort of variant criteria we can try to, go through the variant details, go where it is, the previous literature, anything like that. Any other criteria can be satisfied or not, we have to see. But first step would be definitely to establish they are in trans rather than cis.
Thank you, Bikram. Thank you, Aniruddha.
Next in line is Dr. Shoma. Dr. Shoma Mandal, please come on stage for the case
That will be
presentation.
our last case, and then we'll go for the Botox workshop.
Years-old lady presented with gradually progressive gait imbalance since childhood along with speech problem for last 6 years. She was born out of non-consanguineous marriage with normal perinatal history, but there was delayed developmental milestone. She started working at 3 years of age, but it was almost static and the gait imbalance has worsened in last 3 years. Presently needs support of 1% to walk, along with slurring of speech and occasional tingling sensation of both lower limbs without any comorbidities or any cranial nerve symptoms, no significant family history. This is the video of her eye movement.
So you're showing some nystagmus, right?
Gaze-evoke nystagmus. And the speech is ataxic dysarthric speech. And this is the picture showing the curling of the toes and bilateral pes cavus.
So again another case
Bilateral
of spastic ataxia.
finger
Right?
nose finger impairment, and also there is bilateral heel shin test impairment. Appendicular ataxia. And the gait is spastic ataxic gait. Apart from the finding showed in the video, some important examination finding: MoCA is 24/30 and the spasticity in both lower limb with normal muscle powers and diminished pain sensation in both lower limb below the ankle joint. Brisk knee jerk bilaterally, ankle jerk is 1+, and bilateral plantar equivocal, and bilateral appendicular ataxia with spastic ataxic gait, no extrapyramidal sign. So in summary, 47-year-old lady without any comorbidities had gradually progressive ataxia, ataxic dysarthric speech, gaze-evoke nystagmus, sensory neuropathy, pyramidal signs in lower lip, and mild cognitive impairment along with toe curling and pes cavus without any family history, significant drug history, autonomic involvement, or any cranial nerve symptoms. Let's see what I have put in differential diagnosis. First, Friedreich's ataxia, then ataxia with oculomotor apraxia type 1 or 2, AT or AT-like disorders, mitochondrial disorders like Polg mutation, AVET, spastic SPG7, spinocerebellar ataxia, because there are some types of SCA having peripheral neuropathy, RSAX, Repsam disease, beta lipoproteinemia, and last CTX. The gene test for SCA profile was done, which came out to be negative, and the Friedreich's ataxia gene test also came to be negative. Routine investigation was normal, including thyroid, vitamin B12, vitamin E level, and serum alpha fetoprotein level. NCB showed sensory motor polyneuropathy, lower limb predominant. And this is the MRI brain, which shows the T2 imaging shows the striped hypointensity in the pons, that is the striped pons or tigroid pons sign, and then the sagittal section showing the thinning of the corpus callosum and obvious the prominence of cerebellar folium. OCT shows thickening of the retinal nerve fiber layer, and the fundus photography showing the retinal stripe sign.
Yeah, so spastic ataxia presentation, very clear cut case. Spastic ataxia presentation with pontine stripe and retinal stripe. Pes cavus was a clue, neuropathy was a clue. So this diagnosis was RSAX, right?
Then we did whole exome sequencing. There is homozygous mutation of the SAX gene on exon 10, which is associated pathogenic and associated with spastic ataxia of Charlevoix-Saguenay type. This case was initially detected in the Quebec region of the Canada, but in recently it is found in different parts of the world, including India. In Kerala, there are in a family three brothers of a family from Kerala were detected with this RSEX, and before 2021, only 5 genetically proven case was found from India. So our take-home message is, though it is a very rare syndrome in India, RSEX should be kept in consideration in differentials of young onset ataxic cases, having other features like spasticity of lower limb and peripheral neuropathy. The supporting clue are curling of toes and Pesceval's deformity, MRI brain findings, striped pons, thilling of corpus callosum, atrophy of superior vermis, bithalamic stripe and cerebellar atrophy, and there is retinal stripe sign.
Thank you. Thank you so much. So now we will proceed for our Botox workshop.
I think there's tea outside. We won't have formal tea break, but somebody wants to grab a tea or coffee, you can go outside and come back. Party hai na? Chai hai na? No, just ask them open. So what we'll do, Jackie, because time is less, so we'll have 3 regions: face, 1, second is neck, and third is rest of all. We'll call all the patient together, so that 2-3 patient for face. Then after that, neck. So let's call hemifacial spasm. Let's call blepharospasm. We have the patient, and they can stay here. Then we can proceed forward. And that some problem is involuntary close of the eyes, right? And for some it's very basic. For others you might not have injected till now. But so I will be quite diverse in telling what to do. So what he has is involuntary close of eyes, not one eye, both eyes, right? He is not able to open it properly. थोड़ा आवाज कम करोगे तो अच्छा रहेगा, sister. Thank you. And when it touches, then he opens it. So what it is, a dystonia, a type of dystonia. Unlike hemifacial spasm, which is one side, she has bilateral. He has bilateral, not involving face. So this is blepharospasm, that dystonia of the face muscle, peri-orbital muscles, right? So in dystonia, we have various options of treatment. That includes anticholinergic, that includes even baclofen. But toxin is the best treatment available because it is very small amount. For this amount is very cheap and lasts for 4 to 5 months easily. And it's very easy to inject. But while he's setting up, so we have to inject in the eye muscles, orbicularis, oculi. You have to think where it is and what are the subdivisions of that. Outside, what you see in the Gray's anatomy, perfectly outside is the orbital part, right? So that's not needed. Below that, just outside the eyelashes is palpebral part. That is the most sensitive part. You give small amount, patient responds very well. Okay, and in between the palpebral part and in between the orbital part, there is preseptal part, right? So preseptal part, pretarsal or palpebral, you can say, and then is orbital part. So we have to give the pretarsal on all palpebral. That means we have to stay close to the eyelashes. Okay. नहीं तो copy करके कर दो यार. I'll use this. आंखें बंद कर ले, आंखें बंद कर ले. We have to show the sites. Site, this is the site we have to give. If you are very close to the nose, over here, this punctal sac, it will block the punctal sac and the patient will have epophora. So when you have to give, we have to give away from the punctal sac. So I'm talking about the lower part of oculi. Middle is good, so this place is good. We cannot give only one place because it has high molecular weight. It doesn't go all over the places, so we have to go to multiple places. I would say 4 places are enough, reasonably enough for the oculi. I'll leave it. Can you see generally? Okay. So one is the middle part, not close to the medial part because puncta sac is there. Second is lower lateral. So what we did, lower middle and lower lateral. Upper will give upper medial, not middle. Why not middle? Because another muscle jutting there, levator palpebrae superioris. We have to avoid that because if you give there, the patient will have ptosis. So you'll get upper medial and upper lateral. So that's the way we give in oculi. Apart from that, what muscle to be given in the face? एक बार सर आंखें खोलें ऐसे करेंगे so when you see he looks have to worried appearance and that worried appearance is because of one muscle which is known as corrugator. Where is corrugator? Corrugator is right here in the middle part of eyebrow. So corrugator. Apart from that, in blepharospasm, there is another muscle which is involved, that is procerus. Middle is procerus. Procerus is on both sides, but it comes together to the midline. So if you give the midline, that will suffice. So what the sides we saw in blepharospasm, upper medial, upper lateral, lower middle, lower lateral, corrugator and procerus, that will suffice. Now what is the dose we give? We give botulinum toxin A, be it zeomin, be it Botox, 5 units each side, that will go enough as a starting point. If you're too scared, they can start for 2.5, but what happens in 2.5? Patient doesn't show improvement, and next time you lose the patient. So always good to go therapeutic dose, that's 5. So 5, 5, 5, 5, 5, 5, and 5. So generally 50-55 minutes. So one bottle has 50 units, that will suffice. So we'll inject in front of you and we'll see. This bottle has 100 units, right? But put 100 units, something in the 100 units. What something? If we put say 1 ml, that is 1 ml will constitute 100 units. What we do? We take normal saline, we put needle here, we push 1 ml inside, we mix it. Don't vigorously mix it because it can cause some protein degeneration. So just mix it gently and it's there for you, right? When you have to pull out, you have to pull out 3. So I use tuberculin syringe because it has clear divisions in that. When you see tuberculin syringe, it has 1 to 10. Sure. And each has 10 divisions each. So I remove the air, total. Here. So this is 100 units, right? Then you ask that how to give 5 units. This is 10 units because total is 100. This is 10 units, 5, 5, 5. Yeah. 2,500 per month. Even medicines are not that cheaper. So we inject in the oculi. This is your corrugator. This is your corrugator. Upper medial. You can see the movement of needle. 5 units. You can see wonderful bleb coming up. Upper lateral. Lower middle. Lower lateral. So this is done. When you have done 10 times, it takes 32 minutes time to inject. After, so this is done. And for him, I would say that don't massage it for a few minutes time, at least for half an hour time, because once you massage, you are pushing the toxin from one area to other area, which you don't want. Especially, I'm a little afraid about the LPS, limited pulmonary superiority. So that's it for him. So this blepharospasm. Of course, this is pediatric neurology, but blep can be seen in pediatrics also. Neurometabolic dystonia can have blepharospasm. Okay, thank you. So this is your injected human here. So we'll have 2 more cases of face. So quickly I'll go through 5 or 6 slides just to show how it looks. This is blepharospasm, right? And this is hemifacial spasm. No doubt. Moving on. Is this hemifacial spasm? Yes or no? Why? No, this video. There's only one side. Why not hemifacial spasm? Huh? Yeah, so you're talking about other Babinski signs. So let's tell them. So in hemifacial spasm, it can be functional, it can be organic, right? What happens that anybody can do this, and they then come to your clinic that I have hemifacial spasm. In that is how to recognize that. In case of functional, the eyebrow will come down. When they're doing that, eyebrow will come down. It's very difficult to do eyebrow up and eye close. Can you do that? It's very difficult to do that, right? Eyebrow up and eye close. But in true hemifacial spasm, because frontalis is also supplied by facial nerve, that twig will be hyperactive, frontalis will go up. So eyebrow will go up and eyes will come down. And this lady, when you see this eyebrow is coming down. Eyebrow is coming down. On the other hand, this, even the still picture you see, eyebrow is in fact going up a bit. When you see closely, eyebrow is going up a bit. So in case of true hemifacial spasm, eyebrow will go up. In functional, eyebrow will go down, and this sign is known as other Babinski sign, which was described by Babinski before the Babinski sign, right? And this is one of our lab mates, just to show the same thing. She tried to bring the eyebrow up, she is not able to do that. Anyway. And just show the muscles one by one. What muscle we inject? Frontalis, easy. This is corrugator, the red one. It will come one after. This is procerus in the middle. This is oculi, various parts. This is nasalis. So these muscles are important. This is levator superioris, the various parts, levator superioris. This is zygomaticus. This is rhizorius. This is orbicus oris, around the mouth. Mentalis. This is depressor of angle of mouth. So depressor, angularis labii, right? Angulohoris, sorry. And platysma. So one more time I'll go quickly, and all the muscles are done. Frontalis, corrugator, procerus, oculi, nasalis, levator, zygomaticus, rhizorius, oris, mentalis, depressor angulioris, and platysma. Those are muscles. If you know the face. Go ahead. injecting only for the functional purpose, only for the eyes. So we inject only for the blepharospasm.
As sir was mentioning, here we will mainly consider it the blepharospasm part. We can see there is some hemi component is also there, some cervical component is also there, but those are not that troublesome for her. Mainly bleph is the troublesome for her. So we proceed with this. So the standard dose, as sir was mentioning, 5, 5, 5, 5, 5, so pre-tarsal part, please state how the needle is. We will then try to prepare to put it up so that to just make it less painful and less bleeding.
What is meaning? When you see the needle is not flat. It is like this. So bevel is up towards me. When you do the bevel like this can be a little more painful. More importantly, the toxin can go somewhere else. It can go beyond this. So when you see this, that means bevel is going inside. That means you are in the muscle. So bevel up means seeing the slice in front of you.
So we'll start with the left side, so pre-tarsal part. So the blade is there, so that means you are in the right side. So now the medial one. So you can see that blade. So try to make those blades. We'll avoid just the medial lower part. So avoid that lower medial one. So we'll just inject here, a bit away. Done. See all those blades. I preferably inject for these 4 points and this orbital part. So here.
So what happens when you see two injectors? They can have different approach. He told that I also inject orbital part. I also inject when the patient has stool like this. Orbital part, see, this is spasm of pretarsal part. And if this is spasm of orbital part, if the patient is having that, add in the orbital part also.
So avoid the two medial will not go, the medial. Done. All those blades are coming. So here, see the direction of my hand. This is away from the body, right? So yes. Done. Down. Down. See again those blades. So the last one. So all done.
This is the last case of patient, right?
Yeah.
So now see the patient first. I don't know if everybody can see or not, but can you see the face? Hemifacial response. See the eyebrow. Generally, eyebrow, when you see the line, this eyebrow is going up. Left side mein na? Left side mein, right? In case of functional, she would squeeze like this. Right now, because frontalis is active, this is going up. So this is true hemifacial spasm rather than functional. And in this case, of course, apart from eye, what other muscle you will inject? Can you see the angle of mouth? The whole face is involved. So you'll inject into rhizorius also, into zygomaticus also it's going up. Some nasalis, this is nasalis, some contraction is there also. Platysma, some contraction there. So she needs more injection as compared to only eye, right? Now we have to know where is rhizorius, where is zygomaticus. It's very easy to say in the picture, but where to say this is rhizorius. From angle of mouth towards the tragosophia, straight, medial 1/3 and lateral 2/3. This is a landmark for rhizorius. You cannot see it, it's a small muscle, it is a landmark. Then when you inject the needle should not be like this because thin sheet of muscle. So if you want, you to inject in the longitudinal plane rather than vertical plane, so that If you are a little deep also, you are in the rhizorius. So in this case, this is rhizorius. Zygomaticus, from angle of mouth to zygoma, just below zygoma is zygomaticus. I'll show on the in the picture one more time. Yeah. So can you see that angle of mouth towards stegosphere, medial 1/3, lateral 2/3, angle of mouth towards zygoma, zygoma process, and below the zygoma, that is zygomaticus. And from angle of mouth, a line down and line up, this is depressive angle aureus, and this is elevator. So this is the overall picture of this. Let's start again. कॉटे दे दो ये 1:1 है थोड़ा सा लगना होगा सब 1:1 है 30 ml है क्या 30 गेस So let's start with rhizorius because we have done already. देखिए इधर हेड पकड़ना होगा. So angle of mouth is being pulled from this to tragus, medial 1/3, lateral 2/3. I have to inject here in a way that this is in the plane of muscle, subcutaneous. How much? Unlike eye, this is less forgiving. If you inject little more, the smile will be crooked. So we'll start with 2.5, 2.5 to 5. Generally, I get good response in 2.5. Angle of mouth to zygoma, zygoma. .5. All right. Nasalis is there. थोड़ा सा कि सबको दिख जाए. जरूरत है क्या उसकी? बाद में. All right. Apart from that, we can see that this angle is being pulled, but also lower whole face is moving, right? This is moving, and this is orbicularis oris, right? So you have to give it in this muscle, and the best place to give in the middle. So from the filter, this is philtrum, angle of mouth. In the middle of it, this is upper part of oris on the left side. Lower part of the oris, again middle part on the left side. So this is done. So major muscle moving on the face we have done already. We have done rhizorius, we have done zygomaticus, we have done oris, we have done nasalis. So this is done. One can add platysma, but platysma is not that contracting, it is not that functional. Means mild contraction you don't have to give. No, थोड़ा सा आँख बंद कर लेंगे please. Ready? So this is done. She is not squeezing that much, so I am leaving this, but we can give in the orbital part also. Now we can see the frontalis is also moving. So should we treat that? In fact, we have to see the functional effect, not only what is moving. If we treat the frontalis, then it will become weak. So the effect of closure will be more prominent. What she is doing right now, she has hemifacial spasm. She is using frontalis also to pull it up. And you are giving injection in frontalis, that will become weak and pulling will be difficult. So despite presence of movement, I am not touching frontalis at all. All right. So what other muscle is there which I want to inject? Depressor anguli oris. From angle of mouth to the jawline mandible, a vertical line, middle of this is depressor anguli oris. I want to inject. In some cases they have. If they have, please inject, because what happens in that case, slight change of this, patient will look sad. You do yourself in front of a mirror, do a little bit of this, you will look sad. Do a little bit of, you will feel happy. So, small amount here, means depressor you have released, and patient will look happy. So that's one. Platysma is here. Platysma is a thin sheet of muscle. Very difficult to give platysma because thin sheet of muscle. But in any patient, platysma has two pillars. When you ask yourself to do this, you can feel something here and something here. So when you do this, platysma is not flat. There are two places. It comes in more muscle. That is anterior pillar and posterior pillar. So hold the pillar and give in the pillar. So that's platysma for you. I think face is done. Platysma is done. Mentalis, in some cases, they have more contraction. I'm not giving this patient. And that will look like puckering. When mentalis contracts, it will look like the orange peel. It's puckering something like this. You give in mentalis. Mentalis is the only muscle in the face which is a little thick. So in case of mentalis, you can afford to go a little deeper, but all other is superficial. Any question regarding the face? Yeah, so what I do, what starting amount, 5 into 4, 5, 5, done. All the facial muscle, which expression muscle, don't weaken it because especially in females. So 2.5, 2.5, 2.5. Mentalis is more forgiving, 5. And this platysma, it is a long sheet of muscle, 5 to 10. But these are 2.5, these are 5, 5, 5, 5, 5 to 10. Right? Any question? Good. Yeah. No, what happens when you, so we are at say 50 units there. If I reconstruct in half ml or 100 units there, in 1 ml, that means this is 1 ml. That means if I have to inject 5, I have to inject half of this. Yeah, volume changes. Oh, that's a good question. Yeah, that's a good question. So what happens when, generally for the face, I reconstitute 1:2 we say, that means 50 units and 2 ml. Because suppose somewhere you have to give 2.5 units, it is very difficult when your volume is less. Now your question is, if volume changes, does it matter? It matters, but not to this degree. Suppose the volume is say, for 5 units I have to give 5 ml, that will matter, right? But this much, it doesn't matter. And volume is another principle regarding volume is that when you give for the spastic muscles, make it more volume because you want the injection to spread out. For this, make it less volume because you want it to stay there. Okay, thank you. It acts in about 7 days time. In fact, Befospan, it acts a little faster, 3 to 4 days up to 7 days, and it lasts for up to 3 to 4 months time. And in some cases, 6 months time also. Face done, right? Neck, please bring the neck. Sensation can fool you, right? Suppose somebody has, please watch out. Somebody has torticollis, and what he does, he pushes it up to make the head straight, and you feel that it's shoulder elevation, but it was torticollis, and he's pushing that because of that. So we ask them to do some cognitive load, ginti gino, seedhe chalo, aage piche karo. You have to spend some time before injecting, and it's clear case of torticollis. Better. Beta the chair, better. So torticollis. That means you have to know the muscles. Without knowing the anatomy, you don't go for toxin. In fact, you should know anatomy in a way that when you see your friend also, you're not seeing the neck, you're seeing trapezius, you're seeing sternomastoid. So that will help you, right? So how to know that? There are 54 muscles in neck, and it's impossible to know 54 muscles. So you have to know some major muscles. 4 muscles, you are done. If you know 4 muscles, you are done, number one. Second thing is that when you go to various, workshops, somebody injects somewhere else, somebody injects somewhere else, and it's all confusing. I have seen people that injectors fight on the stage that this is the best way, this is the best way. What you have to know, what is the origin, what is the insertion, and that's it. When you know the origin insertion, then you know, suppose sternomastoid, you inject 1/3 above, 1/3 below, it's a sternomastoid. Some basic principle is there. Not torticollis, right? But before torticollis, don't see him. Look for the muscles, what muscles we should know, and what muscles we should inject. थोड़ा सा इधर हो जाओगे, please. खड़े. So if you know this picture, you know 80% of injection of neck, right? You have seen the picture many times. Picture is, this is sternomastoid, this is posterior triangle, this is clavicle, and behind is trapezius, and in between the 3 muscles are there. So these 4 muscles are important. So one more, sternomastoid, trapezius, clavicle, and 3 muscles. The muscles are splenius capitis, levator scapulae, and scalene. That's it. I will pick up some volunteer. Come. You have pen, right? Marker है ना? चलो खड़े हो जाओ. So this hollow is posterior triangle. He's our consultant, by the way, right? Critical. So from sternum, it goes up laterally sternomastoid. This is trapezius. This is rib, and over here, this is splenius capitis. Below that is levator scapulae. Below that is scalene. Thank you. And how this will help? So in case of, let's know a little bit more of anatomy. Is that okay? 2 minutes more. Sternomastoid is not straight muscle, it is curved muscle. So he is telling left side. That means which sternomastoid is active? Actually right. Because from sternum it has to go out to the back. So when right sternomastoid pulls, it will take the head towards the left side. Clear? No confusion? You can see the sternomastoid also. It's very, you can see that. It is very prominent. So in this torticollis, right sternomastoid will be one of the prime muscle. Why I am saying one of the prime muscle? Sternomastoid is jutting out because there is one silent muscle sitting behind, which is much stronger than sternomastoid, and you don't see from outside. We have to inject that more as compared to sternomastoid. Sternomastoid is a beauty muscle, it's outside, but some muscle is sitting behind. Which muscle is that? एक बार खड़े हो जाओ, पीछे मुड़ जाओ. इधर आओ. So from C4 to T2, from multiple slips, a muscle comes deep inside, below the trapezius, and goes out to be inserted into mastoid process and below that. That muscle is splenius capitis, very strong muscle, very strong muscle. So look at this, something like this. If it will contract, what it will do? What it will do? Ipsilateral, 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 isn't it? Torticollis, one side. So he is telling on the left side, na? Capitis also, because torti also, sorry, retro also. But this splenius left has to do two work. In this case, one is rotation, one is retro. So I won't give the same dose in right splenius. Right splenius is doing only one job, retro. I'll give 50 units. So 80, 50, 50 or 40 will do. 80, 50, 130.
This is the second time it's done. First time I injected right sternomastoid 50 and left splenius cavity 75, right splenius cavity 20.
So you can see this, almost same, 75, 25 and 50. So almost 5 units here and there, doesn't matter. So let's inject that only because he improved, right? So 50 here, which we thought 25 से काम नहीं चलेगा. We have to go higher because sternomastoid is good. Inject कर दो. एक मैं करूँ inject. उसके बाद next one बताना. थोड़ा सा आगे आ जाओ, because थोड़ा trick बता देते हैं उसके बाद. So for sternomastoid, simple. There's no brainer. But don't go from anterior because anterior there is blood vessels, nerve, neurovascular bundle. You are going to hit it. So go from posterior. Second point is that try to be in the middle of the muscle. Why middle? Because lower, middle or upper third. Because lower is very close to pharynx.